Good morning and welcome everyone. I am pleasure to stay here with us with 4 cardiologists and all of us. Now we start this session, this morning session of short-term mechanical support in cardiogenic shock, and we are on time. Let's go to start. I present Manuel, and he's a cardiologist of Gregorio Marañón of hospital in Spain. He's a chief of unit of cardiological clinical unit, and we are all of expert here. We start with the first presentation. Joan Antoni Gómez Hospital. He's working in Bellvitge Hospital. He's an interventional cardiologist with extensive experience in cardiac catheterization, and his presentation in shock in context of KLIP4 acute myocardial infarction, what type of support and when. Yes, I am Fabricios Braga. I am cardiac surgeon in this hospital, and I am pleasure to stay with us. Thank you very much.
Okay, thank you very much. First of all, I want to thank the organization for this kind invitation to talk about the myocardial infarction and shock. So these are my disclosures. And we are talking about a patient with cardiogenic shock. First, the steps that you have to make in a patient with presented with cardiogenic shock is to make analyze the presentation at the examination of this patient. The patient that we presented is a patient that onset chest pain at 9 o'clock in the morning, and he arrived to the emergency unit of our hospital at 10:40. And the physical examination showed a decrease in arterial pressure, 60 to 40, and heart rate 80 per minute. And they presented signs of hyperperfusion with cyanosis and cool legs. So at this moment, we can diagnose the acute coronary syndrome, cardiogenic shock, that represents an 80% of cardiogenic shocks in the vast majority of the literature. And you perform an ECG, and you can detect clearly at the elevation of the anterior leads. So we can diagnose at this moment this STEMI cardiogenic shock that represents 70% of those patients with cardiogenic shock. The first step that we have to do at this moment is to perform a fast echo to rule out mechanical complications like ventricular septal rupture, papillary muscle rupture, or cardiac tamponade. If they are ruled out, you can diagnose the patient with a primary left ventricular dysfunction due to myocardial infarction, and immediately you put on treatment with inotropes and oxygen. The next step is to go fast and immediately to the cath lab. As you can see in the picture, the patient has an acute occlusion of the left main at this moment. So don't panic, and now you have to decide what to do at this moment. Immediate revascularization, immediate support. I think in the differential features of acute myocardial infarction, cardiogenic shock in front of the other classes of cardiogenic shock, is that the patient has an acute situation that leads to thrombotic event and an acute left ventricular dysfunction. And you have any potential reversibility of this situation with reperfusion of this patient. Be careful with the reperfusion injury, but you have another therapy that can help to improve this patient. So the best news is you have two therapeutic options, primary PCI and mechanical cardiac support at this time. But the bad situation is that you have to thought. You have to think about what is better to do first. So let's go to need. I think for this decision, it's very interesting, the SCAI classification of the cardiogenic shock. As you know, SCAI classification classifies the patient in 5 stages, from A to E. And A is the patient is at risk. There's not signs of hypoperfusion or hypotension or tachycardia, but probably this is an example can be a patient with a large myocardial infarction that is in a quite good situation. Stage B is a beginning. The patient is quite signs of hypotension and tachycardia, but there's not hypoperfusion. Stage C is a classical definition of cardiogenic shock. Probably is the situation that was present our patient. There's a hypoperfusion on the legs, and there's hypotension. No, it's not tachycardic, but has hypotension. Stage D is this patient that is in a deteriorating manner. The patient has decreasing the arterial pressure, and stage C is extremis. The best interesting thing is this classification correlates clearly with the prognosis of the patient. Is an increase in mortality on the deeper situation of the cardiogenic shock. And is a parallel with the pathophysiology that occurs in the patient with acute myocardial infarction that develops cardiogenic shock. First manifestation is a decrease in diastolic function, so there's an increase on left ventricular and diastolic pressure. This leads to pulmonary congestion, hypoxemia, and increases the ischemia to the heart. And there's a secondary decrease in systolic function, so there's a decrease in the systolic volume, and this leads to hypotension, decreasing again the coronary perfusion pressure, and leads to increased ischemia and decrease of systemic perfusion, so they lead to the distal organs failure. And if you don't break this circle, probably the patient death. So you have to break this circle and try to put the patient in a better situation. To get the decision, what is the first that we have to do? Probably this SCAI classification is helpful for, in my point of view. So the key point and the cutoff value probably will be the mean aortic pressure if there's less or more than 55 millimeters of mercury. So those patients that are in class A or class B, you can go fast with the reperfusion and hope an increase in cardiac function and better situation for the patient. But if the patient is in a worse situation, probably you go first with the mechanical cardiac support. One of the principal prognostic factors of the good result of any cardiac intervention with an stent implantation is the pressure perfusion of the coronary arteries. If you do not have enough pressure on the coronary arteries, you can perform the better the PCI that you can do, but always you have to thrombose the stent because the hemodynamic situation. So first, in this situation, first support the patient, and after that, make the PCI. What about talking the revascularization with a cardiogenic shock due to an acute myocardial infarction? So the shock trial demonstrated very years ago, in the last century, an improvement in the prognosis with the early revascularization for those patients. But this is a special situation. When you talk about the patient with cardiogenic shock, as you can see on the left, you can see that more than 75% of the times you show multi-vessel disease. On the contrary, that patient without cardiogenic shock. So the question was years ago, what have to do? You have to revascularize all the lesions that presented the patient, or you have to revascularize only the culprit lesion that causes the myocardial infarction at this moment. Luckily, we have the culprit shock trial that was designed to answer this question. And clearly, the study demonstrated that it's better to perform only culprit lesion revascularization. Because if you lose the time on contrast dye and other things, you put the patient in a deleterious situation with increasing renal failure and mortality on those patients. So go first with revascularize only culprit lesion. What about talking about the percutaneous cardiac support that we have in the cath lab or in the hospital? There are several types of cardiac supports. Some of them treated right ventricular support, some of them treated left ventricular support. In an myocardial infarction situation, the vast majority of the cases, we need only left ventricular support. And in this situation, we have VA ECMO, intra-aortic balloon pump, Impella family, and Thoratec PHP, and tandem heart. I think tandem heart is not used anymore in Europe, and is only used in several centers in USA, because there's a complex implantation, because you have to do a transeptal puncture in this setting of acute myocardial infarction, cardiogenic shock. So it's very interesting to know at this moment what is the cardiac and especially the coronary effects that you have these cardiac supports for treating this patient. As you can see, all these devices, ECMO, Impella, and tandem heart, increases cardiac power, but ECMO increases afterload, that is a deleterious situation for the muscle, for the myocardium, and decreases coronary perfusion. Intra-aortic balloon pump and Impella decreases afterload, Impella more deeply than intra-aortic balloon pump, and increases coronary perfusion because Impella injects the aortic flow into the valsalva sinus very close to the coronary ostia. So if you have to decide any of them, I tried, if it is possible, I tried to put the patient on Impella to treat patient with an acute myocardial infarction. One have to put this device. There are not any studies that are designed to answer this question, but we have some registries that detects any data. First, you have an American registry that shows that putting the Impella support before starting PCI, it's beneficial in terms of survival. So this is one registry from the United States. In the bottom, you can see an European registry. Is a single center, 88 patients from Netherlands, and the results are the same. This is a benefit in terms of decreasing mortality to put the Impella before starting PCI. And there is a meta-analysis that shows the same result. So if you have the patient in cardiac shock, so put first the support and then perform PCI. So it's clear and demonstrated that in our mind, it's clear that in a STEMI patient, The door-to-volume time has to be less than 90 minutes. Probably you have to translate that in the cardiogenic shock. Probably you have to put in our mind that door-to-support time, door-to-unload, has to be less than 90 minutes if you can. So the better for the patient is to start the support as early as you can. What about the evidence for this treatment? So there are several devices, and what are the results in this setting? This is a little bit frustrating, but none of these devices has demonstrated any benefit in terms of cardiac survival. Neither intra-aortic balloon pump, tandem heart, nor Impella, nor ECMO in a small study have demonstrated any benefit in terms of mortality. All of them demonstrated that it increased improvement in hemodynamic support, in hemodynamic parameters, but this is not translate to clinical benefit. Why is not translate? There are some reasons for, in my point of view. First, there is a very small number of patients that included, especially for devices. There are more big devices like tandem heart, Impella. There are very small numbers of patients that are included. Second, probably there is a patient device selection bias. Probably we select patients very sick. If you put in the classification of the SCAI classification, the vast majority of patients that are included in that studies probably are in the class E or D. And probably their devices are not enough support to treat those patients. And third, and no less important, is the complications related intrinsically with the device. As you can see in this meta-analysis, we compare cardiac devices like Impella or tandem heart in front of intra-aortic balloon pump. They increased the risk of leg ischemia or bleeding. That is going to be deleterious in the prognosis of the patient. And more important, there is a lot of patients that are included in those trials that has a cardiac arrest, and in a special out-of-hospital cardiac arrest. As you can see, this is a trial that demonstrated clearly that the first cause of mortality of those patients that are admitted in patients with out-of-hospital cardiac arrest is a neurological problem. More than 60% of the patients died from neurological effects. And probably the neurological damage is related to the first attention of the patient and is not related with the device that we put when arrives to the hospital. So it's very difficult, and is a confounding factor to analyze exactly the result of these studies. Nevertheless, there are a lot of studies that are ongoing to demonstrate this benefit of those patients. You can see the list. There's a lot of trials. Always the problem with these trials is the slow recruitment of the patient, that more of them has to be finished before achieving the number of patients that they decide. So probably there is still ongoing the investigation in this setting. So you have no rules. What can make the selection of the device that you put on our patient? So probably you can use again the SCAI classification, and here from patient in stage E and B, if they need some support, probably the intra-aortic balloon pump, due to the safety profile, can be enough for those patients. When the patient be sicker, probably Impella family can be helpful because there's a fast implantation and some benefit, and Impella CP 5 or the last arrival is 5.5. Can be helpful in those patients. Probably 5 and 5.5 have the problem that is a surgical implantation, so it is not so fast to put on the patient. And for patients in the very sick situation, only ECMO VA can be helpful for treating those patients. When you put a patient on this situation, it's very important to know what are the predictive factors that can help us to decide it is enough or not enough. This is a trial that detects the predictive factors for failure of the support for Impella CP of 5.5. And as you can see, the ventilation more than 24 hours, the deep decrease of ventricular function, or the increased data on lactate before starting the procedure or even at 24 hours are predictive factors for failure of the support of Impella. So as you can see on the picture on the right, there are clearly different prognosis for those patients supported by Impella if they need support with mechanical ventilation or not need this support. What about our patient? Our patient was lucky because they arrived at hours that are several interventional cardiologists in the unit, and they can start the procedure two interventional cardiologists that while one patient make the diagnosis, the other put the patient on the support on Impella. So the second diagnostic injection was yet in the patient supported by Impella. We treat the patient with primary PCI, making guiding catheter, wiring the LAD, make a thrombus aspiration, and recovers the left circumflex, that's a very big artery. After a large amount of thrombus removal, the total daughter perfusion time was 55 minutes, so it's on time, and the final result of our PCI was very good, with a quite good distal flow, and the patient recovered the hemodynamics. So, with this data, you can conclude that STEMI patients need to increase coronary flow and decrease myocardial advance, so it has to be taken into account to decide the better treatment. Even there are pharmacological treatment, device selection. SCAI classification for me, it's, in cardiogenic shock, is helpful to classify the patient situation and decide how to start the treatment, first reperfusion or first support. Decide what is the better support device that you could put on my patient. And there are different percutaneous assist devices available nowadays, but none of them have shown any clear benefit on the clinical situation, despite having demonstrated an acute hemodynamic support. So we have no rules, you can decide, and probably the experience of every operator can be taken into account to decide the situation. Thank you very much. This 15 years of experience from the construction of the hospital to the result of today. Okay.
Thank you, John Antonio, for this excellent presentation. We will have the discussion at the end of the three presentations. Our next presentation will be by Dr. Marwit Kanwar. Dr. Kanwar has a large experience managing these patients after the mechanical support device implantation, and she will show us how to take decisions from the practical point of view in these patients. Thank you very much.
Thank you. Good morning, everyone. And I wanted to thank Joe and other organizers for inviting me to your beautiful city. This is my first time attending this particular meeting. Can you hear me? Hello? Sorry, thank you. I thought this is my first time attending this meeting, so I'll tell you a little bit about my program and what I do for all things cardiogenic shock. I come from the city of Pittsburgh, where we have about a 900-bed hospital. That's sort of the mothership, with 7 satellite hospitals feeding patients into that. And we have about a 20-bed CCU, a 20-bed surgical ICU, where we manage all our cardiogenic shock patients. We do about 25 heart transplants a year, about 30 to 35 durable LVADs, and a lot of temporary support devices. I take care of about, of course with my team, about 200 cardiogenic shock patients a year, which we manage with a combination of primarily intra-aortic balloon pump, Impella 5.5, Impella CP, VA ECMO, and a handful of tandem heart cases. We do about 50 to 60 Impella 5.5 cases a year. We don't use 5.0 anymore. About 40 to 60 VA ECMOs every year, and about a dozen tandem hearts, with a lot of, like I said, Impella CP and intra-aortic balloon pump thrown in. I also help, along with Daniel Burkhoff and Naveen Kapoor and others, the Cardiogenic Shock Working Group, which was launched about 3 years ago, which is a large national academic consortium where we have about 25 US centers putting all their cardiogenic shock patients' data into a registry, which is ongoing. We currently have about 4,000 patients of all etiology cardiogenic shock, including about 40% acute MI and about 60% non-AMI cardiogenic shock with all outcomes, from where we are publishing most of our upcoming data. So with that background, I will talk about the temporary cardiogenic shock, and unlike the previous speaker, I'm not going to have a lot of data-driven slides because there is not much to help guide us in decision-making. And if we think the use of temporary machines is controversial in AMI, we don't even have much data in the field of non-AMI cardiogenic shock. So I'm going to tell you how I manage cardiogenic shock in my program, where I run both the temporary and the durable mechanical circulatory support program, as well as the transplant team. So again, as we started by talking, the best practices on what machine to use, when to use it, how to wean it, and when to wean it is controversial. And in the absence of a lot of data driving these decisions, we use individual programs, specific algorithms that we all have come up with. In the last 2-3 years, we've learned that the use of a shock pager or a shock multidisciplinary program is really the one thing that has brought us all into this discussion field, and frankly, probably the main thing that is starting to impact outcomes of these patients. And ideally, the decision to proceed with either implanting or removing a temporary mechanical circulatory device has to be really driven by the need of the patient. And by that, I mean which ventricle is affected, how much it is affected to, why is it in cardiogenic shock, and these decisions are guided by a combination of clinical, hemodynamic, imaging, and other parameters. So there's really not one secret formula or a secret equation that we could say, if you use this, you will know how to escalate or de-escalate. And despite the lack of information guiding us, that really does not deter us from using temporary devices in cardiogenic shock patients. I think in the United States, at my own center, we had an all-time high of using these devices, and especially since the change in our allocation policy in 2018, the use of intra-aortic balloon pump or other temporary devices as a means of getting patients as a status 2 to cardiac transplant has risen dramatically, which has not necessarily been associated with a significant improvement in mortality as much as we would like to think it should. So really, I'm going to end with this slide, but I like to start with this as I'm hoping that over the next 15 minutes or so, we will talk about who is it that the patient, how do we determine which patient should be upgraded to what, and how to wean and how. And really my key take-home point here is for your own institution, because what I may tell you may not be applicable to some of you, is have a method that works for your institution, for your team, because not just coming in and using machines and taking them off without really having a method or a mechanism it will certainly not help improve these outcomes. And it's very, very key to have a multidisciplinary approach to it and to have the what-if scenarios, so to know what your exit strategies are, because these are highly invasive, very expensive, and really very involved machines. So putting them in and taking them out really has to be a team decision with the patient at the center of that decision-making, of course. So let's start with upgrading devices. So as we know, the first key in management of cardiogenic shock, once you've recognized, is learning to uniformly be able to assess the severity of it. And by uniform, I mean in terms of vocabulary, because we used to use terms like early shock or baby shock or advanced shock or my patient's shocky, all sorts of versions of that. And thanks to SCAI, we now have a classification system which again has some of its own issues, but really for the first time a consistent vocabulary. So when I say SCAI E shock, then the person hearing that knows exactly what I'm talking about. The next step, of course, is to determine, is this shock LV, RV, or bi-V predominant? But because just focusing on the LV, which is what we traditionally used to do, we realize that does not necessarily translate into great outcomes, because it is not unoften that LV shock is what brings the patient in, but unrecognized or undertreated RV shock is what ends up causing their mortality. Then we pick up the support options to match those needs. And then, of course, once you've implanted them with a temporary machine, you have to figure out how to take it out, be it as a bridge to recovery, bridge to durable VAD, transplant, etc. So last month, SCAI published an update in their guidelines that was previously, or the consensus conference that was recently mentioned too. And the difference between the triangle that was shown by the previous speaker and here, you will see grades of severity as shown by the changes in the color from blue to red. Now, the vocabulary is consistently the same, so I'm not going to go over that, but going from A to E in terms of increasing severity of shock. And the key difference between the original SCAI 2019 classification and the updated classification is to understand the ongoing continuum of cardiogenic shock. And although the SCAI classification, as it was originally published, was meant to stage patients at the initial time of presentation, they now recognize that the outcome of the patient will be driven by a lot of factors that vary. They may either get better or they may get worse based on the initial presentation that the patients have. So not only is the shock severity, but why they are in shock, how rapidly are they progressing, how they are being managed, etc., all goes into that decision making. So this is our data. So cardiogenic shock work group took what SCAI had published and tried to give it more definitive parameters, because to say things like worsening or improving or deteriorating, again, is hard to translate to a bedside. So is a lactate of 4 going on 5 as bad as 5 going on 4? Is a blood pressure of 90, which we used to traditionally associate with the definition of cardiogenic shock, is 60, how much is that really worse than 90? So as bedside clinicians, we need more parameters than just English vocabulary words telling us it's getting worse or not. So what we took was, we took our patients, nearly 4,000 patients, and assigned specific criteria based on, again, another consensus conference, and using lactate, pH based on ABG, blood pressure, and basically non-invasive, readily available parameters. We try to reclassify these patients into different stages, and then more importantly, describe the temporal progression of cardiogenic shock across these stages and associate that with mortality. So again, how do we decide which machine to use? Whatever it is that you decide, the goal is not to go through a series of escalation process. So understanding the need of the patient, using all the parameters which we just talked about, and matching the therapy early and upfront. At my center, when I took on the shock program about 2.5 years ago, we used to have patients go through a series. So if the patient's coming in the middle of the night, they may get a balloon pump, and in the middle of the day, they may get an Impella 5.5. Depending on who's on call, they may get VA ECMO, or they may get a combination of multiple drugs and Impella CP. So we were really all over the place, but to have a consistent definition of the need of the patient. So I make my fellows, anytime they present a cardiogenic shock patient, is they have to stage the patient. They have to say, is it left ventricular, biventricular, or right ventricular predominant shock, and then what they're going to do, because the machine that you pick shouldn't be just the machine of your comfort zone. Of course, the machine has to be available at your institute, but making sure you match the need of the patient early and upfront, because there's nothing worse that you can do than to have the patients escalate through a series of machines and then de-escalate as well. And really, it's not about, which having a bigger, shinier, or a better toys. It is just learning how to use them and when to use them, and never forgetting the right ventricle in the mix, because really it is sometimes underappreciated of what they do. And my shock mentor, Naveen Kapoor at Tufts in Boston, has this quote that I love to use, is it's really the pumps. If a patient dies on a temporary mechanical circulatory support device, it was not the failure of the pump probably, but the decision to use that pump in that particular patient and when, that led to the impact on mortality. So to just say an RPs don't save lives, or CPs don't save life, or 5.5 save everybody is really an incorrect statement. It's your decision to use that device that matters. Now, we've learned a lot in the first lecture about AMI shock, but understanding that taking data from AMI shock and then trying to prolate it to non-AMI shock is again not going to work. So not all shock is created equal. In fact, more than 50% of cardiogenic shock is caused by non-AMI, and yet we keep trying to extrapolate those findings, hoping that they will fit, and it really does not. So our vocabulary needs to expand from just AMI, non-AMI shock to are we trying to treat hypoperfusion, hypotension, or congestion, or all of them, because that's how you will decide which machine to use, because each machine is going to do a different job. And when to consider device therapy, I don't have a ready formula for that, but what I tell my referring institutes is if you are escalating the dose of your first pressor or inotrope, and you've already sort of reached the higher levels of that, and you're considering addition of a second inotrope or a pressor, that's the time to start thinking about machines, because what you don't want to use is use 4 pressors, max them out, see the lactic acid going up, and then start to trying to implement a machine. So in terms of timing of cardiogenic shock. Which lab parameters to use? Our go-to is pH, which is again readily available, and then serial lactate levels. So not only is the initial lactate level, but the rate of lactate clearance. So if the rule of thumb is if in the first 8 hours of management, you have not managed to lower the lactate below 3, then you are really not perfusing these patients adequately. Now, that's not to say this is highly evidence-based information. This is from the intra-aortic balloon pump a trial, that the 3 number that was derived, but the idea is lactate clearance within hours of initiation of therapy should be the goal as quickly as possible. Because once hemometabolic shock sets in, hemodynamic means the patient's hypotensive, tachycardic, they're still perfusing their organs. Their cardiac output may be low, their cardiac index may be dropping, but their end organ functions, their LFTs, creatinine, urine output, etc., is still preserved. Once that spiral sets in and hemometabolic shock sets in, probably the patient is already in an advanced stage of shock, and if you then try to initiate therapies after all of that has set in, death is almost inevitable. So the idea is early identification of shock is of course key here. And then again, as I was mentioning to my fellows, I always ask the patients, I always ask them on rounds to say, if we chose to use, let's say, a CP or whatever the machine we did, what are we trying to hope the machine will deliver? Are we looking for circulatory support? Are we looking for LV unloading? Are we looking for perfusion of end organs? Because if you can't verbalize that, just saying, I'm going to use an Impella because I can, is really not matching the needs of the patient. So stating, clearly defining what does the patient need so that you can actually use that particular machine if you have at your disposal. Because if you don't use them early on and match the needs of the patients, again, the death is almost inevitable in these patients in this scenario. And then again, this will not be a machine failure, but a decision failure. Now, we have all sorts of devices. Of course, PHP has died out. I haven't updated the figure, but we have a lot of machines at our disposal, both for LV, PIV, and also RV support devices. And understanding the hemodynamics of what each machine does is key, not necessarily to say that every patient needs to have a PV loop performed, but understanding what will an intra-aortic balloon pump. If you try to match a SCI-E patient with an intra-aortic balloon pump, you're not going to get the output you hope to receive. So really what a balloon pump does is improve your cardiac output by lowering wedge pressure to extra support of 1 to 1.5 liters at the most. Whereas an Impella lowers the pulmonary capillary wedge pressure, lowering the preload, induces AO-LV uncoupling, and in doing so improves the multi-organ perfusion by improving cardiac output. The tandem heart, which I understand is not often, we typically use it in aortic stenosis-related cardiogenic shock, will augment your blood pressure, lower your pulmonary capillary wedge pressure, and improve your cardiac output to an extent. Whereas in VA ECMO, really will increase both your preload and afterload, and in shock situations often has to be matched with an LV venting device, but by doing so will improve your multi-organ perfusion to a much higher level. So really our goals of the first 48 hours of temporary support is hemodynamic stability. So every day our shock rounds, we have to say, is the patient hemodynamically stable as defined by a combination of these parameters. The reason why you picked that machine, has that goal been met? Has the patient improved in end organ function? Because if their lactate is still rising, that's not a time to start talking about weaning devices, that's a time to start talking about escalating devices. Or if their lactate was 8 and it stays at 8, then just hoping that we'll be able to wean this device is not going to work. Have we improved end organ perfusion? And in doing so, have we achieved a net negative balance? Because these patients are often on a lot of drips. They get 2, 3, 4 liters in, maybe sometimes fluid, blood products, etc. So even if they have a urine output of 100, 150 an hour, which sounds normally very reassuring, if they're net positive by 2, 3 liters, then they're not going to successfully wean. And then have we corrected other reversible etiologies? Have they been revascularized? Has the valve that was the problem that led them to be in a cardiogenic shock state been addressed, etc., etc. Now, these are parameters that we use at my institution. Again, not necessarily randomized trial data driven, but this is a method we have chosen to use in our institute to wean these devices. Now, there's starting to be a series of publications in this event, because we thought all the effort was really in putting the devices in, but weaning them is a whole art in itself and even less data driven. But again, it's important to have individual protocols at your institute for each device, and hopefully that applies to a broad variety of patients differentiated into AMI and non-AMI shock. And how we use this is, again, in my institution, we rely very heavily on a PAC catheter or Swan catheter, about 99% usage in cardiogenic shock at my institute. And we use a combination of hemodynamic parameters, echocardiogram, of course, clinical parameters to help decide when these patients are ready to wean. So these are the few words that are in the take-home points. Is every day we round on a patient who's on a temporary device, we say, is this patient ready to start weaning? It is something to be done on a daily basis, not just a Monday to Monday as we used to do it earlier. And understanding that each patient may have a different need. So if they're in an AMI situation, they've been revascularized, they may be somebody who can wean quickly. Whereas if somebody is in a post-cardiotomy shock or in a non-ischemic acute and chronic decompensated heart failure, they will not wean quickly, because really you have not reversed the reason why they're in shock, because it is irreversible. Now, the second is the weaning trials themselves. They can be rapid, depending on why the patient is in shock to begin with, or slow, but they have to be intentional and they have to be controlled. Because just coming in the morning and turning the dials down and seeing what the patient's doing over the next 30 seconds and then saying they're ready to wean is again not going to be effective. And make sure that these patients, as you're weaning these devices, they're on therapeutic anticoagulation, because if you just turn their speeds down and they're not anticoagulated, they will end up having a lot of complications from that. And then defining for each patient what a successful wean is, so that you know when that endpoint is reached. So if you can't define it, then you can't really pull it off, is another thing to think about. Now, these are some of the parameters we talked about, looking at their vital signs and organ functions, labs, PAC values, echocardiogram, etc., etc. And then as you're having these discussions, you have to have your plan B. What is your exit strategy? What if you're unable? Ideally, you should be doing that before the machine goes in, is what is the exit strategy for this patient? And then if you pull the machine and the patient crashes, are you going to replace that with the same machine, a different machine, etc., etc.? These are all decisions to be held on your multidisciplinary shock rounds on a day-to-day, or in fact twice-a-day basis if possible. And then being able to, if the patient is on multiple devices, let's say Acapella and or on inotropes, which are you going to wean first? Because the worst sin, as somehow my fellows love to do, is tell me that, oh, this patient was on a P6 support the night before and a milrinone of 0.5, and now they're off of everything. You know, our goal is not instant gratification, is get them off the machine, the bigger machines first, followed by the drips that will follow. Intra-aortic balloon pump, again, typically we can wean it rapidly or slowly. We typically turn it down to 1:2 or 1:3, rarely so at this point, and then wean them as needed using some of these parameters. Aortic pulsatility, so looking at your waveforms, that's really all we talk about ad nauseum on our shock rounds. Is the pulsatility improved? Is the PA diastolic reassuring? Is the aortic diastolic reassuring? Is the PA sat reassuring? Because to pull a machine just because you think you're ready, but the patient may not be, again, is not going to help them. Impella, again, you can wean them over a period, depending on, again, if the patient's been revascularized, you can typically wean them rapidly. But if you are using it for a bridge to recovery or a bridge to a bigger machine, then making sure that you wean them thoughtfully, and not just to say lower is better, or everybody should be left at a certain P level of support using these parameters. And once we have a cardiac index maintaining above 2, we typically wean slowly over a period of time and reassessing. This is not an 8 a.m. discussion to be made necessarily. You have to revisit over and over and over again these patients to make sure, and talking with your surgeons, your interventional cardiologists, etc., to making sure everybody's on the same page. VA ECMO, of course, depending on whether it is vented or it is not, we typically turn them down to 2 to 2.5 liters of support, see their aortic pulsatility, their echocardiogram, and their hemoparameters before we decide to wean all of them. If they have a machine along with that, we typically leave the Impella in so that it can be a bridging therapy once the VA ECMO come off. Again, the goal is not to remove all devices simultaneously, because that is setting that patient up for failure. And then again, remembering to maintain them on therapeutic and anticoagulation. And if they're not met, then you reassess. How are you going to make tomorrow a better, more successful day? Because just hoping that they'll get better is not going to be adequate. Can you diurese them more successfully? Can you optimize them, revascularize them, assess their valves, fix their valves, etc., etc.? And then weaning a tandem, I don't believe you guys use that often, so I'll leave that alone. And then the RV failure devices, of course, they have their own set of parameters using typically RV function, PAPI, and PA-SATs that we often use, and turning them down meaningfully before we pull. And if it's an RV failure from an LV failure issue, you always wean the RV device first, followed by the LV device based on that. And lastly, the do not list is make sure they're adequately anticoagulated, trying to avoid a double negative conundrum, and not to leave them on these therapies longer than needed. We used to do this all the time, is I'll wean this on Monday, even though they're ready on a Saturday, and it's taken a lot of amount of push from our side, the medical folks, to have our invasive colleagues come in on a Saturday and wean these devices. Not start weaning at 7 p.m. because bad things always happen at 3 a.m. Make sure you communicate the goals of the machines, both upgrading and weaning with your team, the patient, their families, not leaving them NPO for extended amounts of time, and then pulling all devices at the same time and hoping that the patient will thrive. So again, my take-home points are early upfront combination of therapies based on the patient's need. Similarly, weaning strategies require equal amount of attention, guided by your clinical, hemodynamic, echocardiographic, and other parameters, and always figure out what your exit strategy is, preferably before you put the machine in, and definitely as you're weaning them, but have a method to it. It may not be most data-driven method, and you may need to revise it every 6 months to a year, but don't not have a method to it, because otherwise the patient's outcomes are not going to improve. Thank you very much.
Margaret, thank you very much for your clear exposition and presentation. And we have the discussion after the last. Fernando Riesgo is a cardiologist from Royal Brompton and Harrowfield Hospital, United Kingdom. He's a consultant cardiologist in heart failure, transplantation, and mechanical circulatory support. His presentation is management of complication and short-term mechanical circulatory support and how to avoid them. Thank you, Fernando.
Thank you very much, and good morning, everybody. This is my first time in this conference, and I have to say I'm really, really impressed with the quality of the program and the presentations, and I would like to thank the organization for inviting me. As Fabrizio said, I work in Harrowfield Hospital. I've been there for 7 years, but you could see my hospital is a lot older than me. That was built in the First World War as a hospital for the Australian and New Zealand troops during the war. And lots have changed within the building, but if you go and see our hospital, the outside looks pretty much the same. I only have one disclosure to share for this presentation, and it's the fact that I'm an advanced heart failure cardiologist, purely clinical, so I don't get involved in the technical aspects of the implantation. So I will talk about the clinical consequences of these complications rather than getting too much into the detail. I would like to see me and my colleagues as team members that can contribute to the good outcome of the patients by not necessarily having to jump on the pitch or get our hands dirty, but I'm sure others see us a little bit like this, passive witness of the hard work of the colleagues. My presentation is now a lot easier, as I was preceded by excellent presentations, and they talk pretty much all about devices, when to do it, how to win it. But just from a simplistic point of view, the most common indications for short-term MCS are cardiogenic shock, usually in the context of acute coronary syndrome, or end-stage heart failure. And we use them as a bridge to a goal, and this goal tends to be either recovery, if at all possible, or a definitive therapy, transplantation, or ventricular assist device. And these devices are very powerful. They come with a lot of advantages. You've seen how good and how powerful they are in improving the circulatory support of the patient, coronary perfusion, ventricular unloading. But obviously, they come also with lots of complications that could jeopardize the success of our patients. And I'm sure all of people around here that have been working in the field for some time sometimes see our patients like these marathon runners that do a titanic effort to suddenly just fall a couple meters before the finish line. And this is particularly frustrating when you think you may have given them the wrong energy drink, or maybe too early, or perhaps too late. The devices I will talk about are already mentioned, will be ECMO, Impella, and Levitronics. And the complications I will cover during the presentation are some of them, and I'm sure I'm missing some, but the time for the presentation is short, and I don't want to bore you too much. I thought that better than talking about the statistics, because things change depending on the units, but depending on the experience, perhaps better to show you some examples of these complications when they occur, and what you can do to prevent them, and what we did in this situation. Probably the first one to talk about are the ones related to the hemocompatibility of the devices. All you know that these devices are well known to cause thrombosis or to be thrombogenic. Reason being is thrombin is constantly generated within the system, and it's sometimes difficult to find the equilibrium between coagulation and anticoagulation processes. If we fail to achieve that, our patients would be on a high risk of bleeding or thrombotic complications. And actually quite difficult to maintain pristine care for these patients for a prolonged period of time. So we will always be on risk for this. How to prevent them? First and foremost, optimal management of the anticoagulation agents. I just saw some of the parameters that are more commonly used, ACT perhaps more in theater, APDT and anti-10A in critical care scenario. Just to comment of our practice, we have moved on from APDT to anti-10A more recently. We've been following that for a couple of years now. Other parameters that are important are fibrinogen, platelet count, TEC, anti-T3, etc. Other important factors to consider is the correction of the coagulopathy, especially within the first few hours of the implantation, and more importantly, if this implant has been surgically. Adequate management of transfusion requirements, very close circuit monitoring, and quite importantly, infection prevention or aggressive treatment, as infection is a quite strong risk factor for thromboembolic and hemorrhagic complications. Despite that, these complications could still occur, and our options at this point are quite limited. If we're dealing with a hemorrhagic complication, obviously we have to at least reduce the anticoagulation treatment and very often reverse it completely, and we'll be expecting a high risk of thrombosis as a consequence. If we are on the opposite side and we're dealing with a thrombotic complication, we could think about thrombolytic agents, but you would argue that those strategies are high risk as well. Circuit change is a common practice. Surgical or percutaneous interventions are usually not that easy, as our patients tend to be not very fit to undergo them, but potentially could be an option as well. On the right side of the slide, you see a few examples of these complications that happen in our unit. Top left, you see a massive intracranial hemorrhage of a patient supported with ECMO. Remember, that was day 5, and from a cardiovascular perspective, he was doing well. But then we found this, and obviously that was the end in terms of our care. We had to withdraw. The one on the top right is a patient supported with an Impella 5.0 for 4 weeks as a bridge to transplant. which he successfully had, and from a cardiovascular perspective, he did very well. He did not require MCS, but when we woke him up, we realized that he had had a perioperative frontal stroke from which he's recovering, and thankfully, his deficit is actually a lot less than what you could imagine with this scan. And on the lower part of the slide, you have 2 patients supported with Levitronics. One of them who had recurrent hemothoraces that dificulted a lot the progression for a more durable device, but in the end, we managed to do so. And on the right, you have somebody who sadly succumbed to quite large retroperitoneal hemorrhage that in size is pretty much the size of a heart, and unfortunately, the patient could not survive it. Other complications with the same category are hemolysis, and this complication is possible in all forms of MCS devices. If we talk about ECMO and Levitronics, it tends to be more associated with the oxygenator. In Impella devices, it's a lot more common in small devices like Impella CP or 2.5, although it's not used that much anymore, and is directly related to malposition of the device and if they're running very high speed. The diagnosis is relatively straightforward. You look for hemolytic markers such as plasma-free hemoglobin, LDH, some units use haptoglobin. Other clinical features of hemolysis are choleric urine or high bilirubin content in the blood test. The consequences are multiple, and I would say tend to be a little bit undermined, although they're quite important clinically. The most obvious one is that our patients become anemic, and that by itself compromises the circulatory support as reduces the oxygen delivery to our tissues. And what we do when we have somebody that is becoming more anemic is to transfuse them, and that comes with other sorts of problems as well. Volume loading, coagulopathy, and very importantly in our field, HLA sensitization. And I can give you a few examples of people that we bridge to transplantation with short-term devices, and unfortunately they become too sensitized to undergo transplant in the end because of the repetitive blood transfusion. So just remember that we have to think about our ultimate goal. Acute renal failure, also quite common in profound hemolysis. Liver failure can occur as well, and the risk of infection increases over time as well. How to manage, how to prevent them, already talked about that. Optimize anticoagulation in terms of device management. Take care about the position of the Impella and reposition if possible, if you have the impression that hemolysis is getting out of hand. Oxygenator change is a possibility as well. The adjustment of the support could be also a possibility in terms of reducing the support if it's not that necessary. Do not run, especially in Impella, at the speed that is not required at that point. And very often the only thing we can do is upgrade to a more advanced device, such as Impella 5.0, Levitronics, or sometimes, although quite rare, if the patient is having profound hemolysis, transplantation, or ventricular assist device. This is another example in our unit, somebody who decompensated quite quickly, underlying DCM with predominant LV dysfunction. His right ventricle was relatively well preserved at that point, but decompensated quickly, and he needed to have an Impella CP put on an emergency basis. And you could see that the angulation of the Impella is not correct, is compromising the function of the mitral valve, and is causing a quite profound hemolysis, as you see by the LDH rise from an initially 2400, which is quite high, to 4500. The patient went into anuric renal failure within 12 hours and had to be put on dialysis or hemofiltration. And as a consequence, his window of opportunity for transplantation disappeared as the renal function didn't recover quickly after we repositioned the Impella. So in the end, we had to choose an alternative option. He received an LVAD, from which he recovered well, and he's in the unit, but we had to deviate from our initial plan. Infections, and sorry for the picture, especially that early in the morning. It's also common. It's common in all forms of treatments in the hospital, and MCS is not going to be an exception. The probability increases over time, especially if the duration of the support is prolonged and the severity of the underlying illness is advanced. There are all sorts of infections associated with this: bloodstream infection, ventilator-associated pneumonia, and infections in relationship with the cannulation or catheter used for the care of our patients. Prevention, I wouldn't go too much into detail. The one thing that I really would push for it is We tend to be very proactive in waking our patients so we can extubate them and minimize the risk of pneumonia. At the same time, promote quick rehab post-implant and chest physiotherapy. And what is quite important as well is to monitor very closely for any forms of indwelling line or cannula infection or septic signs, and escalate our antibiotics very quickly. Here on the right, you have quite nasty picture of ECMO cannula-related infection, but second case is slightly more unique. And this is a patient supported with an Impella, again, for 4 weeks. Initially, it's a bridge to transplant, but it happened during the worst part of the pandemic, and he did not receive an organ in time. Because he was relatively senior, and we thought he would not do well with the Levitronics Vivat, he didn't have probably the resilience to undergo a separate or second MCS device. We opted to give him an LVAD therapy, and he recovered very well, but only a few weeks after discharge, he returned to the hospital with swollen right arm and increased inflammatory markers from not very clear origin. We tried different things, and in the end, because we couldn't find the origin, we did a PET-CT, and it showed an FDG active area at the site of the Impella implantation. And that gave us the hint that that was, we're dealing with endocarditis infection at the site of the implant, and the patient required surgical correction of the subclavian artery and prolonged antibiotics. I can say he's doing well now, thankfully. Error in the circuit, potentially catastrophic complication, occurs quite rarely, but if it does, the consequences could be fatal in most cases. It's related to the accidental air entry into the circuit, and this could either stop the pump or cause severe air embolism. The causes are usually in relationship with either accidental puncture of the inflow cannula, which is exposed to a very negative pressure, and also during atrial cannulation, if the pump is run at high revolutions, can also make the atrial chamber to be under negative pressure. The other kind of potential source of air in the circuit is the suboptimal management of the central venous access, especially if the three-way taps are not closed properly or not capped properly, and most importantly, if they are in close proximity to the venous return cannula. So we have to be very careful with our line management. I couldn't find any picture of it in a hospital, so I used something published in the literature. I think the author will give a talk later, and he demonstrated very nicely how the CVC was very close to the return cannula, and as a consequence, because the line was left open, the patient had quite intense air embolism in the left carotid artery, blocking it completely. What you have to do if that happens in your patient is to act very quickly. You only have a few seconds at most to prevent irreversible damage. And what you would do is you clamp the arterial line to prevent the air embolism, then replace the prick cannula, then aspirate the bubbles from the oxygenator and the air system. And you could do it successfully, but time is quite precious in this scenario. Another complication that is perhaps not that frequent as well, but can complicate the care of your patient is the presence of intracardiac shunt, which could be either related to a pre-existing congenital abnormality that maybe was missed during the assessment pathway, and especially because the hemodynamic situation could change after implanting a biventricular device, or it could be also a consequence of iatrogenic injury due to transeptal approach for previous mitral clips, LA venting, tandem heart in the past, although not used that much anymore, cannulation a bit more rarely. The consequences of intracardiac shunt complicating the MCS support are hemodynamic. It can produce volume overloading, mostly in the left ventricle, because mostly that would be a right to left shunt, and it can cause also systemic desaturation. How to manage that? Well, I forgot to say, first of all, do a proper assessment before you implant the device to know what you're dealing with and be prepared. If that happens despite this, you could try to optimize the biventricular support and maintain as much as possible a good balance in between the interdependence and aim for a kind of neutral net balance in terms of the shunt, although that is quite difficult as the pressures in both chambers will be quite different. Percutaneous closure could be attempted with an unplatzer device, but obviously it's not the most straightforward situation, and I'm sure your interventional cardiologist may not be as happy to do so. Surgical correction could be attempted as well, but if you have to do so, you probably have to think about escalating the support anyway. And escalation is also possible, and sometimes you could think about either a permanent solution like a vato transplant. But transplantation, again, you're dealing with the timing pressure that you cannot decide when to happen. And this is another case of a unit that had a PFO that was inadvertently found after Levitronics, and it was complicating the situation that much, and we could not close it percutaneously. We had to take the patient to theater and put a VAD. Talking about complications more specific to peripheral VA ECMO, I think there are three that are quite good, quite important to mention. First one is limb ischemia. Everybody dealing with peripheral VA ECMO knows about that, and how important this is and how difficult the management of our patients can become if it happens. It's obviously avoidable or potentially avoidable with proper cannulation strategies, and yesterday we're giving a talk about how to cannulate properly, a beautiful talk, and that already covered what I was going to say, but basically ultrasound-guided cannulation with proper cannula selection based on size of the patient, and more importantly, size of the vessel could be a key. We need to maintain the flow through the cyst to minimize the risk of cyst thrombosis, and most centers would choose to use a distal limb perfusion cannula to maintain distal perfusion. An alternative to that is a T-shaped Dacron graft that is used slightly less commonly across the units, but is a possibility as well. But despite using either perfusion cannula or the T-shaped Dacron graft, we need to remain vigilant for the complication, but it can still occur. So we have to be very vigilant for the circuit state, and also maintain a close eye on the distal perfusion with Doppler pedal pulse. And if it happens, usually pharmacological agents would not be enough. You're not going to be able to resolve that in most cases. And also thrombolytic agents come with risk in a patient that is supported with VA ECMO. So usually what you have to do is something either percutaneous or surgical with either thromboembolectomy or vascular repair. Very often, you also need to change the cannula, and in occasions, if the ischemia is profound and comes with compartmental syndrome, you need to also do fasciotomy as well, and that, you would argue, is going to complicate your care quite a lot. A beautiful complication from a physiopathological perspective is the LV distension. My previous speaker has very elegantly demonstrated with PV loops why that happens. In essence, is the problem that the retrograde flow from the arterial cannula into the extending aorta increases the afterload to an already failing left ventricle. And as a consequence, our patients tend to have an increased LVDP that is transmitted retrogradely to the left atria and pulmonary capillaries. Subsequently, patients tend to develop pulmonary edema, which then will compromise the oxygenation of the blood, and eventually the perfusion of the heart, kind of exaggerating or maintaining the downward spiral of cardiogenic shock. At the same time, we're talking about patients that are either ischemic or have poor coronary perfusion. So the gradient through the myocardium is going to be also compromised, as you have low coronary perfusion facing a high LVDP. So the subendocardium is going to be poorly perfused for sure. And usually in this situation, the aortic valve remains closed, so there is a quite high risk of blood stasis and intracavitary clot formation. How to manage or prevent these complications? First of all, if you're using peripheral VA ECMO and you need to maintain this support for a prolonged period of time, just take it for granted that it will probably happen unless the ventricle recovers quite quickly. You could opt for kind of optimize the general measures if the patient doesn't have any clinical consequence by then. By doing so, I mean try to reduce the ECMO flow to the minimum that maintains good perfusion to the organs, but doesn't increase the afterload excessively. Remember that we're talking about heart failure patients, and by definition, in 95% of the cases, they're overloaded. So don't forget to use diuretics and control the volume status. Optimize the inotropic support, trying to promote contractility and ejection of the heart, and be very vigilant with usually recommended to use a PA catheter and regular echocardiographic evaluation. However, if the patient is already developing pulmonary edema, you should act quickly. And the options are percutaneous or surgical to the ventricle. From a simple point of view, how you choose between one or the other, I would say probably in relationship with what is your expectation for the heart to do in the next few days. If you think there is high recovery potential, like in patients with myocarditis, perhaps maintaining a percutaneous system would be interesting. So you could use left atrial venting with transeptal approach, or more recently, in most centers would use Impella. If you think the chances of recovery are quite low or perhaps non-existent, maybe maintaining a percutaneous system is not going to be the best. And you could think about either escalation to a durable device, but more commonly the use of a more midterm device like Levitronics Vivat. Talking about the role of Impella, already mentioned, the combination of Impella and ECMO is usually called ECPella. The pressure volume curves also elegantly demonstrate that Impella is quite powerful in reducing the LVDP, and by doing so, it would counterpart all these negative features that I said in the previous slides, reducing the left atrial pressure, minimizing the risk of pulmonary edema, promoting forward flow, and reducing the chances of intraventricular clot. Here we have a case in the department as well, a very young patient who had a first presentation of quite severe heart failure in the context of dilated cardiomyopathy.
Fernando, you need to finish.
Okay. Sorry. Who was treated with Impella, and how the Impella resolved the pulmonary edema. I'm sorry, I will go very quickly then. Harlequin syndrome happens when the heart recovers, the lungs doesn't recover that, and causing a mixing point to be in the coronary arteries or the supraortic trunks. How to resolve that? Optimizing ventilatory adjustments, increasing ECMO flows, and reducing inotropes to temporize the situation, but we need to think about changing the cannulation to central, VAV, or VV ECMO, depending on the heart recovery. And very quickly, just I'll go through this. The images are probably more interesting. Impella thrombosis can occur. Rarely you can see with echo, but in this case, we saw very beautiful thrombus there. At that point, the patient was not ready to be upgraded to a Levitronics Vivat, so we thought about putting him on VA ECMO and removing the Impella. To protect the supraortic trunks, we used a Sentinel device, and it was successful. The patient was supported with VA ECMO for 2 days, and eventually Levitronics Vivat. And finally, I'm sorry because, strangely, valvular damage can also occur with Impella. Apologize because it should be the other way around. It normally happens more in the aortic valve than in the mitral valve. It could be due to malcoaptation or direct injury of the valve. If it's direct irreversible injury of the valve, it's difficult to treat after, and the valve should be usually changed. Finishing the presentation, my conclusions are, if we want to avoid the complications in MCS, try to avoid the need of MCS, and how to do so, recognize the precardiogenic shock promptly and start the other maneuvers that perhaps would stabilize the patient. If you need to use MCS, do it quickly, do it nicely, and choose the adequate device, but remain vigilant because complications will occur one way or the other. Timing of escalation or weaning to a definitive therapy, or weaning, as I said, do not do it too early, but definitely do not do it too late, and multidisciplinary approach is key. And as Thomas Jefferson said, probably not thinking about MCS, let the eye of vigilance never be closed. Thank you very much, and sorry for...
I don't know if we have time for 5 minutes discussion. Just please keep the questions and answers short, please. I have a question for John Antoni. As you've shown us right now, in most patients with acute shock due to acute myocardial infarction, we prefer to support first and then to revascularize. But in cases as the one you show us with such a large amount of acute ischemia, I'm not so sure. In your case, there was no problem because you had both interventional cardiologists available. But if you only have one, in that case, with such a large amount of acute ischemia, would you also go first for support, or would you try to open first the left main? Thank you.
I think it depends extremely of the hemodynamic situation of the patient. It is closer to have a mean pressure like 50 to 60. You can starting putting a guiding catheter and crossing with a wire to open and have some flow. But if you don't have any enough pressure, you can open the artery, but there is not the perfusion, so it's not enough to recover this myocardium, and probably the perfusion injury can be deleterious for the patient. So I think in this situation, I think it's better to support the patient first, and after that, we open the artery and treat the artery. For this reason, you have to be the teams has to be trained to be very fast to put the patient on the support. So it has to balance the time to need to put the patient on the support and the time to go faster to open the artery. So.
Yeah, great session. Thanks so much. I have a question for the whole panel, which I think is the most important question in the field in practical relevance. Can you identify the patient in whom balloon pumps work? And I'm saying this on the background that we still use a lot of balloon pumps. Is there a hemodynamic profile that you identify and you say it's going to work? And is mitral regurgitation, the presence thereof, an indicator of response?
I think in the acute myocardial infarction situation, you have very few data to decide. Probably you only have the hemodynamic situation of the patient. Probably you have an echo to detect if there's another problems. But probably at this time you can only have the data from the hemodynamics of the patient. Sometimes it's better to do not have the analytics of the patient because we are faster from the results of the lab. No? So probably at this time, I think the only data that you have to decide is the hemodynamic situation of the patient, and you have to think about what is the relationship of this situation with the other problems with the patient.
Can I do a very quick follow-up question to this? Our approach is, because the balloon pump is so much better with regard to side effects, hemocompatibility, if the patient's in the lab and there's time, I ask the interventionist to put a balloon pump, and if it augments very nicely, leave it. If not, swap it. Is that reasonable or cost-effective?
I think, again, if the patient is presenting in non-ischemic failure, he talked about the AMI situation. I love intra-aortic balloon pump in patients with, I love patients with in non-ischemic heart failure. If they're presenting, I can't keep to manage this, but if they're presenting in acute decompensated heart failure from cardiogenic shock in a non-AMI situation, a balloon pump may not be enough. But if they're acute and chronic, these are patients with functional MRs, long-standing dilated cardiomyopathies, sometimes but intra-aortic balloon pump actually just does enough trick to get them to a more durable support. Not the primary support, but in AMI situation, again, we use intra-aortic balloon pump fairly heavily still.
Yeah,
probably one thing that I want to remark that probably in the cath lab you make the decision that was the first device that we select to treat the patient at this moment, but it is not finished the history. Probably it is possible that 30 minutes after the primary PCI, 1 hour after that, they change the situation and they need an escalation of another device. So probably you have to, in the acute phase of the myocardial infarction, you have to decide quickly the first device that you have to need. And probably for this decide, it's the device that can implant faster, and probably the better way to improve coronary perfusion in the setting of primary PCI. After that, probably you have to close surveillance of the patient to decide if there's enough or they need to move on another device. Okay.
In our case, we no longer use intra-aortic balloon pumps in non-ischemic patients. But in patients with acute ischemia, I think one thing that is clear is that balloon pumps improve coronary perfusion. So I think they still have a role, and as you said, from the point of view of cost, the difference is huge.
And I think it's also important to know how far you are from a kind of an optimal hemodynamic state, how much circulatory support deficit you're dealing with, to see whether a balloon pump could potentially overcome that. And I was going to ask a question to the panel then is, would you consider putting a PA catheter in the lab to see where you are and see whether a balloon pump is potentially effective? Because if you're kind of dealing with a very, very low cardiac output, probably balloon pump won't be enough. So in your practice, do you sometimes use a PA catheter? I try to convince my interventional cardiologists that don't like it very much, but I don't know if that happens in your practice.
Yes, absolutely. I've almost forgotten without them. Sorry. Yes, so the answer is we rely very heavily on PAC catheters with the idea that no patient should leave the cath lab still on inadequate support. You know, the first machine is what you've used. But prior, if they're in shock, of course, not all STEMIs need that. But once they move to the CCU, we should never be bringing them back 6 hours later for more and more machines, because now we are realizing it was not enough. So every patient gets a PAC catheter in shock prior to leaving the cath lab, and if they present in the CCU, then we just do bedside swans.
So I have to say that it's impressive to see the differences between Europe and the US here. We in the US, and maybe because of the new allocation system that we have, we got back to balloon pump big time. Yes, we all agree that acute myocardial infarction, complicated cardiogenic shock, we don't use it. But in heart failure, decompensated heart failure on the spectrum of shock, we all use it probably as the predominant device. We use a PA catheter in all the patients. So you said you don't want to ask. We, the heart failure doctor, puts them in. And as Manrich just said, there is not cardiogenic shock management without a PA catheter. So I think a lot of it is related to how comfortable you are. And like digoxin was once the most popular medication, it went down. Now again it's popular, it's going down. The same thing is balloon pump. Balloon pump, I have to say that the current experience that the American site will have due to the new allocation system, it's gained a lot of popularity.
And can I ask, like, does it give you any priority in the transplant? Because in the UK, it doesn't, balloon pump or not, is routine.
Yes,
So,
balloon pump give you status, balloon pump and hemodynamic parameter give you a status 2 that is equivalent to Impella. ECMO is status 1, balloon pump status 2 together with Impella. LVAD, durable LVAD, status 3 and 4.
In the system, the balloon pump will save your life without increasing your cardiac output, you know, just because you have it.
Dr. Costello wants to ask a question, please.
Just a fast question. Regarding the Impella, we also see a lot of hemolysis with the Impella, and especially with the ECPella. I mean, it's massive. And we get kidney failure, as you just mentioned. So I'm happy to see that we all see the same complications. We also get thrombosis of the Impella. So in my view, and we're always being told that the next generation device will get rid, you know, it's always like, no, CP, once you get the 5.0, great. We got the 5.0 and we still get these complications. What about the 5.5? Is that it? Or, and what do you think about, we just have the cannula for the tandem heart, which is approved in Spain right now, so we could use tandem heart. In what patients would you use tandem heart? In the acute phase compared to Impella, or to vent, for example, ECMO?
So 5.5 is less bad. That's what all I'd say is it's more easier to manipulate than a 5.0 because the angle of the pigtail and to the subclavian approach is more direct. But that doesn't mean it requires less manipulation. The biggest advantage, of course, of auxiliary devices is you can ambulate these patients, which is huge advantage as compared to femoral devices. CP is a hemolysis machine. I mean, I've never seen a CP without one yet. But then we don't use CPs in cardiogenic shock unless it's a STEMI, which is high-risk PCI being done. So we upgrade or change it out to 5.5s. We do see much less hemolysis with 5.5, but it's not negligible. It needs repositioning often, despite our best attempts. We use tandems in aortic stenosis-related cardiogenic shocks not unoften, but maybe 10 to 12 a year. I'm not saying we're using that very often. And then the newest kid on the block, the LAVA ECMO approach, which is supposed to be a little bit better, again, transeptal approach to decongest both LV and RV simultaneously, is being considered. We've done about 3 or 4 of those. It's again, we're trying to patch repair, but hemolysis is still predominant.
But Joe, I have to say, our experience with the 5 and 5.5, and lately it's mostly 5.5, is pretty good. We have patients that on 5.5 easily stay on the 5.5 for 4 weeks, 6 weeks, waiting for transplant. We don't see hemolysis with them. As Manrit said, we do a lot of mobilization with those patients. So, and I do think there is a learning curve to the implantation technique and how you position the cannula. And by far, it's the difference in the CP. I have to say the CP was sometimes with, sometimes without. Again, I thought that also there is a learning curve here and how you fixate in it, the situation. But the 5.5 is definitely different. As you know, in the United States right now, the EFS of the Impella DBD is starting. So this is a new type. This is Impella that you can go home with. So this is the Impella that's supposed to start to take transvalvular LVAD into the chronic management at home. So I believe we'll have some more information. But the reason that you can do now the DBD is because the data on the 5 and the 5.5 in relate to hemolysis was pretty stable, that it's not, because you're not sending a home patient that you need to check LDH every day.
Yeah.
And Joe, we've done about, I think, 120 5.5 so far. We are yet to remove one for hemolysis. We've adjusted a bunch of them, but not had to pull it just for that reason, which is an improvement.
And one last question regarding the approach you showed us was based mainly on hemodynamic parameters and lab parameters. What about clinical parameters? But because at least in my case, most of these patients have an advanced age, they are quite frequently octogenarians, and if you search for the evidence in those patients, all the registers and studies have a mean age that is like 50 or something like that. So how do you use these clinical parameters and particularly age in the decision-making in these patients?
For sure. And, where I practice, we are the second oldest county in the U.S., so my patients' average age at presentation is 69. So that cannot be underemphasized. My topic was machine, so I went with those. But, physical exam, cold extremities, and signs of hypoperfusion and congestion on physical exam, the Forrester classification is still key. Urine output is our big, of course, hemodynamics in terms of vital signs are key. And then urine output, and then very non-invasive things I would use are pH of the patient at the time of presentation and lactate. A combination of those are actually sometimes enough. Now, we use PAC heavily because that's our protocol, but we are actually starting our first US multi-center trial of PAC versus no PAC catheter, just using other parameters, echo, physical exam, urine output, lactate, and pH to guide therapies, because we've almost swung the pendulum on the other side where we don't know how to think without a PAC at this point. But our 7 referring hospitals with my own institute, none of them do PACs. So we are the only one. But my thought is if you're using a temporary machine, then having a PAC catheter is helpful. But that's, we live in an ivory tower where we can afford to have 100% PAC rate. But physical exam, urine output, mental status, of course, vital signs cannot be replaced by any catheter.
Question from the audience? Okay, we start the clinical case in cardiogenic shock. The first case is myocarditis, no ischemic cardiomyopathy. Elena Garcia, Hospital de Belviche Hospital, and cardiologist expert in cardiogenic shock unit.
Good morning. Thank you very much for the presentation. And as mentioned, I will present a case report in cardiogenic shock. This is a 26 years old Armenian female with medical history of recent polyarthralgia treated with low-dose prednisone that presented to a peripheral hospital with 24-hour history of chest pain, rapid worsening dyspnea, nausea, and syncope. Physical exam showed VP of 70-30 millimeters of mercury, heart rate of 120 BPM, and severe hypoxemia and lactic acidosis. An echocardiography revealed cardiac tamponade with severe left ventricular dysfunction. Because the pandemic was beginning, an nasopharyngeal swab was performed. So here you can see the first AKG with diffuse acetyl elevation and low voltages, and this is the first X-ray. Despite drainage of the pericardial effusion and vasoactive treatment, the patient remained in cardiogenic shock, so she was transferred to our hospital. We repeated an echocardiography that confirms severe ventricular dysfunction with no pericardial effusion. Blood tests also reveal very high troponin levels for a very young person. So what should we do first? We perform a coronary angiography.
Primera pregunta.
I think we must implant an ECMO right now. Maybe we can perform an endomyocardial biopsy, or do you think we have to carry out all of them? So we have...
So now we should have, here we go. So what you have to do is with your phone you scan, escaneáis el QR y entonces ahí podéis votar. Y si no, entráis en slido.com y ponéis el número y votáis. Esto será para todos los casos. ¿Veis? Ya estáis votando. Ya hay dos. Estáis votando. Damos 30 segundos para votar. We'll give 30 seconds to vote, and then we can discuss the results.
Okay, it's fine. So most people answer that we should carry out all of them, and we will see what happens with our patient. With the suspicion of myocarditis, we perform an endomyocardial biopsy, and coronary angiography showed normal arteries. We decided to implant veno-arterial ECMO and an intra-aortic balloon pump that finally was placed in cardiac arrest because of electromechanical dissociation. That night, the PCR for SARS-CoV-2 was positive, but in the endomyocardial biopsy, the PCR for SARS-CoV-2 was negative. But we could see some interstitial T lymphocytes and some lymphocytes also in the wall of an arteriolar. So hydroxychloroquine, tocilizumab, and high-dose methylprednisolone was started. And hemodynamic improvement of the patient allowed us to norepinephrine withdrawal. But she presented worsening respiratory failure, so that was because of pulmonary congestion, but also because of acute respiratory distress syndrome due to COVID-19 pneumonia. All this, associated with persistent severe biventricular dysfunction, led us to change support to biventricular CentriMac with an oxygenation membrane. During surgery, we take an epicardial biopsy. Postoperative course was complicated with acute kidney injury, several infections, and anoxic encephalopathy. The epicardial biopsy showed more evident endothelitis with moderate macrophage interstitial infiltrate, and there was sparse T lymphocytes also in this biopsy. Ultrastructural change were sarcomeric abnormalities, Z-disc irregularities, and areas of myofibrillar loss. Here, we didn't identify viral particles, but the PCR of SARS-CoV-2 was positive. So left ventricular function started recovering 2 weeks after CentriMac implantation, and the right ventricle recovered 1 week later. Both continued recovering, but we have to delay the CentriMac explantation because of persistence of respiratory failure. Finally, the explantation was 25th of April, after 20 days of CentriMac support. We can perform another epicardial biopsy during surgery, and this biopsy showed similar findings, but here there was very significant interstitial fibrosis. Here you can see biventricular functional recovery 20 hours after the removal of the system. So hemodynamic stability was followed by renal and respiratory improvements, so mechanical ventilation was withdrawn, and we performed a cardiac resonance, a magnetic resonance in June that showed just mild left ventricular dysfunction with diffuse myocardial edema, no fibrosis, but it was a pericardial inflammation that was persistent. Finally, the patient was discharged to a rehabilitation center with CPC 223, and a thorax CT revealed persistent areas of consolidation in both upper lobes and extensive bilateral ground glass infiltrates without clear signs of established pulmonary fibrosis. This is the last echocardiography, November 21. And here you can see a left ventricular ejection fraction of 48%, but with normal right ventricular function. And here you can see our patient in the last outpatient control. So to conclude, we have presented a case report of fulminant myopericarditis by SARS-CoV-2 that was followed by acute respiratory distress syndrome that required mechanical circulatory support, first with ECMO, that was followed by biventricular CentriMac. And compared with other case reports that are similar in publications, we performed surgical epicardial biopsy, and this achieves more bigger samples. We have shown histopathological evolution that was characterized by endothelitis, macrophage interstitial infiltrate, and eventually myocyte necrosis and fibrosis. So we have seen how mechanical circulatory support and anti-inflammatory treatment in this case was useful. So that's all, and thank you very much for your attention.
I have a couple questions. Of course, this is a new vocabulary for us, COVID myocarditis, in the last 2 years. Prior to that, we used to think of fulminant myocarditis with ventricular tachycardia, cardiogenic shock presentation as one of the most fulminant courses. Did this patient have a lot of arrhythmia issues? I'm just curious.
Sorry? Did this patient?
Ventricular tachycardia, was that a part of the
No.
Okay.
The patient didn't have ventricular tachycardia, and the first rhythm abnormality was electromechanical dissociation.
And then at the time of discharge, did you place her on any guideline-directed medical therapy and steroids, or?
Well, neurohormonal treatment, because the patient had mild left ventricular dysfunction, and also the patient was treating with low dose of prednisone because of his polyarthralgia, so we maintained this treatment.
And Mandarin, I have a question. Yes, you have to do something different in this case, similar case, no? What do you think about?
No, I think this was excellent management. I was initially thinking if the biventricular need has improved, we would have transitioned them to VAV ECMO, but I think Centrimax were adequately used. Obviously, this requires a surgical approach, but clearly it fit the patient well.
What do you think about the timing of ECMO? You have to...
I thought the first slide was interesting because 2 of the choices were diagnostic and 1 was therapeutic. You said all of the above. I was surprised at the rapidity with which we would have started with ECMO, absolutely, and then talk about endomyocardial biopsy. But again, you have to support the patient while you figure. I would have probably treated him with steroids, assuming that this is going to be a myocarditis, and then gotten a biopsy when a little bit more stable. But again, this is COVID, and we don't see that much VT with it. So I think this was fantastic.
Thank you very much.
Thank you.
Yeah, amazing, really amazing case, and I think perfect management. I have one comment. I like the way you showed the evolution, you called it evolution, of the histological findings. We biopsied about 10 patients with similar scenarios in April, not in April, around this time, March, April 2020, because we wanted to show this is the pattern of COVID myocarditis, and our finding was all over the place. And so maybe I'm now rethinking, maybe we biopsied at different stages, but I don't think so. I think really there is no clear histopathology for COVID myocarditis. That's a very big lesson, I think. And then I think you never answered the question that you asked. Did you put the patient on ECMO and then do coronary angiography, or did you do coronary angiography biopsy? You never answered the question, so I'm still waiting.
So, I think
the patient arrives to the cath lab, because I stay in the cath lab without ECMO. I think it's preferable to support the patient first, because probably this is not an myocardial infarction. This the clinical case it seems to be a myocarditis, so it's not a reversible situation at this moment. So probably it's we prefer to put on support first.
I want to emphasize something that Uli said about the point of myocarditis. Again, when we speak about COVID-19, not all the patients are myocarditis. There is a lot of myocardial injury. Actually, only 5% of the myocardial injury is myocarditis. When we took 100 patients that die, we took the autopsy of the heart, and we look, and we did actually a PCR from the heart muscle to look for DNA of the virus. We could identify it only in 8% of the cases. The majority of the myocardial injury is microemboli in the coronary that you will not capture in a coronary angiogram, but you will capture in that extent. So I have to say that today we know so much more than we knew in April 2020. And there is no doubt that the MCS therapy for this case was amazing. But today we have so many different medications that we probably would have used. The amazing case, congratulations.
Thank you very much.
Elena, I have one question. This patient was previously on steroid therapy. So it's
on steroid, sorry?
with corticoids. She was receiving
low dose.
I think that's interesting because usually you would think that would like protect her from myocarditis, and in this case it was the opposite.
Yes.
So have you? I don't know if there are similar cases that have been published. Is it a risk factor for myocarditis? Because I wouldn't expect to see myocarditis in a patient that is receiving previously this kind of treatment.
Yes, it's right, but it was with very low dose. So we put a high dose methylprednisolone, 500 milligrams for 3 days. So this is a high dose that maybe can improve the left ventricular function, and not so the low dose that the patient was receiving.
Just one quick comment from our experience. We have seen similar things. We were biopsying patients initially. We stopped doing it. But obviously, probably you didn't know that it was COVID by the time you biopsied. But if we would have known, probably would not have biopsied the patient, because it probably doesn't change the management. We will be doing the same. And rarely you see that the inflammation is the main driver. The only comment I would say is, would you consider maintaining the percutaneous approach rather than moving into Levitronics bypass? Because I don't remember what was the time frame of recovery. Do you think you could have kept the patient on ECMO with an impeller? That would be enough. In our experience, we have done it because we expected the heart to recover in a relatively short period of time, and obviously not all, but some of them did well. So that might be also a possibility, thinking about not having to move to a central approach and keeping him on ECMO plus impeller. Obviously, you had to do something to unload the ventricle, but maybe that approach would have been also possible.
Yes, I was quite agree with you, because this is my question. Do you have the experience with Impella 5 or Impella 5.5 associated with a Protect Duo cannula in such a situation? Because in our experience in Paris, we use it in such situation, and I think it's very efficient and also very interesting to avoid to open the chest. It's a less invasive approach, and it provides an efficient biventricular support during 1 month, 3 or 4 weeks, and it could be relevant, I think.
Yes.
We go to the next case, Francisco Galvan, cardiologist, and we speak about arrhythmic storm in cardiogenic shock.
Good morning to everybody. I present this case of a 50-year-old man that was affected with hypertension, obesity, and type 2 diabetes mellitus with a poor control. And he had a family history of sudden death and ischemic cardiopathy at young age. So he had suffered from exertional angina for months until he had chest pain at rest and was attended by emergent medical services, and an ECG was done. This is the ECG. So you can see on the screen ST elevation myocardial infarction with a right bundle branch block. At that point, he had a normal blood pressure, but he had rails on the physical exploration, and at that point, he was transferred to the cath lab. So this is the angiography. As you can see, there was an acute, really critical stenosis of the left anterior descending artery, and it was treated by a drug-electing stent with a really nice result. Ischemic time was really short, of less than 2 hours. And we could see also lesions in the other territories. As you can see on the left, the obtuse marginal was occluded, and it was a chronic occlusion. And on the right, you can see the right coronary artery also occluded. But at that point, they were not revascularized. So the clinical course in the critical care unit was characterized by an acute kidney injury. The left ventricular ejection fraction was really depressed of 20%. He had pulmonary congestion, and at this point, we implanted a catheter, a pulmonary catheter, just to guide the treatment. So the pressures were really high. The pulmonary capillary wedge pressure was 28, and the central venous pressure was 21, and a low cardiac index was detected too. At that point, we initiated high-dose furosemide, also dobutamine and nitroprusside, with a really good diuretic response and the creatinine clearance. The pulmonary congestion also improved, and we could discontinue the dobutamine and lower the furosemide dose. But at day 9, we saw this ventricular arrhythmia, as you can see on the screen. He had no previous chest pain. The potassium levels in the blood was normal, and he had a really mild hypocalcemia. We had to do a defibrillation with good result, and we started amiodarone and calcium supplementation. Despite this, in the next 6 hours, he had several polymorphic ventricular tachycardia degenerating into ventricular fibrillation. And it happened despite amiodarone, magnesium, and sedation. And at that point, potassium and calcium levels were in normal range. We also saw sinus tachycardia and elevation of lactate, showing the starting cardiogenic shock that the patient had. So I ask the audience this question: what therapeutic approach would you have taken at that time? Number 1, to transfer the patient to cath lab for urgent coronary angiography, because I believe that myocardial ischemia is the origin of arrhythmias. Number 2, intra-aortic balloon pump implantation, because the patient is deteriorating and I want to support hemodynamics. Number 3, intensification of sedation and orotracheal intubation, because this is intended to reduce the burden of arrhythmia. Or number 4, peripheral VA ECMO implantation, because the patient has resistant and persistent ventricular arrhythmias despite defibrillation and antiarrhythmic drugs. He also has severe ventricular dysfunction and signs of shock.
So while people are answering this, after the initial PCI, did the EKG improve and the chest pain go away? Because
yeah, he had no chest pain. The ECG improved. The ST was isodiphasic, and the arrhythmia happened with no really triggers, obvious triggers, just occurred. So we moved on. And what we did was to increase sedation and got prepared for intra-aortic balloon pump implantation that occurred in a ward. But the electric storm came to the case, so he had a rapidly recurrent polymorphic ventricular tachycardia that passed to a refractory ventricular fibrillation. Sorry for that. And we started at advanced CPR. At 10 minutes with no ROSC, we activated the ECMO protocol in CPR. So time to circulation was 28 minutes. The maximum lactate levels was 8 and minimum pH 7.1. Those are the size of the cannulas we implanted, venous cannula of 25 French and arterial cannula of 17 French. After that, we implanted a distal perfusion cannula. And in the first 24 hours after ECMO implantation, he had some arrhythmic instability. He had recurrent polymorphic ventricular tachycardia with non-prolonged QTC, and he had no response to some antiarrhythmic drugs, amiodarone and lidocaine. So right ventricle transvenous overdriving pacing was initiated as well as quinidine. And with that, he had rhythm stability. However, he had a significant left ventricular ejection fraction depression, and we didn't obtain a really favorable ECMO winning attempts. So at day 13, we thought that more physiological atrioventricular conduction could be beneficial for the patient. So we implanted a coronary sinus catheter for atrial pacing. And with, with that, hemodynamic rhythm stability was obtained. At day 17, from admission, and 8th from ECMO implantation, with the use of intra-aortic balloon pump and dobutamine, as well as quinidine and overdriving atrial pacing, we could do the weaning from ECMO. As the main complications of the case of the admission, he had a left ventricular thrombus with no embolism, a vascular complication that requires surgical repair, and also severe myopathy with 30 days of mechanical ventilation and a tracheostomy. We completed the study during admission, and we could see viability of lateral and inferior walls of left ventricle. And we did a successful PCI on the two territories of the obtuse marginal and the right coronary artery. To conclude, at 6 months after discharge, he's in NIHA class 2. He has a nice adherence to treatment for the 4 drugs related with good prognosis in heart failure with reduced ejection fraction. He has an ICD implanted, and he has a left ventricular ejection fraction of 44%. So this is the case. Thank you very much.
I think it was an excellent presentation, and obviously the result is very good. I guess my only comment would be, knowing that he had polymorphic VTs that could have been in the context of ischemia, among other factors, once you had the patient established on ECMO, would you have considered to take him to the lab and see whether you could treat something and try to perhaps stop this arrhythmic storm? In the end, you did it, and that's something that was treatable. So do you think could have been also a possibility to do it while on ECMO? And whether you think that could either complicate things or improve things after? That's my only thing I would probably have done, but the result is very good.
Yeah, thank you for the question. We thought about doing revascularization of those territories while being on ECMO. But we knew that those were chronic total occlusions. We didn't see ST elevation or depression on ECG. He had no chest pain before what happened, and after from 12 to 24 hours of instability, we could reach that stability, and then we stopped, and we did what we did, as you could say. Yeah, but it could be an option for the patient to treat those arteries while being on ECMO.
I wanted to ask about the ICD. It's always a difficult decision in these patients because probably all the arrhythmias were related with ischemia. So once you solve the ischemia and you expect a recovery of the ventricular function, sometimes you can wait and just decide not to use the ICD. We also have these valves, I don't know if you have them available, that you can use during the first month or something. What do you think about the ICD decision in this case?
Yeah, the ICD implantation was done during the admission. As you could see on the second angiography, the lead of the ICD was there. And it was a multidisciplinary discussion. And he also had a confounding factor, this patient. In the resonance, we could see also some signs of non-compacted myocardiopathy. So he had the ischemic part and also probably some other things. So finally, as we could see that it was a extended infarction in the echocardiogram, and he had very severe arrhythmias. We had the discussion, the multidisciplinary discussion, and implanted the ICD.
Question from the audience.
Yeah, thank you for the excellent case, impressive as the previous one. I wonder if in this young patient, diabetic with 3-vessel disease, did you plan at the beginning, after opening the culprit artery, to revascularize the other vessels, either with percutaneously or surgically? May that have changed the outcome of the patient?
We really don't know. It could be the case. We thought that this arrhythmia happened with no ischemic triggering.
Yeah, but in diabetic chest pain is not a good sign of recurrent. And the patient had evident viability, as we learned after all the... So I don't know, because
I think this is a patient that we cannot classify as a cardiogenic shock during the myocardial infarction, because the pressure is normal or quite normal and goes well with the primary PCI. But he has some signs that they are not well, because they are in KLIP class 2 to 3, and the anatomy is a more dangerous anatomy, is a more sicker anatomy that you can find. This is an acute occlusion of LAD and chronic occlusion of marginal and right coronary artery.
Right.
Probably is the cases that it's not clear that we can support this patient, but probably he needs an intra-aortic balloon pump. He's in class A to B on the SCAI classification, and probably you can support this patient for the first days, because after that we put the treatment on furosemide. You can change the electrolytes and can precipitate also the arrhythmic storm. So I don't know. I agree with you that we have to revascularize the patient before discharging this patient, because this is a very sick patient. And even if they're not present the arrhythmic storm. Okay.
One last quick question, because we need to move on.
I would like to congratulate you for your excellent presentation, an excellent case. But I have a question. Don't you think that it was better to do pacing before to put an ECMO?
Well, sometimes right ventricular pacing could deteriorate the hemodynamics too. And we were on really PCR, CPR, yeah. And we have this protocol here in this hospital. So when a patient has some clinical characteristics and the characteristics of CPR, and after 10 minutes we just start with this protocol. And we did it. He had ventricular fibrillation with not respondent to the treatment, to all the CPR, and the ECMO therapy at that point was the only thing that we could use.
Okay, thank you very much. So we need to move on. The next case will be presented by Dr. Oriol Alegre. It's a case of acute MI with left main occlusion. So I'm waiting to see what you did first in this case. Thank you.
Hello, good morning, and thank you for the invitation. So I will start the case. We have a 57-year-old man who is a former smoker and who has high blood pressure, dyslipidemia, gastroesophageal reflux disease, and benign prostatic hyperplasia, and who is under treatment with enalapril, simvastatin, and omeprazole. The patient goes to the primary care center at 10 a.m. with a history of chest pain of 1 hour of evolution, and an EKG is performed where we can see an acute anterior transmural ischemia, and in that moment the patient receives loading doses of aspirin, ticagrelor, and unfractionated heparin, and he is transferred to Beibice Hospital in order to perform primary angioplasty at 12 approx. He arrived at 11:12. He arrived at 12 here in a regular clinical situation, in a pre-shock state with blood pressure 90/60 and tachycardia 120 beats per minute. And also the patient has pulmonary edema with low oxygen saturation. So the angiography, the coronary angiography starts. The right side is okay. In the left side, we have an occlusion of the proximal LAD with a large amount of thrombus. The angioplasty starts with thromboaspiration and tirofiban, and in that moment, we have a slow flow phenomenon, and also we can see distal disease. This causes hypotension and the need to start dobutamine and norepinephrine. And finally, an Impella CP is implanted via right femoral artery. So the pre-shock state in that moment turns into a stabilized cardiogenic shock. The angioplasty continues, a dilatation of the artery is performed, and finally, a large drug-eluting stent is placed in the proximal and mid LAD. With a regular result, the final flow is TIMI2. So in that moment, the patient is admitted in the intensive cardiac care unit. The initial evolution in the first hours, the patient goes better. The norepinephrine is stopped, and we can start nitroprusside. We have 3.2 liters with the Impella. The patient presents some short episodes of VTs that are successfully treated with procainamide. And also the patient is under support with high-flow nasal cannula and moderate Lasix or furosemide dose. Here we have the Impella screen and the chest X-ray. And in the echo, we see mild dilatation of the left ventricle with a very severe dysfunction, and no involvement or mild involvement of the right ventricle. Normal valves, no pericardial effusion, and no mechanical complications related to the acute MI. The lab test is pretty okay. We have only high elevation of troponin levels, mild elevation of the lactate, and some hepatic cytolysis. But in the fourth day, we have problems. There is need to restart the norepinephrine infusion in order to achieve a correct mean blood pressure. The patient is under moderate support with high-flow nasal cannula and diuretic treatment. And at that point, we have a problem of hemolysis that is evident in the lab test. And this obligates us to reduce the Impella support. Also, we have a problem of infection. In the blood culture, there is an isolation of staph epidermidis methicillin sensitive. Daptomycin is started. And unfortunately, in the winning test, we have not a good recuperation of the heart with 2 liters or less with the Impella. The patient needs more dobutamine and more norepinephrine. The mean blood pressure goes down. The left ventricular ejection fraction is very low. And we have another time non-sustained VTs. And in the Swan catheter, we have high pulmonary artery pressure, high pulmonary wedge pressure, although the right ventricle is acceptable. So in the summary of the situation is a bad reperfusion, situation intermax 3-2, and complications related to the Impella with hemolysis and catheter versus device-related infection. And in that moment, heart transplant study was ongoing. So now we have the question, what to do now? Impeller removal and dobutamine norepinephrine escalation, or intra-aortic balloon pump placement, or impeller 5.0 placement via axillary access, or left ventricular CentriMag placement, or left ventricular and right ventricular CentriMag placement. So let's wait some seconds. There's some problem with...
We don't see the results.
It's possible to return to presentation? Don't worry. Torniamo alla presentazione.
Show results? No? Oh, now. Okay.
Okay. So let's return to the presentation.
CentriMag win, no?
So yes, what was done was option 4, impeller CP removal and left ventricle CentriMag placement, bridge to decision. But and the ticagrelor, the ticagrelor was cleaned using hemoadsorption with Cytosorb. Here we have an image of the patient and the CentriMag recently implanted. And the initial evolution, we have that in the first hours, problem of residual hemolysis and relative hypovolemia and cavitation that was partially solved with liquids and polytransfusion. Because in the lab test we have low hemoglobin levels and low platelets, although there was not important bleeding. After that, the patient goes better, we can restart nitroprusside, and he was under moderate support with mechanical ventilation. He has also an anuric acute kidney injury, stage 3, and needed to start continuous venovenous hemodiafiltration. In the echo, no changes, aortic valve was closed, and there was no patent foramenovalia. And finally, a problem of heparin-induced thrombocytopenia was diagnosed, so the heparin infusion was stopped and argatroban was started. But in the 6 days, we have more problems in the form of an hypoxemic respiratory failure and hypotension. The patient needed another time high-dose norepinephrine and also terlipressin, and he was supported with maximal oxygen with the mechanical ventilator. And in the ventilator, we see elevation of plateau driving pressure and lung compliance reduced. The lab test showed severe hypoxemia and also an elevation of the lactate acid. And another time in the echo, no important changes, a mild dilatation and dysfunction of the right ventricle, but not important. And in the Swan-Ganz catheter, the pulmonary wedge pressure and central venous pressure were normal or only mild elevated. And also there was a severe systemic vascular resistance index very low. So in that time, in that moment, ARDS and vasoplesic syndrome is suspected, with maybe some involvement of the right ventricle, and all these strategies were applied: protective ventilation, neuromuscular blockade, inhaled nitric oxide, and finally an artificial lung was placed in the circuit of the CentriMag. Also, the antibiotic therapy was escalated with meropenem, and with all these things, there was an important hemodynamic improvement. Here we have the imaging with the chest X-ray and the thorax scan Also, we can see in the thoracic scan pleural effusion, and a pleural drainage was in fact placed in the left side, and also a bronchoscopy was performed, seeing mucopurulent secretions, isolating Stenotrophomola maltophilia, and the antibiotics were changed to clotrimazole and nebulize colistin. But after that, in the 7th days, we have another time more problems. In the form of new onset of hemodynamic instability. The mean blood pressure was low, a new onset of atrial fibrillation, and another time escalating in the doses of dobutamine and norepinephrine. The patient was with, at that time, moderate support, respiratory support with mechanical ventilation and the artificial lung, and due to the instability situation, the dialysis was temporarily stopped. In the lab test, we have lactic acidosis and a decrease in the oxygen venous saturation and hepatic cytolysis. And finally, in the echo, we see left ventricular collapse with a severe impairment of the right ventricle function, and in the Swan-Ganz catheter, low pulmonary wedge pressure and high central venous pressure, and a severe impairment of all other right ventricle parameters. So in that moment, an evident right ventricular failure was there, and the patient need dobutamine, norepinephrine, and also epinephrine, liquids, and finally, a right ventricular Centrimac was placed using a Protect Duo cannula. Here we have the imaging of the chest X-ray with the Protect Duo cannula. And to conclude the case, further evolution in summary, now we have the patient with the biventricular Centrimac, and the evolution was better. In day 9, the artificial lung was removed. In day 13, the right ventricular Centrimac was also removed. The right ventricle parameters were acceptable at that time. In day 19, the oxynitric was removed, and another time the nitro proceed was started. And in day 21, extubation was achieved. And now the patient is waiting for more improvement in order to decide urgent heart transplant or left ventricular assist device. And this is the case, and thank you.
We have questions from the audience, please. Could you? Very interesting case that finally went well, at least till now.
We'll see.
Yeah, it's another really great case with Centrimac support. I'm curious about, you already showed the case, what people are doing in the audience also. We really do not place only left-sided support anymore. We really go always for, no matter what, almost no matter what the RV looks like, for bi-V support, because this scenario is so unpredictable, and we just want to get the situation under control. So I was for a long time at Columbia. This approach had been established. Then I moved, now 7 years to go to Montefiore, and we had a lot of academic discussion about why only the left-sided device is needed until 2 patients failed. And now it's always a priori BiVAD, so I'm curious what people are doing.
Uli, as you know, we, sorry, my voice a little bit hoarse today. We move away for Centrimac BiVAD to KVAD. So KVAD is actually give you biventricular support. You have an inflow cannula in the LV. You have another inflow cannula actually on the venous system, and you push the blood fluorescent oxygenator into back into the aortic system. By doing so, we don't have to go so aggressive with biventricular support. It's just minimal surgery. I think Guillaume may give some more insight into it because as a surgeon, but seriously, the challenge with BiVAD is the surgical technique. And if you can limit the surgical technique, that's something that you can benefit. So yes, sometimes we will still use full-blown BiVAD. 90% of the cases now will be only what we call KVAD, that as I describe it, give you ECMO and biventricular support. Guillaume?
It's a, it's a difficult question because I'm not sure that we do every time the same thing in such a situation. For sure, we can discuss a biventricular approach in this situation, but personally, now what we try to do in La Pitié in Paris is to use a full percutaneous approach with a Protect Duo cannula for the right support and Impella 5. Because like that, you keep the chest free for LVAD implantation or another thing. You keep, you win some time, in fact, for another approach more aggressive. Personally, I think that B-Centri-Mag is something, we do it, but it's something which is very aggressive, and we have a lot of complication, infectious complication, bleeding. And after, you are, in fact, at the end of what you can do for the patient. Because sometimes, because of this complication, after it's not possible to go to heart transplantation easily, or to go to an LVAD, or to go to... So we prefer to use first percutaneous approach, and after, if it's necessary, it's possible to go to the next step with a more aggressive strategy.
I was going to comment the same as Dr. Leverton, because in essence, the reason that you change the approach is because of a complication, rather than at this particular time, maybe the cardiac output was not enough. And hemolysis happens always in CPs. It's like a machine that does hemolysis, this does. But it doesn't happen so often in Impella 5.0. So maybe at that point, a different option would have been to switch to Impella 5.0. You thought you could have bridged the patient to a definitive therapy within a relatively short period of time. Because I guess by then, he was not in such a profound shock. He was suffering from the consequences of hemolysis and renal failure, which can also happen in Impella 5.0, but it rarely happens to this degree. If the patient has, and also because you demonstrated quite elegantly that the right ventricular parameters at that point were quite good. CVP to wedge ratio, all these were very favorable to univentricular support. If he got biventricular support, by all means, that would have been the case, but that could have been also a possibility as well.
So your last slide was waiting urgent VAD or ECMO decision. I'm sorry, VAD or transplant, durable. Because if you go with a durable VAD, the RV is going to struggle again, most likely. I'm wondering if this patient gets a durable LVAD, would you preemptively do an RVAD, LVAD coming out of the OR? Just because you've already demonstrated that the RV is bad to begin with. I mean, transplant, obviously, it's taken out of the equation. Okay. So do you guys do BiVADs for durable LVAD, temporary RVAD, for somebody like him coming out of the OR?
The last comment?
I want to make a comment on the initial strategy of this patient, no? Because there is a complication, this is a non-reflow phenomenon that I think quite be expected, because this is a patient with a, not for the antithrombotic therapy that you put on ticagrelor and tirofiban, but there is a patient with a complicated hemodynamic situation, so it can occur the non-reflow phenomenon. Probably in this setting, I say, always I say that the interventional cardiologist is an animal that is prepared to open the arteries. And sometimes you need to stop 2 minutes and think about the patient that you have. So probably, I mean, if it is not my case, but I will prefer to put first the Impella, and after that, you can cross the occlusion with a wire and to wait for the definitive treatment that is more thrombotic to have a good support, good hemodynamic support.
Thank you very much. We go to the last case. Dr. Eva Oliver is intensivist in postoperative cardiac surgery. And the title of his case is Post-Heart Transplant Cardiogenic Shock.
Good morning. First of all, I would like to thank my colleagues from cardiology and cardiac surgery department for the invitation. I'm going to talk about a case of cardiogenic shock after heart transplantation. In fact, it's a primary graft dysfunction case. And the patient is a 64 years old man. He was a heavy smoker as the only known cardiovascular risk factor, that he suffered a cardiac arrest and he's transferred to another hospital. There, a PCI is performed and a stent is placed in a proximal anterior descending coronary artery. But despite of a good result, he stays in cardiogenic shock, and he developed multi-organ dysfunction. That's the reason he's transferred to our hospital to evaluate advanced therapies. When he arrived, an intra-aortic balloon pump is placed, but despite of this, he persists in cardiogenic shock with a cardiac ultrasound that revealed a left ventricle ejection fraction of 25% and with extensive anterior akinesia. He persists in Intermax 3, so they implant an Impella CP, and finally a HeartMate 3 bridge to decision. He arrived at our hospital in November 2019, and he is discharged to home in February 2020. While he is at home, tests for transplantation were performed. All were positive, so he's included in the waiting list in October 2020. He was a B group, a blood B group, and at that moment he was 94 kilos and 1.76 meters. He was transplanted on 24th of February in 2021. The donor was a brain death donor, a 37-year-old man, group B, 70 kilos, 1.75 meters, without cardiovascular risk factors. He had been in the hospital during 3 months due to several complications of a cerebral abscess surgery. And finally, the cause of the death is edema. He was in another hospital, 70 kilometers away from our hospital, and at the moment of the brain death diagnosis, he was supported with noradrenaline, 0.6 micrograms kilo-minute. The predicted heart mass ratio was 1.03, and the cold ischemia time was 214 minutes. The cardiopulmonary bypass time to 128 minutes, and the aortic cross clamp 76 minutes. It was a bicaval orthotopic heart transplantation, and during the surgery, multiple adhesions throughout the pericardial cavity was seen. Due to the inflammatory reaction generated by the HeartMate 3 and the rotor, it was very difficult to release the adhesions, and it was no clot formation and heavy bleeding. He needed to be transfused with 3 grams of fibrinogen, 4 units of fresh frozen plasma, 2 units of platelets, and 2-pack red blood cells. When the aortic cross clamp was released, a complete auriculoventricular blockade was seen. So the heart was to be stimulated with a DDD pacemaker, and he was supported during the CPB with noradrenaline, 0.4 micrograms kilo-minute. At the moment of the weaning of the CPB, there's a need to increase the butamine from 6 to 20 micrograms kilo-minute, and isoprenaline from 0.05 to 0.4 micrograms kilo-minute without achieving a mean arterial pressure above 60 millimeters of mercury. The surgeons saw biventricular failure, especially right ventricle dilation. So now I have a question. What would you have done at this point? One, go back to CPB and give some more time to check if the hemodynamics condition of the patient improves. 2, increase dose of inotropes and vasoactive drugs transferred to the ICU, and if the situation doesn't improve in 6-12 hours, proceed to ECMO implantation right now, or increase dose of inotropes and vasoactive drugs initiate nitric oxide, and transfer to the ICU. Okay, we implant a veno-arterial ECMO, a peripheral veno-arterial ECMO, okay, and the patient leaves the operating room with the ECMO flow at 4.445 liters per minute, in DDD rhythm at 100 beats per minute, and with the butamine 10 micrograms per kilo per minute, noradrenaline 0.25, and isoprenaline 0.4 micrograms kilo minute. When he arrived at the ICU, we first saw a severe metabolic acidosis with lactate levels of 9 and 10, and the first we thought that he had mesenteric ischemia that we ruled out by a CT. He developed also an acute kidney injury AKIN3 with the need of continuous renal replacement therapies and an obstructive shock with cardiac tamponade and with the need of a second surgery in what the surgeon saw bleeding and multiple clots in the bed of the heart May3. The next days, there's a progressive hemodynamic stability. We could decrease inotropes. The ECMO functioned quite well with a flow of 4 liters per minute. We couldn't start anticoagulation therapy because of the high risk of bleeding. Curiously, he never developed respiratory failure, but he had a persistent acute renal failure with continuous renal replacement therapies. On the day 5 after the transplantation, he was very stable, hemodynamically stable. The noradrenaline was withdrawn 24 hours before. We could decrease the ECMO flow progressively. He persists with the complete blockade, but he maintained a mean arterial pressure above 70 with a central venous pressure of 13 and venous oxygen saturation above 70. So we perform a ECMO weaning test, echo-guided. First, with these parameters, we saw non-delayed left ventricular with hyperdynamic systolic function with a VTI of 10 centimeters. The valves were okay and they opened well. The right ventricle was slightly delayed with a slightly depressed global contractility, especially the radial contractility of the more basal segments. We decreased the ECMO flow until 1.5 liters per minute. He suffered a mild hypotension, but always a mean arterial pressure above 65 millimeters of mercury and a central venous pressure of 14. And no significant dilations of the right cavities were seen, unchanged right ventricle systolic function, and no significant tricuspid regurgitation. The left ventricle maintains an unchanged systolic function, and the VTI increases to 15-16 centimeters. We consider the test favorable for weaning, and the next day the ECMO is removed. After the removal of the ECMO, the patient developed a mild right ventricular dysfunction that we could manage with inotropes and nitric oxide. He also developed an acute cellular rejection grade 2R and a ventilator-associated pneumonia and a pneumothorax. But finally, he could be discharged from the ICU 1 month later. And that's the case. I didn't write it in my slides, but he is alive and he has a normal, he lives a normal life.
Thank you very much, Eva. Sorry we have delay, so we have only 2 questions for this case. Would you like to comment, Sandra?
So I have a quick question. So at my center, when we do a VAD to transplant, we typically leave the chest open for the first few hours and prefer to use central VA ECMO if bi-V dysfunction is seen in the OR. So this patient had peripheral VA ECMO. I'm assuming the chest was closed. I'm just curious, how do others practice? Because we love leaving, I mean, nobody loves having a post-transplantation on ECMO. What I meant is, if you have to have it, we do it centrally if possible. I'm curious how the others
Well, maybe
do
a
that.
surgeon can explain that better than me.
Yeah, I am a surgeon in my dreams, so I'm going to explain it. No, I think this actually is, I just want to say, I know, very brief, 30 seconds. All the presentations from this institution, exceptionally sophisticated, so just congratulations to the whole team here. I think this was textbook management. I think to do central ECMO, we used to do this a long time ago, and I think absent discussion of surgeons with ICU in cardiologists about the long-term consequence, the risk of infection in that setting is very high. This was absolutely the way to go, to put peripheral and close the chest, presumably very quickly in the OR.
Just last question. Eva, great case, really great case. And I agree with Uli, by the way, we don't do centralized ECMO, peripheral ECMO, keep the chest closed if we have those cases. But what was dramatically changed, the rate of ECMO, LVAD to transplant, primary graft dysfunction, is the utilization of Sharper pack. Do you have Sharper pack in Spain or in UK or in France? And no?
What's that? Explain.
Oh, okay. So right now, when we go and harvest the heart, we actually put the heart in ice in a solution. Okay. That's what we used to do. We stopped that. So actually, if there is, unless it's really in the same hospital, and we transfer her heart, we use a system that is very meticulous, keep the temperature at the same time, all the time. It's a digital system. By doing so, actually, if you demonstrate the temperature in the ice is changing over time, and the heart became, and Guillaume or the other surgeon here can say the heart became very stiff. When you do LVAD to transplant, the anticipation that you will have some adhesion and the explant will be harder. That's the reason you know that you're going to be in 214-minute time. If you do the Sharper pack, it's dramatically reduce your PGD. So in the official study that was presented last year in ISHLT, it was a reduction from 9% to 2%. We already use a Sharper pack in close to 70 transplants in a row, and we didn't have any PGD, so I don't know if it's 70 is enough number. But this is how it is. So we completely stop LVAD to transplant with regular ice. Not to get into the trouble.
I know.
But you save it.
That's a good point, but we don't have it.
We do have it in the UK. We haven't used it yet, but we do, and it's very reassuring what you're saying. We should read it.
Thank you very much for your comment. We don't have any time to speak, and we go to the presentation. Thank you very much, all of you.
Perdón, nos sentamos un momentito que tenemos la inauguración y enseguida os dejamos ir al café, ¿vale?
¿Quieres?
Buen día. Buen día, buenos días. Welcome to Barcelona. Welcome to Belviche University Hospital. Bienvenidos al 9º curso de asistencia circulatoria mecánica. Desde la dirección del hospital les damos la bienvenida. Confiamos en que serán 2 jornadas, la de ayer y hoy, muy interesantes para todos ustedes y para nosotros también. Y después de 2 años complicados que llevamos, es una satisfacción poder volver a retomar un poco la normalidad y volver a hacer estos cursos presenciales y compartir experiencias entre todos. Me acompañan en la mesa el doctor Comín, jefe de servicio de cardiología, yo, responsable de insuficiencia cardíaca, y el doctor Albert Miralles, jefe de servicio de cirugía cardíaca. Les paso la palabra al doctor Miralles.
Buen día, buenos días. Bienvenidos al 9º curso de asistencia circulatoria mecánica. Welcome again. This is a course that had been done for almost the last 20 years. And this is because of the interest and the Dr. Castells, who is one of our mentors, and who passed away this year, and this is I want to pay a tribute to him for his interest to create this course that has been a success for all these years. The last year was 2 years ago, was the last meeting, and we had just the chance to do it before the close down because of the pandemic. No? When we were organizing this meeting this year, we had a lot of concerns and a lot of doubts about how to do it. And finally, we decided to do it as a presential meeting. And we think it's a good idea. And of course, we have also the things going better with the pandemic. And finally, I expect the course is going to be good for everybody. I want to thank especially all the speakers coming from different places of the world in Spain. And because in these periods of uncertainty, they have been quite interested and very always at our side. No? I want also to ask to thank all the assistants for to be here with us, the hospital, the organizers, and of course the industry because of their support. I wish you have a good meeting and also a good stay here in Catalonia and in Barcelona. Thank you and welcome.
Well, benvinguts, bienvenidos, welcome. I'll try to be short because I'm aware you are waiting for the coffee we're going to have right now. So I just wanted to add a few things about what just being commented. I think this is a classical. I would say this course today is a classical. It's not just because we come along here and learn, because it's an opportunity to have the option for networking. I think networking and multidisciplinary cross-team collaboration is one of the key success of the implementation of innovations in heart failure and advanced heart failure support. And I think this is an example. All these different type of professionals, from nurses to cardiologists, intensivists, surgeons, cooperating for having good success in patients that actually otherwise wouldn't have an opportunity to go back to their life. So I want to thank you very much for coming along. I think it's a great opportunity for you to share your knowledge and also because you all that you come along to this course also teach us how to do things better. So thanks very much for coming.
Bueno, yo simplemente cerrar para que podamos ir al café y a las 11 quedamos. Sabéis que por el tema COVID no hay café, no nos dejan hacer café aquí fuera como hacemos habitualmente. Os recomiendo ir a la cafetería y luego simplemente para la comida sí que iremos a la Hesperia y hoy sí que hemos intentado, ¿no? Ayer tuvimos un problema porque no había suficientes comidas porque vinisteis más gente a los talleres de los que inicialmente estabais apuntados, entonces hoy sí que creo que tendremos para todos, o sea que no habrá problema. Así que thank you very much for all the speakers that come from abroad and I hope we can all learn a lot from this meeting. Thank you.
Portàtil, si us plau.
Me, Dr. Marisa Crespo, who is a well-known cardiologist, is specialist dedicated in heart failure, heart transplantation, and also in mechanical support. He has participated actively in the task force for the last guidelines of the EACS for LVAD implantations, and I am very glad to be here with you. And if you want, you can begin with the presentations, the first cases.
Thank you very much, Albert. Thank you all, and I had to congratulate the co-organizers for this excellent meeting and for having invited me. So I am very pleased to invite Dr. Victoria Delgado, now well-known cardiologist, expert in imaging, now is working in Hospital Universitario Germán Trias y Pujol, and her talk is on the assessment of the right ventricle in patients who are candidates for long-term ventricular assist devices.
Well, thank you very much, Marisa, for the kind invitation, and also to Joe.
And you had to ask if the echocardiogram alone is enough.
Thank you. Thank you very much, Marisa, for this kind introduction, and to Joe, very good friend, for having invited me to participate in this meeting. I didn't know if it would be in English or in Spanish or in Catalan, so there are some mix of languages. So why is important to assess the right ventricular function in heart failure patients who may be candidate for LVADs, particularly for those who are at a destination therapy? Because if right ventricular failure happens after LVAD implantation, then it's increased with a perioperative mortality, which is quite high, 43%, is associated with worse survival to and after heart transplant, if we are implanting an LVAD as a bridge to transplant, is associated with increased transfusion requirements and failure of restoration of end organ function. So it's really important to assess the right ventricular function. In terms of how often it happens, in terms of incidence, it's around 9%, but it depends very much on which are the patients that form the registry or the trial that are being included. Because sometimes in some series, there are patients with an ejection fraction of the right ventricle which is less than 50%, and they are already planned to be treated with an LVAD. It's also depending on the definition of right ventricular failure. Sometimes the definition includes the implantation of an LVAD or not, and it's also different or variable depending on if it happens acutely or if it happens at late follow-up. And how does it happen? Is this image, for example, quite extreme of right ventricular failure? When there is a right ventricular failure and further dilatation, there will be a reduced preload of the left ventricle. In addition, the LVAD is sucking or is unloading the left ventricle, which facilitates a leftward deviation of the septum, which can even completely collapse the left ventricular cavity and the cannula of the LVAD, leading to a reduced flow and important morbidity. This is the typical example that we can have. In terms of how do we assess right ventricular function, so I just come from another workshop on devices in heart failure and how do we assess cardiac function, and I could hear that actually we should be not using ejection fraction, and we should be using a multi-parametric approach. Good news for the right ventricle, if we use echo, there are several parameters that you can use, and most of the times not always coincide, which is quite challenging. If we continue using echo, other parameters that have come is three-dimensional echocardiography, and for the right ventricle is particularly important because it has a very specific geometry. And right now, many centers have an equipment with three-dimensional echocardiography, and we should be trained and be more familiar to acquire those data and provide those values. Other parameters that we can use as well is, for example, strain imaging, which measures the shortening directly of the myocardium, but similarly to the right ventricular ejection fraction is somehow dependent on the loading conditions. We, of course, can use CMR. CMR is considered the reference standard for assessment of volumes, and particularly for the right ventricle. But we don't have to forget that many patients who would be candidate for an LVAD may have other devices that lead to significant artifacts of the image that will not allow us to measure the function of the right ventricle. Here are the different parameters that we use on assessment of right ventricular function. And I want to remember, right ventricular function assessment is key, because if we use the figure that Jan Topilsky used to have with 3 concentric cycles, where we put in the center the LVAD, and surrounding the LVAD the left ventricle, and surrounding the left ventricle the right ventricle, you can expand the concentric circles of the LVAD to the level of the left ventricle and become one circle, but they will never become the right ventricle. If it does that, then we are in failure. So the right ventricle is key to support the LVAD and the left ventricle. With echocardiography, the different dimensions try to highlight the specific geometry of the right ventricle with a sort of banana shape. And here you have the different dimensions that indicate which is abnormal. And in terms of systolic function, you have the tricuspid annular plane systolic excursion, which is considered abnormal when it's below 1.6 centimeters. We can also use the tissue Doppler velocity of the myocardium, which will be less than 10 centimeters per second. We can use myocardial performance index, or the TEI index, and the fractional area change. Probably in many centers, we use fractional area change because it's 2-dimensional and because they are not that familiar acquiring 3D echocardiography. But you have to be aware of how you cut the image. This 4-chamber view can be very different if we are going more posteriorly, where we have a fractional area change of 20%, or if we go more anteriorly, where we will have a fractional area change of 40%. In the middle will be around 60%. So you can see that there is a significant variability in the measurement, and we need to be aware of these geometrical assumptions before we give the value in the report. TAPSE is probably the easiest way to measure, and the recommendations include that parameter as a method to be used routinely because it's simple, it's quite reproducible, and is associated with outcomes. And the other parameters that many of us use is also integrate the hemodynamics with the presence of tricuspid regurgitation and its severity, as well as the gradient that is measured through the regurgitation, the tricuspid regurgitation, and if the pressure is high enough, we assume that that ventricle is capable to generate that pressure, and therefore the function should be good. But it's not always the case. Other parameters that we need to integrate is the dimensions of the right atrium, the dimensions of the inferior vena cava and its collapsibility, which give us an idea as well of the loading conditions of the patient. And I have to remind you that all these measurements should be performed with the patient in the most euvolemic conditions or even dry in order to assess properly the function. One of the parameters that tries to incorporate the hemodynamics with the dimensions is the load adaptation index that Tandel proposed in one of his articles of his series. And this one tries to incorporate the velocity time integral of the tricuspid regurgitation and the dimension of the right ventricle and the area. This parameter, which is not currently included in the recommendations of echocardiography to assess the function of the right ventricle, was quite good and quite accurate to identify the patients who would have right ventricular failure at follow-up. This is the series that I was speaking to you about. There were 200 patients. There were patients also with a right ventricular ejection fraction of 50%, so you can expect that these patients are going to have higher risk of presenting right heart failure, which was 9.5%. And this load adaptation index, when it was less than 14, had a sensitivity and a specificity quite good to predict right ventricular failure. This was the other parameter that I was mentioned, the pulse wave tissue Doppler, where we measure the systolic velocity, and if it's less than 10, is associated with poor outcome and indicating poor right ventricular systolic function, and also in the series of Dandel had a rather acceptable sensitivity and specificity to predict right ventricular failure. In this case, the cutoff value was somewhat lower than 10, probably because there were some patients already with right ventricular dysfunction. And the most named now parameter that we use in clinical practice, or that they try to implement in clinical practice, is a global longitudinal strain, quite used, for example, for heart failure to assess the left ventricular systolic function, but also on the right ventricle, it can give us the assessment of the shortening, the active shortening of the myocardium in the lateral wall. For this, for example, the series of Cleveland Clinic, including 117 patients, and 40% of them having right ventricular failure, they could show that a value of global longitudinal strain below 9.6 had a rather modest sensitivity and specificity to predict right ventricular failure. This is a very low value, because the normal value of right ventricular longitudinal strain it would be around 23%. So these were patients with very poor systolic function. And it had an area under the curve much higher than using the Michigan score, or the Michigan score with a subjective right ventricular function. Now, the question was, shall I use only echocardiography? I think not. This is an invasive procedure, and it's a device that we hope, if we are selecting these patients for a destination therapy, that is going to last long and is going to give to the patient a good quality of life for a long time period. And therefore, we need to also incorporate the hemodynamic measures. And for that, I think that right heart catheterization is also an important parameter to take into consideration. Here, there are the various parameters that indicate the risk of right ventricular failure, and one of them, for example, was the ratio between the right atrial pressure and the wedge pressure, in this case using this cutoff value, 0.63. But in this derivation and validation risk score, they use a much lower cutoff value of 0.54, including other parameters, clinical parameters such as, for example, hemoglobin, or the use of inotropes, or the classification of Intermax. And here you have the right ventricular dysfunction, severe right ventricular dysfunction, which was not available in all the patients. This had a good performance to identify the patients who would be a high risk of right ventricular failure and events during follow-up. And just for finalizing, trying to answer whether the echocardiogram is the only parameter that we can use to assess the right ventricle, I think that is the most accessible, that's for sure, and is the imaging technique that we can use at first time, and quite versatile, having the possibility to develop several parameters. But I think that it's important, first of all, to make the exam with the patient in euvolemia or even drier, and it needs to be integrated as well with the hemodynamic measurements invasively. And with this, I would like to thank you very much and invite you to join the heart failure meeting that is going to be in Madrid, and where the Association of Heart Failure from Spain is working hard to make it remarkable. Thank you very much for your attention.
Thank you very much, Doctora Delgado. We are going to discuss after the presentation of all. The next presentation will be done by Dr. Jorde, who is a cardiologist from the Montefiore Medical Center. And he is going to talk about one of the problems of the destination therapy, that is, for instance, one of the most implanted strategies now in the United States. Is the destination therapy is for everybody. We will listen to you. Thank you.
Great, thank you very much. Again, I just talked to Joe, and I guess it's my 6th time at this meeting. And just thank you again. It's always fantastic. And I will say that today, again, I say it again, the case presentations were really super top-notch and reflect, I think, the excellence at the center. I'm going to just not address my assigned topic, but talk about something completely different for 1 second, because I saw the COVID case. And here is our center is in the Bronx in New York, and we just published this paper. And you can see here in red is the admissions, the bed concentration with COVID-only cases. We had in April of 2020, when you saw your case, we had in 1 week at Montefiore 1,000 COVID admissions, and that brought our hospital bed occupancy to about 130%, 1,800 patients in 1,500 beds. And then COVID went away slowly here, and the bed occupancy rate though decreased dramatically because the moment our governor said no more elective surgeries, no more elective admissions, the hospital freed up for COVID. What you can see on this side is mortality. Initially, during this first week, was about 30%. And then later on, it was around 5 to 10%. And everybody talked about remdesivir, steroids, all these things, which have not much to do with it. What you see here is, was triggered by the hydroxychloroquine. In the beginning, everybody got hydroxychloroquine. This is the drug, and then nobody. And you can see in yellow the use of steroids. Okay, increasing and anticoagulation. And my main point is that the mortality dropped immediately when the beds were freed up and more staff was available to take care of the patient. And that paper just came out this week, so I just wanted to quickly show this. But my actual topic is destination therapy for LVAD. Is it for everyone? And it's a short presentation. The answer is no. I would like to add that the term destination therapy has really become obsolete, and the decision is really a priori LVAD versus a priori transplant versus palliative care. I've come here for 12 years, but we really started about 20 years with the first wearable left ventricular assist device, the HeartMate 1, that is shown here. And at that time, we had in place ACE inhibitors, MRAs, and beta blockers, and had dramatically improved outcomes of patients with advanced heart failure who presented naive to therapy, from 50% one-year mortality in the 80s with Lasix and digoxin to really only 10 to 15% one-year mortality with appropriate medical therapy. On this background, the HeartMate 1 was reasonably successful. I'm not going to show you the data on this, you probably know it, but we have come a long way over the past 20 years to what we consider a destination therapy device, if you still want to use that term. This is the old pump that lasted about a year or two. This is the new pump, the HeartMate 3, that can last, who knows, at least 10 years, I would say, mechanically, maybe longer. But also, dramatic changes have occurred with medical therapy that have to be mentioned before we ever talk about LVAD therapy. This is just the Entresto data you see here, Entresto versus enalapril. There's an improvement. There is an absolute reduction of about 5% in the combined endpoint of hospitalization for heart failure or mortality. And the number needed to treat to prevent hospitalization or death is relatively small, but just using an ARNI over an ACE-ARB. This is a new foundation. Second step, SGLT2 inhibitors. I know this group is familiar probably with the DAPA heart failure study that showed, again, a similar absolute reduction of 5% with DAPA versus placebo on otherwise well-medicated patients with HFrEF. And then, of course, came the empagliflozin study, showed exactly the same. And we take away from this that there is a class effect for SGLT2 inhibitors in heart failure with or without diabetes. Important tidbit is here, in DAPA heart failure, a retrospective analysis was done to look at whether this additional benefit is preserved if the patient is already on Entresto, and the answer is yes. So this is additive therapy, and your guidelines are always ahead of the American guidelines, already recommended as a class 1. This is also happening now in the AHA guidelines. You probably have seen these slides before that I just showed you, but this is something that's really a beautiful paper that came out in JAMA that puts all of this together. And what they did is they had a theoretical model where they said, what if I
give the patient conventional therapy, ACE/ARB beta blocker for heart failure, or I give him what I would consider comprehensive medical therapy, having an ARNI, having an MRA, and having an SGLT2 inhibitor. And what they modeled is that if you start a 55-year-old on conventional or comprehensive, this patient will gain 8 life years. This is an incredible difference. If you start a 65-year-old, they will gain 6 years, and even an 80-year-old will gain 2.7 years from a comprehensive heart failure package versus what we did 10 or even 5 years ago. So when we talk about destination therapy, this is something that you have to keep in mind. Medical therapy has incredibly improved, and other things are coming. Here's the cardiac myosin activation with omecamtiv. This is a large study recently in New England Journal, negative. There was a sub-study that looked at patients with severe heart failure, more advanced, lower EF, sicker, and there seemed to be a signal from omecamtiv, but again, this is a retrospective analysis. I just told you how great Entresto is. Everybody should use it, but be careful if you use this drug in patients with more advanced heart failure. The LIFE trial was conducted, also a randomized placebo-controlled study, randomized versus ACE inhibitor, and there were 335 patients. I don't know whether this is already published, was presented at the ACC last year. They had an EF less than 20%, not 40%, but less than 20. They had a low blood pressure, they had a low GFR, and they had a high NT-proBNP level. And in those patients, starting an ARNI over an ARB in a randomized trial actually led to more harm, more hyperkalemia, more hypotension. So this is not something that we want to use to rescue a patient. It should be introduced early, but don't try to save a patient with Entresto when they are really ill. So this brief excursion into medical therapy I think is very relevant, but let me summarize it. The medical therapy for HFrEF has dramatically improved over the past 4 decades. The 1-year survival for the all-comer, drug-naive heart failure patients is from 50 to 90%, but survival remains poor for patients who remain symptomatic despite comprehensive medical therapy, which is the foundation for any device trial nowadays. So what becomes very important that we recognize the failure of therapy early on and then move to device therapy as indicated. This device therapy could be a mitral clip, and I know you're doing mitral clips here. Dramatic results of the COAPT study that all of you are also familiar with, but just look at the mortality at the 2 years. It's not that everybody survives. A lot of people still die, so there is room for improvement. The other thing I want to underscore for you, that an important metric to look at when you look at will a heart failure therapy be successful is whether the ventricle continues to remodel and get larger, or whether the ventricle reverse remodels, i.e. gets smaller and possibly stronger. And what you can see here is despite the dramatic outcome improvement with MitraClip, the device group still continues to remodel. And this is why the mortality is high. So we should absolutely use it, but there may be other things that we can look for to fill this gap between comprehensive medical therapy and heart replacement therapy. I'm not going to talk to you about shunts, but I was just at the THT meeting that Dr. Uriel co-chairs in New York, and we saw the CORVIA results, which you may have seen in HFpEF, very disappointing. In HFrEF, we don't have anything yet, but I'm not sure that's going to be the answer. So I would like to briefly show you something that we're currently doing a global study on. This is the so-called AccuCinch device. I have a little movie here how this thing goes in. This is a percutaneous ventriculoplasty, where the interventional structural cardiologist goes into the heart with a catheter, goes about 2 centimeters below the mitral valve, and then places a sequence of anchors and little sutures to then shrink the ventricle. A physical restraint from inside, like the stitch procedure that surgeons used to do from inside. This is currently being tested. Here's just how this looks in vivo in our lab at Montefiore. This is the placement of the anchor. These are the anchors now placed into the patient. And this is what it looks like once this device has been cinched or made smaller. This is the original curvature circumference, and this is now comes in by about 1 centimeter. There's 3 different cases. Here's the device in the animal right after it was put in. This is the device 10 days in human, where it's beginning to endothelialize, and here it is 3 months later, where it's completely integrated into the ventricular wall. What has been observed with this in anecdotal cases is a comprehensive reverse remodeling of the left ventricle, as shown here in a patient who had 2 contrast CAT scans with a 3D reconstruction of the heart. And what I want you to notice is that not just up here, where the restraint was placed from inside, but the entire heart reverse remodels. And we now have experience with this in just over 40 patients worldwide, EF 20 to 40%. Comprehensive medical therapy, meaning an ANI, ideally an SGLT2 inhibitor also, no significant mitral regurgitation, and symptomatic heart failure. And what you see here is a really, really nice signal of a reduction in LVEDV by 40 cc's from about 200 to 160. Reverse remodeling, as I told you earlier, is extremely important. Here are a number of heart failure trials and outcomes, and these trials here in blue all had reverse remodeling, ventricle got smaller, and mortality or heart failure hospitalization reduced. So before we talk about destination therapy, you have to go through the sequence of other things. But as I said, don't rescue a patient with Entresto, don't refer the patient too late when we move to destination therapy. So again, I told you we have the 2 devices. The patient has also changed. 20 years ago, in the first ever destination therapy study, the ejection fraction was 17%. Same now in Momentum 3. The age was 67, a little bit younger here because it also included bridge to transplant patients. Serum creatinine 1.8, a little better here. We're moving earlier. How early should we move? The next panel is going to resolve this for you, maybe. But we're moving earlier. Patients are not as sick as they used to be in the first destination therapy trials. I just listed these exclusion criteria for the momentum trials because these are the obvious contraindications, but I didn't want to put my whole talk on this. Obviously, if you have a high bilirubin, if you have irreversible end-organ disease of the lung or of the liver or of the kidney, you are not a candidate for destination therapy. Once you're a candidate, however, we have seen just dramatic improvement over the past 20 years. And this is where we are right now. First of all, we have stopped to just talk about mortality because survival at 2 years has gone from 0 to 70 or 80%. We are now talking alive, free of stroke, and or need to remove the pump. And this combined endpoint with the current device, the HeartMate 3, has gone to about 75% at 2 years. And keep in mind, when you think about a DT LVAD, that the absolute survival difference in somebody who is failing medical therapy and is a candidate is about 70% mortality. So we should strongly consider these devices. But when to use them and who to use them in, I've reserved this for the combatants that are coming right after me that you see here in the pictures, so they can talk about at what point should we consider a left ventricular assist device. And I just leave it there to set the stage for the 2. Thank you very much.
Thank you, Ulrich, for this excellent talk. And I think it's a very good introduction from the next speakers. And I am sure we are going to have big fun. So the next talk is early implant of ventricular assist device long-term in patients with chronic heart failure. And the pro is Guillaume Le Breton from the La Pitié Salpêtrière Hospital, Paris.
Thank you very much.
First of all, thank you for your invitation, because it's a pleasure for me to be there today. Like it was said before, it's a very interesting meeting for discussion, for the presentation, for everything, and I'm very happy to be there today. I will try, and I hope I will succeed, to convince you that early implantation of LVAD is the good strategy. So this is my disclosure. What will tell you the next speaker is that today with LVAD we still have a lot of complication, a lot of adverse event with bleeding, infection, driveline, etc. And this is what is reported in the literature and in some publication from a long time. And that's right, that if you look a roadmap study, by example, at 2 years, you can see that with the LVAD therapy, you have some complication and some adverse event. You have a lot of bleeding, stroke, thrombosis, driveline infection, but you have also a benefit in terms of survival, like it was said just before by Ulrich. But now, at the ArtMed 3 era, things are a little bit different. A little bit different because we have less complication, and probably also because we have a better management of the device, and also probably a better device than in the past. And you know that with this new pump, we have very, very few or very exceptional pump thrombosis, so it changes a lot of things, and probably now we learn to manage this complication. And consecutively, you can see there that we have a better survival with this pump, with ArtMed 3, that we can have in the past. And during the Second World War, Winston Churchill said, "I have nothing to offer but blood, toil, tears, and sweat." But for LVAD, I think it's a little bit different. For sure, you can have some adverse event, but you are alive. And I think it's very important to consider that. And to have complication, you have to be still alive. It was a sentence from another great man, not Winston Churchill, but Ulrich Jord. 2 years ago in this room, he said that, and I think it's a very, very, very true. Okay, for sure, patients with LVAD, maybe they will have any complication, but they are alive. And I think it's very important to keep in mind. Because, by example, in France, and I know that it's like that everywhere, we are in front of an organ shortage. So probably heart transplantation is the best option when it's possible. But never forget that all the patients can be transplanted. And in France, by example, we just have 1 heart for 2 patients on the waiting list. So when we speak of the good result of heart transplantation, we speak of the good result of the transplantation for the patient who can be transplanted and who have the chance to have an heart. But it's not all the patients. So if you reason in terms of intention to treat, it's a little bit different. And if you look the result today of the LVAD at the Momentum 3 era, it's very different of what it was in the past. In bridge to transplantation today, results are more than 80% of survival at 2 years. And it's something which is very interesting, because if you look the result of heart transplantation at 2 years, sometimes it's not really, really better. And to convince you, I will share with you this clinical case, which is a young man, Mr. Dessy, which is an aristocratic patient in France, 38 years old. It's a patient with a cardiomyopathy, and he was registered on the waiting list in January 5 years ago. He was, you have there his group, his blood group, he was O, it was a big patient, and he had a low score, because probably you know that in France now we moved to a scoring system for the allocation of the graft, and he has a low score because the score is calculated with the renal function, with the bilirubin and the BNP, and this patient is at home. He's Intermax 5 or 545, and so he had a low score, and on the waiting list, he wait, and he wait a long time. He wait during more than 1 year without any call, without any graft proposal. And during Christmas, with his kid, he was at home, and he understood that if he do nothing, the end will be very catastrophic for him. So even if we discuss of LVAD implantation for him since months, he finally accepted this option. And I performed this implantation in February 3 years ago. And with a manubriotomy and thoracotomy, the outcome were quite classical in such a situation because it was an ambulatory patient. He was at home when we performed this implantation. And I see this patient in consultation few months after the implantation, and he told me these 2 sentences I want to share with you because I think this is the best argument to convince you that early implantation is probably the best option. He said, it is truly life-changing, HeartMate 3, and if I had known, I would have accepted sooner. He said that in French, so I did the translation in English. Maybe it's not perfect, but I think you understand what he wanted to say. And I think it summarized very well the situation. And he were transplanted 1 year later, and he is still alive. So today, result with LVAD. If we look at bridge to transplantation, destination therapy, or in the international registry, the 2-year survival is 80 to 85%. So it's very good. It's totally different of what it was in the past. So with this LVAD, and it was just on the roadmap study a few years ago, you have a benefit in terms of survival, but also a benefit in terms of quality of life. So in other words, you give some days to the life, improving the survival, but also you give life to the days, improving the quality of life, which is also very, very important to consider. And it was in the Roadmap 2 study, but in the HeartMate 3, you will see that we have also the same result. But what is important to consider is that the result will depend also of when you will perform the implantation. Because if you perform the implantation in a rescue therapy, and the ECMO, by example, results are totally different. This is what you can see on this slide. And if you perform the implantation, awaiting renal failure, awaiting right ventricle failure, it will be too late and you will have poor result. So it's another argument to convince you that it's necessary to consider the VAD implantation before it's too late. And to answer to this question, few years ago, Richard published this comparison between patients implanted in Intermax 4 to 7 and Intermax 1 to 3, and there is a difference in terms of survival. But what is also interesting is to see in the Intermax 4 to 7 what is the difference? Because in fact, between a patient which is with resting symptom at home, a frequent flyer, and a patient with an advanced dyspnea, NYHA 3, it's very different. And to answer to this question, you have this publication in the literature from Ambard-Decker. We did a comparison between LVAD therapy and medical therapy for several Intermax level. And you see that for Intermax 4 to 5, there is a benefit in terms of survival for LVAD implantation in comparison of medical therapy. A benefit in terms of survival, but also a benefit in terms of quality of life. So I hope with this argument I can convince you that early implantation is the good option. And last but not least, awaiting on the waiting list or waiting before to consider an LVAD implantation, the risk is to have to consider this implantation under ECMO support. And under ECMO support, as a bridge-to-bridge strategy, the results are very poor or very disappointing because the patients are in a very critical situation and also because it's very difficult to have a good assessment of the right ventricle under ECMO support. Very difficult or not really possible today. we can discuss of that after, because probably we can have some interesting option, especially with the ECPELA strategy. And if you do the comparison between bridge-to-bridge and transplantation and their ECMO support in France, this is our experience in La Pitié, it's totally different, because transplantation and their ECMO support, we have exactly the same result that transplantation on the standard waiting list in our experience. But in bridge-to-bridge, totally different, 50% of survival at 3 years. So disappointing result. And you see that this is in the post-operative course that there is a big difference and a big mortality. And recently, De Philippis, which is a guy from a collaborator from Neuroriel, I think, published this publication in JACC Heart Failure with a comparison between ECMO to heart transplant and ECMO to LVAD. And in ECMO to LVAD, in bridge-to-bridge, he reported quite some similar result of our result a few years ago. It's about 50% of survival at 2 years. So disappointing result in this strategy. So I think it's necessary to avoid, to consider VAD implantation under ECMO support. So to conclude, I can conclude just with these 2 sentences of this patient, because I think it's a good summarization of the situation. But we can conclude also by this graph. I think that when the patient is stable on the waiting list for Intermax 5 to 6, probably the best option is to wait, to have a graft for this patient. But when you have heart failure, decompensation, cardiogenic shock, it's important to consider when the patient is a frequent flyer, it's necessary to consider a VAD implantation, Intermax 4 to 5, when it's not too late, because with an early implantation, you will improve the patient and you will have better result, even if you want to consider an heart transplant later. If you wait with the time, the patient will be in a poor situation, maybe with renal dysfunction, renal failure, organ failure, and results are totally different, and it's necessary to avoid this situation. And for the patient in cardiogenic shock, I think in emergency there is no place for VAD. This is what I think, and this is what we do in our institution. We prefer to use ECMO as a bridge to decision to see after what we can offer to the patient, but you have seen that VAD under ECMO support results are a little bit disappointing, even if since few months we improve our result. So, and this is the end. Now, with the LVAD, we improve the result in terms of survival, in terms of quality of life, in terms of complication, because we have a better management of this complication. So we improve the result. And in this context of heart failure and organ shortage, this is a good option. This is a good option, but it's not a magic weapon, and it's necessary to consider this implantation before it's too late, because if the patient is quite stable in a good clinical situation, you will have good result, and this is a good strategy. If you wait, decompensation, organ failure, results are totally different, and you will be disappointed. So, if we want to summarize on this table, when consider an LVAD implantation, today I think that from Intermax 4 to 5, this is the good time to consider an implantation. And I say that it's important to do it. I believe in early LVAD implantation, but sometimes, even in our institution, we don't do it. Thank you for your attention.
Thank you, Guillaume, for this excellent talk. I think Dr. Costello is going to be very nervous. So now, Joe Costello González Costello, from the Hospital Universitari de Bellvitge, from here in Barcelona, is going to defend the CONS.
Thank you very much. Thank you, Guillaume. That was an excellent presentation, and really, you cover the whole spectrum, because you cover the early, you cover the late. So I'm going to start with a clinical case, just to put it into perspective, because we all like to think that, as you said in your last slide, that we are thinking about LVAD implantation early, But then when you look at what we do and when you analyze what we do, we're not actually doing that. So this is a clinical case that comes to prove a little bit that. So this is a 66-year-old male, diabetic, dyslipidemic, chronic ischemic cardiomyopathy, stented, then eventually got surgical revascularization, was left with the left ventricular ejection fraction of 30%, got an ICD. He was on optimal medical therapy, as Uli told us, and he was really very stable since 2009. But he had an acute myocardial infarction in February last year. So they did a left heart catheterization, which showed that the bypass to the right coronary was occluded. He got a stent there, and the bypass to the LAD was okay. The bypass to the first diagonal was okay, and he had an 85% circumflex stenosis, which wasn't treated because of the distal area was not that great. He had complete AV block post myocardial infarction, so he needed pacing, he needed inotropes, and eventually was upgraded to CRT ICD. However, he was left with left ventricular ejection fraction of 29%. Eventually, it had actually increased a little bit, but he was much worse from dyspnea. He was in New York Heart Association class 3, despite optimal medical therapy, and he was admitted because of heart failure in May 2021. At this point, they referred him to our institution. This is the ECG. This is the chest X-ray. This is the echo. So he had a severely dilated left ventricle with an ejection fraction of 27%. As you can see, he had apical, enteroceptal, and infraposterior akinesia. He had restrictive fill-in, moderately dilated left atrium. He had a severe mitral regurgitation, and he was probably not a great candidate for MitraClip. As Uli said, he had calcium in the leaflets and the ring, short posterior leaflet, and a very dilated LV. More like Mitra FR than co-opt. So there we go. So we evaluated the RV, as Victoria told us, and it didn't look bad. Echo looked pretty good. We did a right heart cath. He had elevated wedge. CVP was low. Cardiac index was definitely low, cardiac index of 1.7. And he had a PVR of 3.8, which was reversible with dobutamine and nitroprusside. He had a right ventricular stroke work index of 728. CVP to wedge of 0.29 and a PAPI of 2. So RV looks pretty decent. So he is an LVAD or a heart transplant candidate. So he was 66 years old. He was not frail. He was big. He did have diabetes, which was treated with insulin for quite a few years. He didn't have proteinuria or retinopathy, but GFR was 43. NT-proBNP was 3,000. And what we didn't like is that he had important aortic infrarenal calcification. So his CT scan was really a lot of calcification, atherosclerosis, but he didn't have any significantly hemodynamic occlusion of the arteries. He also had a bone cyst in the left femur. Respiratory was decent. He was a blood group A, and he had good family support, and he didn't have, he had a negative Luminex. So at this point, we decided, you know, what should we do? Maybe, as Guillaume suggested, we should go straight for an LVAD as a bridge to transplant. He is definitely Intermax 4, I would say. Try the MitraClip, although he may not be the best candidate. Start levosimendan. We can do this intermittently and list as an elective heart transplant. And if he worsens, we implant an LVAD. So this would be, you know, let's wait. Or should we implant an Impella and list him straight for heart transplant as emergency 0, which is something we can do in Spain. So I don't have the answers here because it's not a case. So this is what we did. And this is probably what we do in many cases in Spain, as I will show you a little bit later. So this is not infrequent in Spain. We all agree that the patient is in advanced heart failure. Marisa knows a lot about this because she led the position paper. And we all agree that this patient has evolved and he is in stage D and he has reduced cardiac output and increased left ventricular end diastolic pressures. So these are the cases, these are the patients we should be acting. If he doesn't have absolute contraindication to heart transplant or LVAD, these are the patients we should take to transplant or LVAD. So the question is, do we consider he's eligible for transplants? We did. We considered he was eligible. So what we did was list him and give him levosimendan just to keep him out of hospital. The other option would be to consider him not candidate for a transplant. And there, I think, you know, the sooner you implant the LVAD, the better, because otherwise this patient is not going to do well. So I like this algorithm because it tells you a little bit what to do. So I do think Intermax 4, and now this would be an Intermax 3 if we put him on levosimendan. So this is certainly a patient that if we're thinking for destination therapy, I would go straight for LVAD. I wouldn't wait any longer. What are you waiting for? But if we list him for heart transplant, you know, he already has a sternotomy. So it's a tricky case. And in this case, we decided to put him on the heart transplant list and wait. And Guillaume also told us, obviously, if you can get the patient to transplant, that's still the better option. And if you can avoid, you know, another surgery in this patient, this is probably still the better option. The problem is whether this patient can wait, because we know that the results from Momentum 3 are really good with the new LVADs. However, results for heart transplant in Spain are also quite good. We know the benefits of the LVAD implants, as Guillaume showed. Increase in quality of life is significant, and this is mortality is especially increased over the last few years, and this is because of the new devices, because of the HeartMate 3. So bridge to transplants as an option with an LVAD. Is this an option for this patient? Well, if we look at the data, this is data from the US, it looks like a good option. Destination therapy is worse, but why is it worse? Well, it's worse because these patients aren't getting the heart transplant. If we analyze the patients that did not get the heart transplant, there's really not much difference. However, the patients that got the heart transplant are doing better. So obviously in the long term, heart transplant is still a better option. So if we look at the roadmap trial, the roadmap showed us that in patients Intermax 5 to 7, you can probably wait safely to implant the LVAD. However, Intermax 4 and 3, I agree with Guillaume, they're the patients we should be putting in the LVAD directly. So here, the ESC guidelines actually tell us, I was a little bit surprised with this from the ESC, because patients Intermax more than 4, we obviously evaluate them. If they're candidates for heart transplant, we list them. But Intermax 4, 3 to 4, which would be this case, he doesn't have a contraindication for heart transplant, so what do the guidelines tell us? List for heart transplant and wait. And surprisingly, or delisting with very close follow-up in case of meaningful improvements, which is highly unlikely in a patient like this. And they don't really tell us where to do bridge to transplant. They talk about bridge to candidacy, they talk about destination therapy, but where is bridge to transplant? So the guidelines are telling us to wait. So did we do correctly in this case? So do we have other options? Well, yeah, we do. We have what we actually did, continuous inotropes, but the level of evidence is clearly inferior. So we're doing something that is not actually backed by the guidelines or by evidence, and we're not doing something that is clearly, that has clear evidence. So I want to show you this. We just sent this to the Heart Failure Association Congress. And this is the Level TC registry, which is a registry. I think David is here. He's one of the instigators with myself and Javier de Juan. So we decided to study all these patients that are being bridged to transplant with levosimendan, which is something that happens quite often. This is 238 patients from 2015 to 2020. So if the patient gets a transplant early, before the first year, it seems a decent strategy. If they have to wait longer, they have more mortality. And the outcomes after heart transplant are good. They're similar with or without levosimendan. What I don't like is this, the increased risk for heart failure admission with levosimendan in these patients waiting on the heart transplant list. So what happens? Well, what the registry told us. Readmission for heart failure, October 2021. Flash pulmonary edema in the context of atrial fibrillation, which is something we know can happen with inotropes. So a patient needed non-invasive ventilation, intra-aortic balloon pump, NT-proBNP went up. We managed to stabilize the patient, lactate didn't go up. We were able to wean the intra-aortic balloon pump. We gave him another dose of levosimendan, we keep insisting. We got the patient into sinus rhythm with electrical cardioversion because we didn't see any thrombus in the transesophageal. And so here, what do we do now? Do we go straight for heart transplant with an Impella, which is the easy option? Do we implant an LVAD as bridge to transplant? Do we decide, we're thinking maybe he's a destination therapy? Maybe we should implant the LVAD and then decide whether he's bridge to transplant or destination. Or we can implant the left centrimag as bridge to transplant. So this is what we decided to do. In Spain, we do a lot of short-term VADs as bridge to transplant. Here's what Eduardo showed us, that with an ECMO or biventricular short-term VAD as bridge to transplant, the results are not that great. However, with a temporary LVAD, such as Impella Centrimag, results are much better. So we decided to implant the LVADs. What we do is we try and stabilize the patient. He was on aspirin, clopidogrel, and now he had atrial fibrillation, so he needed anticoagulation. So we took the clopidogrel off, waited a few days. We actually managed to restart all the medication. However, he started with pain in the left hip. He had a cyst there, so initially we thought it was just that. But 5 days later, the patient went into acute decompensated heart failure, hemoglobin dropped a little bit, renal function worsened, he had intense pain in the left hip. So when we did a CT scan, and he had retroperitoneal hematomas. This was spontaneous, we hadn't done anything there. But he was on enoxaparin. So we deferred the implant, we obviously stopped anticoagulation. He improved with dobutamine, diuretic. He improved his pain, hemoglobin was stabilized. We did another CT scan, it looked stable, and we restarted heparin. 3 days later, he again went into atrial fibrillation, worsened heart failure, intra-aortic balloon pump, dobutamine, norepinephrine, and really the patient went very fast into cardiogenic shock. When we looked at the vessels to implant an ECMO, because he was actually just crashing, the vessels were absolutely disaster, so we didn't implant an ECMO, and we were deciding whether to implant a Centrimag and Impella, and the patient just crashed and he died. So late implantation of LVAD in patients with Intermax 3 to 4 and bridge to transplant has to be carefully evaluated case by case. The other option is, just implant the LVAD and then decide whether he's a bridge to transplant or destination therapy, which I know is what you do in the US. But this is what we do here in Spain, so there you go. Intermittent inotropes as bridge to transplant is easy, but we have less evidence, and sometimes patients decompensate rapidly, and then you don't have time to implant the LVAD. Thank you very much.
Thank you, Joe, for this interesting presentation. We are going to continue the presentations with the one from Niri Uriel from Columbia University Medical Center. He is going to talk us about the future of this mechanical support, what we are going to expect in the next years.
So first of all, thank you very, very, very much. It's a great honor to be here, and I want to thank Joe and the rest of the Belviche Hospital for organizing it. Again and again, we are coming to Barcelona, and again, we are learning in Barcelona. Great meeting, and fun to be among friends in person, and not only on the other side in a Zoom. So my task for today is a fun task. I have the opportunity to imagine how is the future of mechanical circulatory support is going to look in the next 5 to 10 years. So before we start, we just need to remember, we have a good option now. We have the HeartMate 3. It's completely magnetic levitated. This is already futuristic. It has a wide blood flow passage, it's frictionless, and it has an intrinsic pulse. So we're pretty good. And as you saw before, the outcome of the HeartMate 3 are pretty good as well. 75% survival, free of the risk of a stroke, and free of the need for device exchange. However, if we look at it, it seems to be that LVAD and transplant reach the same outcome. In short-term support, 2 years. Can this be long-term? And can MCS be superior to transplantation? Can we get rid of all this big list of adverse events in order to understand what the future will look like? So let's start thinking, what are the gaps? And for me, the gap number one, LVAD need to be forgettable. Patients need to forget that they have something. So we need a completely implantable LVAD, and we'll talk about it soon. Gap number two, LVAD is not physiological. We have different need in different time. LVAD have to be smart. It cannot continue to be a stupid pump, have to be a smart pump. As I showed before, there is still a big list of adverse events, and I think the two that are the most worrisome right now for us, or need more to be advanced, is the GI bleeding and RV failure. And last and not least, Guillaume, we love surgeon, but this needs to be implantable by cardiologists. So we need to be easier implant, smaller pump, and maybe percutaneous implant. So let's go one by one and see where we are, and let's see if we can close those gaps. Why it's so important to forget LVAD? Because when we have a driveline that's coming outside of the body, we are going to have problem. This is an analysis from the momentum free. As you can see here, infection in LVAD is very common. But what I want to emphasize is on the left side is the freedom from driveline infection. Momentum free brought us a great pump, but the risk of driveline infection is still identical between HeartMate 2 and HeartMate 3, and it's still very, very, very high. Furthermore, we can say that yes, whenever you have an LVAD-related infection, as you can see on the left side, it's increased your mortality. However, driveline infection by itself at 2 years did not increase your mortality, but it's something that is cumbersome to the patient, and it's bothering the patient. So can we get rid of this driveline infection? So this is something that we know we can do. This is Leviticus. This is a pump that come to solve this problem in a generalized way. So the idea behind it is to put a battery inside the body, and this battery can be charged from a Wi-Fi technology. In order to not create heat, it needs to be a very big coil. So the coil is going to be surrounding the lung. In the second that you have a big coil, you don't generate a lot of heat, and you can charge the patient. As you can see here, the patient is being charged. It's taking him an hour or so, and then he can get rid of this charger, and he can go and become free. And when the patient is free, he actually can do whatever he wants. He can take a shower. He can do whatever he needs. And he have a watch on his head that can tell him what next time he need to do it. We did the first implant of it actually a few years back in Kazakhstan. And actually the first patient that you can see here had a Javi card, because if it was not working, we can connect the patient. What definitely it shows us a proof of concept. It can happen. Unfortunately, since then, Leviticus didn't start, but there is now a collaboration in France and implanting Leviticus with other pump, not the Jarvik 2000. But there is other pumps that are actually coming with this. This is the Covion. Covion pump is actually represent two different technology. One, it's a hybrid magnetic levitated pump. It's much smaller, so the amount of energy it requires is substantially lower. Now, if you need low energy, maybe now you can do something with percutaneous pump. This pump have a battery that can last for 3 years, and then you can exchange the battery and continue. But the battery is outside of the pump. It's not part of the pump. So that's definitely something. This battery is rechargeable, and every time you charge it, it lasts for 3 hours. In 2022, the Covion study is supposed to start, and actually we will know the lesson whether or not it's a function. So it's coming. Abbott, Medtronic also have a breakthrough designated device that is completely implantable. Abbott have a technology that is coming close, so definitely. Physiological and responsible pump, something that will react to us. We are running. A lot of you are going to run. You need a cardiac output of 23 liters. We are sleeping. We need a cardiac output of 3 liters. We have to adapt to those changes. Is LDAP adapting? This is a beautiful, beautiful paper that Donna Mancini actually did, and demonstrate what happened when we exercise with LVAD. First of all, this is the rest and exercise. As you can see, the heart rate is going up, mean arterial pressure going up. However, right atrium going up, mean pulmonary pressure jumping to the 40, wedge jumping to almost the 30. And the peak cardiac output, it's improved, but it's improved from 4 liters to 8 liters. You remember how much I told you when I run I need? I need 23 liters. So if you look, the big jump that we can see in the cardiac output during exercise, it generates actually by something that is not the pump, by the natural heart or by the pulsatility. This is not something that will give us a solution. Can we change it? So this is a very elegant study from the group in Sydney, Australia, and they demonstrate that by, yes, it's still not optimal because they just increase the speed a little bit, but if you increase the speed, you can close this gap a little bit. So what do we need? HeartMate-free is the only pump we have today. We have a HeartMate-free with a brain that will react to our physiological behavior, adaptation for activity level, still less adverse event and even improved survival as it is now. So what are the sensors that we have in order to do that? First of all, it's in the LV, so we have sensor in the LV, maybe LV-EDP, left atrial pressure, as we saw the paper that came out now on Victorious, pulmonary capillary wedge pressure or PA pressure, and I will speak about it in a second because this is already exists. This is the cardiomen. We need to know what happened to the RV. So not only the LV, There is now a sensor also for the right ventricle. I'm not going to talk about him too much today. And definitely, we need to react to the activity, and this we know how to do. Pacemaker is doing it for years. They react to our muscle motion, and it can react to activity. And afterload, we need to start really knowing what is the afterload of LVAD, and there is also technology about that. So our smart pump will designate and notice that we have a high pressure or we are running, and it will increase the speed automatically. It will recognize that the pressure are going down. It doesn't want a suction, and we are resting, and will reduce the speed optimally. Can CardioMEM be the first step for this? All of us using it. So we did a big analysis on the CardioMEM from actually all the implant that we saw, and definitely we can see a significant drop in the PA. But I want to mention careful. Careful with CardioMEM and LVAD. And the reason is, yes, PA diastolic, CardioMEM give us PA diastolic, correlate with actually the wedge pressure. But LVADs represent a unique population, that 50% of them have what we call diastolic gap, or decoupling between the PA diastolic and the wedge, 50% of them. And if this is happening, what will happen, if we will react to high PA pressure, we may find ourselves with suction, that is the source of a lot of problem with LVAD. Here in the study, you can see some of the patients had a gap of 18 millimeter mercury, 14 millimeter mercury. So because of it, we have Ramp It Up Free. That actually, it's funny because only this morning I signed finally all the document and we are starting it. It's a hemodynamic study that actually going to really learn how to adjust PA diastolic based on the decoupling with HeartMate free. This is a pilot study, and we're going to see how it is. I will speak about it a little bit more in my next talk later on. I said we still have some adverse event. The reason I didn't mention stroke, because today the perioperative risk of stroke of LVAD still exists, but 6 months after LVAD implantation, the risk of stroke is identical to regular heart failure patient. So, but we have other things that are not, GI bleeding and RV failure. So what we need to do with GI bleeding, and Uli, I'm sure you're going to talk about it in your talk. I'm just going to mention HeartMate free reduce the rate of GI bleeding, relative reduction of 5% or 9%, depending on the patient population, but definitely better. But what we definitely know, that the patients that are old are bleeding, they have von Willebrand disease, but this is not the cause of their bleeding because this is only one thing. They have abnormal angiogenesis. Abnormal angiogenesis, we know what it is. It's create blood vessel that start to bleed, AV malformation. This is because the animal have more angiopoietin 2. LVAD patients have more angiopoietin 2. LVAD patients have more TNF alpha. But it's not because they have LVAD. It's because they are heart failure patients. And this is eventually a lot of inflammation, a lot of angiogenesis that is abnormal, but it starts before the LVAD going in. So I don't think we are going to find a solution to GI bleeding from the LVAD. I think we are going to find a solution for GI bleeding from us managing the patient differently. And this is, for example, a lot of people put a lot of attention, and Guillaume, this is also coming from France. Maybe it's the pulsatility. My big belief is GI bleeding is going to go away when inflammation and heart failure will go away. And that's the reason, and Uli is going to go into it, it's starting before. Right now, we think maybe we over-exaggerate by the management that we give, and we are testing in the multi-center study that's called ARIS, the utilization of aspirin. So again, GI bleeding, I think, going to look different in 5 years, but not because of different pump, rather than because of different management. RV failure. Is it a problem? Yes, it's a problem. You show the rate of RV failure require RVAD, but the RV failure in general, post-op is very common. Late RV failure is also very common. It's 9%. If you have late RV failure, you die. So we need to resolve it. And resolving it is not only patient selection. Resolving it is maybe to do a bivacor or kind of a device that will support both the left side and the right side together. A mechanical circulatory support that will be similar to a total artificial device. But definitely, this is another thing that can come in the future. The Bivacor study is supposed to start also this year in 2022. It's a completely biventricular support. The last thing is an easier import and a smaller pump. I don't know how many of you are familiar with the Chin-Chin device. The Chin-Chin device is very similar to the HeartMate 3. It's much smaller. I don't know if you had a chance to implant it, Guillaume. It's coming from China. It's actually almost the same technology as HeartMate 3, but miniaturized. It was supposed to be the HeartMate 4, if you want to think about it like that. It already exists in China. Interesting to see the result of this pump, but it's smaller, but it's only 1 part smaller. I truly think 5 years from now, we'll have some devices that will be able to do in a percutaneous way or a minimal invasive way completely. As I mentioned before, the Impella started, the EFS study of the Impella is starting in the second quarter of this year. This pump will allow to send patients with percutaneous transvalvular LVAD home. This is going to be, the technology is based on the Impella 5.5, and definitely something that is going to be interesting to see. But in the future, this is what we anticipate. But maybe it's not going to be only LVAD, and maybe the future will be xenotransplantation. I still think the technology have a lot to say. There is no doubt that xenotransplantation is fascinating. It's a topic for another talk. But for the meanwhile, I have a dream that still includes mechanical circulatory support in the next 5 to 10 years. Thank you very, very much for having me here.
Thank you very much, Neil, for this excellent talk on the future of mechanical circulatory support. We have time for questions. Any questions for the audience? Fernando.
Thank you. Well, excellent panel. I was impressed by all the presentations. I was wondering if you could help me in deciding whether we should implant an LVAD in a patient based on the results of transplantation after LVAD. And you already alluded to the SERPAC, how improved the PGD. Are the bridge to transplant results with an LVAD good enough to justify early implantation? Because, for example, in the UK, we can only do it as a bridge to transplant. We don't have destination therapy as an option.
So I have to say that this is a topic that even we need to dissect it to multiple elements. There are patients that I still think will benefit getting an LVAD before a transplant. Let's take a 28-year-old man that is going to now need advanced heart failure therapy. I'm going to give him the best transplant. And you know, before I went to the flight, I had a clinic, and I saw a patient in the clinic, and she was 34 years after the transplant. But she's now 36 years old. So now you ask yourself the question, is it enough? 34 years after transplant, tell me, this is a great transplant. But she doesn't want to die in the age of 36. And now she has so many antibodies, she cannot also get the second transplant. Maybe young patient population will benefit from an LVAD. The current technology can give them a 10, 15 years, and then go into the transplant. Yes, there is a little bit increased risk, but not dramatically increased risk. And with the other technology that's available today, with warm ischemia, as we spoke about OCS, or what Guillaume is doing, and cold ischemia with the Sharpa pack, you actually overcome those challenges in relation to post-transplant. This is one patient population. Another patient population that actually I already have the result, and I'm questioning how much I can say, is the elderly patient population. We did an analysis. We took all the patients in momentum 3. So we know they're a very clean patient population above the age of 70. And we took those patient population and we compared them to patients that were transplanted above the age of 70 in UNOS. And the difference was not so dramatic on the long term. And now you ask yourself a question. When you transplant someone above the age of 70, and you give him immunosuppression, he's going to get cancer, he's going to get infection. CMV is not a walk in the park on this patient population. Is it time to do a head-to-head study, heart transplant to LVAD? I think yes. I think it's very challenging. I think it will not happen because it's too much of a niche in order to bring it to the reality. But if we already put an LVAD to a patient, and the patient is doing well, I'm not so sure we need to run and list him for transplant if he's 70 years old. He can cruise control on an LVAD. So there is still room for LVAD, and I just mentioned two patient populations, young and old, and I can go more and more and more. What we need is a toolbox that will give us the option to treat each patient for what's best for him. And we need to be objective, because when we go to a patient, we actually pretty much, he can read our language, what we think is better. I'm in a point that in those two patient populations I just mentioned, I don't know what's better. So when I don't know what's better, I think there is a lot of option. Uli, I don't know what you do.
Yeah, you get a second opinion, in this case from me. So I think that while I'm listening, I'm trying to figure out who won the debate, and because that would answer your question, right? But if you listened carefully, you will recognize that they both won the debate because they both argued the same point. They both said you should implant early, right? Nobody said to wait. I also think that when you look at an individual patient, like the one Joe presented, actually very good, and this is very common, physicians think, what should we do with this patient, LVAD or transplant? And then you ask the patient, would you like an LVAD and then a transplant? Or would you like a transplant? The patient will say, you know, what kind of question is that? And I think many people die because physicians ask the patient that question. I would say if you have 100 patients like Joe's, you get lucky in 15, but not in the other ones. So I think early LVAD is it's not even a debate, in my opinion. And we used to have 4, 5, 6, 7 in these studies. What we saw today is 3 and 4. Once a patient is inotrope dependent, there's clearly a mortality benefit. And what I tell my patient is, nothing good can happen between now and the time we rescue you from this state. And with an LVAD, we can do it tomorrow. With the transplant, you may get lucky. 4, in my opinion, INOMAX 4 is really, if you were to put a catheter in the patient, you would basically find, shock numbers, walking shock. Goes into that game. We never implant 5, 6, 7. We almost exclusively implant 3, but that's because when somebody is in stage 4, we do a right heart cath and say, well, we should probably give an inotrope.
I have a question. So, not unoften in patients in cardiogenic shock, we see refractory shock from a non-reversible etiology in a young patient. Can you talk about the approach of using a durable LVAD as a bridge to recovery versus primary transplant in a fairly young patient who, would have a life expectancy that would be limited by transplant, but may have a shot at recovery?
Manrita, you're bringing a very good point. And if you look, and again in the United States, in the previous allocation system, short-term support did not give you a lot of status. It's not like what you have in Spain, that if you put Impella, it's status 0, you said. In the previous one, status 1 was ECMO, but that's it. The rate of recovery on the list in people with status 1 was 7.6%. Meaning it's not a lot, but still 7.6%. Eventually you think that it's not, and suddenly it's recovered. Right now, with the new allocation system that we have in the United States, if you have status 1 or 2, and we use what you use also in Spain, you get Impella, your status 2. Status 2 is very good status for us. You get transplant pretty fast. The rate of recovery is down to 0.6%, meaning that you transplant 7% of the patient in the list that actually have a recoverable left ventricle. The question that you need to ask yourself, what is better? Mortality on the wait list or recovery? And should LVAD be the one who close this gap? I actually think LVAD should be the one who close this gap. I think right now what happens, sometimes policy affects medicine, and not only medicine affects the policy. And for us in the United States, we are in this, and that's the reason your question. In Europe, it's a little bit different. Even though, also, when you have, if you put Impella, it's a status 0, you already start to be biased and thinking, I can get status 0. If I put an LVAD, what status does it give you in Spain?
0. Just elective. You get elective allocation unless you get a complication of the LVAD.
So that's exactly like in the US, so it's challenged. So Marisa?
Yeah, this is a continuously learning curve because in Spain, after the results of the ASISTENCIA that showing that the patients that went to transplant on mechanical circulatory support short term, and as Joe showed, the patients with LVAD versus ECMO or BiVAD as a worse survival. In 2016, in Spain, our distribution criteria changed, and now if a patient is in status 0 with ECMO, has to be at least 2 days on ECMO until be on the list, just to make sure that the multi-organ failure has resolved before going to the list. So now we are dealing with, and this is what I think, because it's very difficult in all the countries. It's different. We have now increasing heart transplant demands, and we also have increasing donor pool offer. We have hepatitis C virus in the US, not in Spain, but in the US, yes, and also the DCD donors that now is increasingly, at least in Spain, we have more than 14 cases with good results. So it's a continuous challenging, and this is different among countries and even among centers. And what we try to do in the algorithm, in the ESC guidelines, is make a clear concept for the patients who are in the intermass 1, 2 to 3, put mechanical circulatory support, just to make sure that there is no multi-organ failure. And then, if the patient has no contraindications, go to list for transplant. You never know when the donor is coming. In Spain, in the status 0 urgent, in the ASISTENCIA, wasting less than 7 days. But you never know. But if the patient has any contraindications, go to LVAD, either from as the destination or candidacy to have the make profit of each donor.
Yeah. I have a question, because to the panel, I'm interested in what you think. The first thing in the future I put is a forgettable LVAD that will be completely implantable, that actually the studies are, 2 studies are starting this year about it, okay? If you will have a completely implantable LVAD, then where you see, because we still, it seems to be even in this discussion, that we're so biased to transplant. Yeah. If you have a completely implantable LVAD, is this going to make the cut?
I think the answer is yes, and it ties actually into the recovery question. I think that you all know the literature on this, that in the registries, recovery is 1 or 2% on LVAD, but in prospective studies with selected patients, it's between 15 and 25%. I forget the name of the study now, the Emma Burke study. What's it called?
Restage.
Restage, right. I think what we will see with the fully implantable LVADs, forgettable, is an explosion in the recovery field, because a lot more people are going to get it. You get it before the train has left the station, before it's really, really very much too late. And then I think you will see more people recover on an LVAD, and then that forgettable LVAD will become truly forgettable by being taken out, and you can forget it.
Guillaume, a lot of this technology coming from France. Are you seeing it? Oh, sorry. Laura.
I have a question.
I think one important thing is how we define inotropic dependence, because in a lot of patients, they are not on inotropic treatment, but you can see how they are deteriorating, and when you visit them in the clinic, they are getting, you see them and it's a clinical evaluation and you know they are in chronic low cardiac output. Probably those patients are Intermax 3, even if we are kind of very conservative, especially if they are 70-something year old and you don't want to be very aggressive if you're not determined in, you know, in doing destination therapy. So my guess, I don't know, is that maybe we are missing some very good candidates for destination therapy in our country, for example, because we are, you know, being very conservative, and there are a lot of patients with very low peak VO2, very bad clinical chronic situation, and maybe it's because we are thinking if they are not in chronic, I don't know, dobutamine we don't do very much in our country, but maybe levosimendan or whatever. So how do you define that threshold, or how can we manage that?
Yeah, I think the clean definition is end organ dysfunction, even if ever so mild, like slight increase in creatinine when you remove the inotrope. That would be the true inotrope dependence. But often you have the so-called frequent flyers, right? They come back, and I think they would be for me, like in heart failure, we now say we used to say class 3 and 4, now we sometimes say 3B. So I'm going to say they are Intermax 3B, 3 and 4. I think once you have low cardiac output, and this is the root cause of your decompensation, even if reversible, I believe you have a mortality benefit from LVAD, even though the roadmap study didn't show that, but I think it didn't phenotype the patient well enough to select those that would have a mortality benefit.
I would just like to say, I think we're sometimes missing the boat, because all our levosimendan patients are clearly Intermax 3. Yeah. And we're not thinking of the LVAD for these patients. And a lot of them are in this kind of, like the patient I presented, in this 65 to 70 age group, where I think, you know, because if this patient deteriorates like the one I showed, there's, you know, it's hard to get him out. And then sometimes you say, well, he's too bad for heart transplant now, because what, are you going to do Centrimag? And, you know, this is another surgical intervention. You're going to take him to Centrimag with 66-year-old, and you know the results are not going to be good. So that is why, you know, I think, and I showed that case, because I think we're one of the aggressive centers, but clearly we're not. And we're missing the boat on these early LVAD implantations.
I totally agree, and I think any patient on the waiting list that are under levosimendan, we should ask every week we see the patient, why are not we implanted an LVAD? And I think you're absolutely right. And also, and it's going to be very interesting in the registry, you are having the data now to see how many patients we have on levosimendan in our country, in most of the centers, that are supposed to be as palliative care of heart failure, and how many of them are not being evaluated for destination therapy.
But Lola, I think to take even what you're saying to the next level, because Jose, Joe, this is so, so important. What's happening is that we are biased. When you told me, and this is a beautiful registry, I'm actually looking forward, and congratulations to Joe, David, and all the rest of the people that this is registry of the levosimendan. What it tells us, we still don't completely believe in the MCS technology. That's what it tells us. For me, again, in specific patient population, I have already in my head an equipoise. I actually think that it's a little bit funny that when there is another talk that I need to give tonight, because it will be in Los Angeles noon, and I show that the number of LVAD in the United States is significantly declining, going down almost by 30%. This happened in a time that we have the best pump we ever had, like much better than the HeartMate 2, much better than the HVAD. And it's mean that we ourselves, and this is because we're human, we still think that heart transplant is better than MCS. And I love heart transplant, you know it, Lola, and people that know me know that. But we need to remember that for every patient, something else can be better. And what definitely is better, and I didn't know that it's a quote from Uli that Guillaume used. Yes, they have complication, but they're still alive. So we have to remember that. This is a fight for life. We are in the oncology part of cardiology, so levocement and just maintain it a little bit.
I think if you remove the driveline, that'll be
Yes.
That's game changer.
That's what we need. I think there's a reluctance now to proceed with even though the current devices are so good. What has happened in the US is that because of the allocation system, balloon pump use gets patients to transplant earlier, but more importantly almost is that because of this change in the allocation, it is so much more difficult to get a transplant when you already have an LVAD. That for this reason, purely logistic, the physicians in the US are moving away from LVADs because they say, this is not really a bridge to transplant device like it used to be. This is really destination therapy, and that I don't want. That my patient wants to take a chance and wait for the heart transplant. That's the current problem that we have. On the other hand, with a long view, I'm not unhappy that LVADs are not so popular right now because there needs to be more pressure to make the next generation LVAD.
But in your allocation system, is there a limitation in terms of duration under TCS? Because in France, by example, now in our scoring system, in the first months with this system, we have no limitation. Patients under ECMO support have a high priority level with 900 points. And people, the physician, wait to have the good graft, and they wait a long time, and after the patient is candidate for nothing.
Yeah.
So now we decided to change since 2 years with a limitation. The patient has 900 points during under ECMO support since the implantation to the day 12, and after it decreased to 0 at day 15. And in order to make a medical doctor reasonable, to go to consider VAD implantation or another thing, and not to wait. And in your system, is there a limitation?
So there are similar nuances where after 7 days on the balloon pump, let's say, you have to show A, that you cannot wean it, and B, the patient cannot be a candidate for an LVAD. So if you have somebody who's a candidate for LVAD who's on the balloon pump after 7 days, you lose the priority. But there are always ways,
and I think we can discuss of that also, but it seems to be very curious for us to consider that this is the same level of priority for balloon pump and ECMO, because these patients are totally different. If I can, because medical doctors sometimes are not really reasonable. If to give priority for all patients, if we speak in terms of individual benefit for the patient, it's just necessary to put a balloon pump to improve the patient and to give some points to the patient.
No, ECMO is higher. ECMO
is not the same thing. When you have to cross the river,
balloon pump status 2. So they're higher, they're different. ECMO, you're really high, balloon pump is status 2, but the principle remains of your point, and I agree.
But here in Spain, for example, ECMO and Impella are the same level. And we also have a time limit of 7 to 10 days, depending on whether the patient is extubated or not. But it makes no sense. I mean, an ECMO patient, a patient on ECMO has nothing to do with a patient on Impella, and most of these are CP Impellas.
For sure.
Which is like, excuse me? And then we can't prioritize our LVAD patients. Therefore, what do? We don't use LVADs as bridge to transplant. We use an Impella.
Yes, I agree.
So it's kind of, so now we're trying to discuss this also in the Spanish Heart Failure Association. And so we'll do a consensus conference in June. So a lot of the people here are already invited. So hopefully we can kind of puts a little bit of order, because now we have, I agree, we have great technology, the best technology in LVAD, and we're not using it because of the policy.
Yeah.
It's crazy.
That's what I said. It's policy make medicine, and not medicine dictate what's right for the patient.
Yeah.
And I think that hopefully we'll be able slowly to adjust to those policies. I'm 100% with you. I'm proud that Spain is going to do it. In the US, there is still a delay because we just moved in 2018 to the last allocation system.
I think we have to have data and then to look what we have and then change the policies.
I mean, that's the idea of the US allocation system, it's a planned collection of data in this system to then ultimately develop a allocation score based on the experience. That's the goal. And, you know, we have to keep, so that's what we need. And the system is not designed to help the individual patient or individual system. The system is designed to allocate, I don't know, 3,000 hearts a year appropriately with 3,000 good outcomes.
But this is what we did in France to build our scoring system, but there is a bias. Because, in fact, in France, because Impella wasn't reimbursed, we didn't use Impella. And in our database, Impella support doesn't appear as a risk factor of mortality on the waiting list, so no points for Impella. Yeah. And at the opposite, because ECMO is used, we have a huge use of ECMO, we have points for ECMO. So now when we have the choice, and this is what's said here, when we have a patient in cardiogenic shock, we want to go first, we want all the MD, want to go first to ECMO because it will give points to the patient.
Yes, exactly.
And they don't try another strategy. And it's crazy. And if I add another comment just to find a compromise for debate in between our two positions, because I agree with you. But what we try to do in our institution since 2 or 3 years now is that when we have a patient in Intermax 4 or 5 on the waiting list, we decide to put a deadline. And the patient wait on the waiting list during X months, and at the deadline, we perform the VAD implantation. So we give a chance for the patient to be transplanted, but after it's too late. Over time, we decide to implant the patient. We do that, and I think it's a good compromise.
Thank you. Excellent panel and excellent discussion. My question is regarding to one of the questions pointed in the Joe's presentation, and is in the bridge to transplant population, the timing for therapies with mitral clip, for example. I mean, which patient would you consider for mitral clip therapy before LVAD? What is experience with LVAD therapy after mitral clip implantation, etc.?
I think the criteria, the patient meets criteria for the co-op trial. I think, that is, I think you can do it because that will improve the quality of the patient. But you have to be very careful and follow the patient to see how he's doing, because as Uli showed, mortality in the mitral clip arm is still very high. So I think it's good. It works. It certainly improves the quality of life of the patient, and it may influence remodeling, and for some patients that may be it, but you have to keep them, you have to keep regular follow-up of these patients because they may need the LVAD or the heart transplant soon after.
David, if I may even make your question bigger, it's not only mitral clip. Mitral clip, if you look at the mortality, not what the slide that Uli show is mortality and hospitalization. If you look only mortality at 3 years in the co-op study, that is the best study because mitral FR was not superior. In the co-op study, the mortality is 42% in 3 years, mortality. Let's take the VT ablation. We all do VT ablation to patient, and we do another VT ablation, and we do another VT ablation. There is in medicine something that's called competitive interest. It exists in a different parallel field to cardiology, oncology. There is multiple type of chemotherapy protocol you can give to a patient when you identify that the patient is have a cancer. So what do? You do tumor board. There's supposed to be a presentation in which multiple disciplines are sitting together and deciding this patient is good for CHOP chemotherapy, this patient will go to anti-CD40 combined with anti-CD20, for example. We are not there in cardiology yet, unfortunately. If a patient is coming to the electrophysiology because of VT and you have an EF of 10% and you already had 3 VT ablation in different institutions, say, but this VT we didn't have ablation in our institution, we need to give it a try. And he will go to shock after that and maybe it will be too late. If a patient is needing a mitral clip and you have an LVDD of 7.5, sometimes he gets first to the interventions, to the structural heart, he will get a mitral clip before anyone. We need to learn to do heart failure board, to sit together and say this is the right approach to this patient. Because not only that, 2 years from now, Uli, I think you mentioned it in one of your slides, we'll have omecamtiv mecarbil to patients that have what we call severe heart failure. Now there is now what the difference between severe heart failure to advanced heart failure? It starts to be tricky. Okay? So how do I choose who I'm putting on omecamtiv and who I'm putting on LVAD? We need to start having heart failure board. So not individual physician or group of physicians from one discipline taking decision rather than multidisciplinary.
Thank you. I think we have much space to the clinical case presentation. You stay here also to discuss after. And we are going to begin with the presentation of from Francisco Hernandez with when the ventricle should be is not optimal. Is not here?
Good morning, everybody. First thing, I'd like to thank the organizers for the invitation to the meeting. I really appreciate the opportunity to be here, to learn, and to share our experience with this clinical case. I decided to bring this case because it has several key RV failure elements. It supposed a challenge for us about decision and management, and we learned a lot from it. And to add some excitement, it was in the worst moment of the pandemic. Because we were here in April 2020, first wave of pandemic, and we had a 38-year-old Chinese man who was diagnosed of a non-ischemic dilated cardiomyopathy 1 year ago with no family history. He was living in Madrid the last 2 years and he didn't have a relevant past medical history, except he was a strong former drinker until 2017, but he assured not to drink anything since then. The patient had a heart failure hospitalization 4 months before the acute decompensation in the context of a flu infection. It's important to note that all of this history was managed not in our hospital but in other tertiary centers in Madrid, Hospital Clínico. 2 months before the acute decompensation, he was in functional class New Heart Association 2 to 3, tolerating low doses of the 3 classic drugs of heart failure and between 80 to 120 milligrams of furosemide daily. The follow-up was irregular to this point, and in the echo he had biventricular dysfunction. As you can see, the LV was dilated and the ejection fraction was calculated in 18%. The RV was dilated too, but the conductivity was not too bad. The TAPSE was 12 millimeters and he had a mild tricuspid regurgitation. In April 2020, he had chest pain at home and he called the emergency services. They found him conscious but hypotensive with a monomorphic ventricular tachycardia that was treated with amiodarone. The patient was admitted at the CICU of this tertiary center. He was stable in the first 6 to 12 hours and they decided to implant him an ICD as a secondary prevention. However, in the next 24 hours after the ICD implantation, he developed a profound cardiogenic shock with a biventricular dysfunction high levels of lactate, and multi-organ failure, although high doses of vasoactive drugs. So the team in charge decided to implant him a temporary vivat, concretely 2 cm pumps with sternotomy and cannulary left atria to aorta and right atria to pulmonary artery. We can discuss if it had been our first choice or we would have used a VECMO for this patient with biventricular dysfunction with unloading with a percutaneous device. But the truth is that they feel comfortable with this setting, with this temporary vivat, and they have a lot of experience with it. Also, they thought that it was a patient with a terminal heart failure and the only solution was an urgent heart transplantation. 1 week later, they called us. The patient was stable with the temporary vivat, extubated, and without drugs. In the echo, as you can see here, there was an apical LV thrombus. So, as we thought that the cardiac shock was related to the VT, we asked them to try to win the temporary support. Unfortunately, when they lowered in parallel the vivat, the blood pressure dropped, the contractility of the LV was really poor, the RV dilated, and the CVP was more than 20 millimeters of mercury. Also, it appeared suction events in the temporary LVAD, so we failed the winning test. So the bottom line is that we have a young man with a dilated cardiomyopathy in cardiac shock supported with a temporary vivat, and we failed the attempt of winning after 1 week of support. So it seemed to be a straightforward transplant indication, but it wasn't easy to do a transplant in April 2020. We didn't have ICU beds, there were problems with donors, so we deferred the transfer to our center 1 more week and we asked them for a right cath. Our surprise was the result of the right cath because the patient had severe pulmonary hypertension that we didn't expect it. With a transpulmonary gradient of 29 millimeters of mercury and more than 6 foot units, we shouldn't go ahead with the transplant. So we thought how to reverse the pulmonary hypertension with biventricular dysfunction. And we decided to try again a winning test, but in this case only the temporary RVAT in order to transfer the temporary vivat into a long-term LVAT as a bridge to candidacy to reverse the pulmonary hypertension. Besides, the RP improved in the echo and the pressures in the right cath were hopeful, as you can see here. So we put the patient on milrinone, we forced diuresis, and we got to lower the temporary RVAT to 1.2 liters per minute without instability and without suction events in the temporary LVAT. We repeated the measures that were similar to the other right cath, confirming the pulmonary hypertension, although with higher values in the right atria, as we expected, lowering the temporary RVAT. Here you have a quite good contractility of the right ventricle with this setting, with 1 liter per minute. We calculated some hemodynamic parameters, predictors of RV failure after the LVAT implantation. Some of them, like the PAPI or the Strower index, were good, and other, like the ratio between the CVP and the wedge pressure, was wrong, although we were unloading the left chambers and it was artifactual. Finally, we transferred the patient to our hospital and implanted the HARMY-3 as a bridge to candidacy to reverse the pulmonary hypertension. And how did it go? Well, there were polytransfusion during the surgery. The surgeon removed LV thrombus without too much trouble. The CPV time was 18 minutes, and the patient got out of the OR with 4,600 RPM and a flow of 3.4 liters per minute, with moderate doses of vasoactive drugs, with nitric oxide and sildenafil after 24 hours. The truth is that we plan to keep the temporary RVAT after the surgery to prevent an acute severe RV failure using a protected cannula to avoid reopening the chest to remove it. But eventually we didn't use it because the whole team considered that the RB was doing well in the OR and it wouldn't be necessary. The patient was extubated at 72 hours after removing the nitric oxide. We were able to raise the HARMY-3 up to 50 to conclude that in some cases as this one, a suboptimal RB can get better with mechanical support, with negative fluid balance, with inotropes, and the most important, with time, especially when it is related with an acute decompensation. Thank you very much and see you soon. Good morning, everybody.
Thank you very much, Frank, for your very interesting case and very successful. We move on to the next presentation.
We can ask. We can ask questions if we want.
Yeah.
Fran should be there.
Yeah, hi everybody.
Is he still there?
This is
You
late.
look-
Forget the question.
Yeah.
We don't want the question. It's already. So is Fran there? Do we have
Yeah.
Fran on Zoom?
Yes.
There he
Yeah.
is.
Hello everybody.
I have a question. It's a really terrific case. Congratulations. I'm wondering, you delayed, you bridged him with the HARMY-3 because of the lung. Did you consider using nitric oxide and sildenafil while he was on the Centromec BIVAD?
Yeah, we thought about it.
We can hear
but, yeah, can you hear me? Yeah.
No te oímos.
Sorry. Can you hear me?
No,
No.
te oímos. No. ¿Tenemos sonido?
Hello.
Si
No
no,
sound.
You look great.
si no, igual Manolo, ¿no? O Javier. ¿Tenemos un micrófono para ellos?
Hello. Hello.
¿Y el micrófono?
I'm sorry. The fact is that the patient was in another hospital. It was a referring hospital. Sometimes in our way of functioning with hospitals that have the possibility to implant short-term VADs is to keep them. We visit the patients there, but you not always have the complete freedom to manage patients. But you are right. Nitric oxide or sildenafil, when the patient was in the temporary VAD, would have been a good choice. Although the pulmonary resistance was pretty high. I don't know if that would have solved the problem.
Javier, a question. When did you took out the RVAD? 3 days after the implant of the HARMY-3, or you took it during the implant itself?
The LVAD?
The Protect Duo later.
When did you take out the R?
The RVAD.
Yeah.
It was, maybe you remember better than me, Manolo, when we explanted the right, I think it was 3 days after, more or less. Can you hear us, Fran?
Can you hear me?
It was 3 days.
No, but
Yes,
it means
yeah.
that it was, you let it rest after the surgery for a few days and then you take it out. That's what I'm asking, and it seems to be, yeah.
So you put in the Protect Duo, left it 3 days, and then
Right.
took it out, right?
That's right.
Yeah.
That's right.
And then the patient was on sildenafil afterwards with the LVAD?
Yeah, we kept him, for several weeks, maybe 6 weeks, I guess. Lola.
Excellent case. I have a question. I don't know what's the experience of any of the people on the panel or in Puerta de Hierro with Centrimac for
pulmonary hypertension reversal, because we have we had a patient last year that had a very severe pulmonary hypertension. We were trying to evaluate for heart transplant, but he had some comorbidity that we had to clear out before. So we decided to go to a bronchoscopy just to study some adenopathies or whatever. And in that scenario, he had a cardiac arrest and he ended up with a left centrimac with a very severe pulmonary hypertension. And the first intention was, okay, let's try to do nitric oxide and sildenafil. And when we were in very high doses, we repeated the right heart cath, and it was like maybe, I would say it's on top of my head, but it's like 2 months after the centrimac, and it was not reversible, and we said, what are we going to do next? Let's go for an LVAD or whatever. But then he had an infection and endocarditis due to the ICD lead, so we need to remove that. So at the end of the case, it was like 3 months, 4 months, and we decided, so now we are clear out of all these infections, let's go for an LVAD. But we repeated the right heart cath again, and he was reversible, and he could go to the transplant directly. So, but we tried to look in the literature how, cases with pulmonary hypertension reversal, because all the cases are with LVADs, and we know it's going to be reversible, but you don't repeat the right heart cath like in the last weeks, because you're going to wait anyway because they got an LVAD. So I don't know how reasonable is that, or how long do we have to wait until we go for the next step?
Yeah, I can comment on that. I think there are two phases, or maybe even 2 types of reversal. The one is where you have a high PVR just because you're hypoxic and you're congested, and you relieve the, you lower the left atrial pressure and things get better right away. And the other one is where you have an elevated PVR that's either irreversible or is reversible with treatment. And then that treatment, I think you asked about the time, right? Then the treatment will take longer. I would say at least 4 to 8 weeks. That's kind of our anecdotal experience. I do want to point out that actually the last paper that Neera and I published as first and last author just came out maybe a year ago after 10 years of writing. And in that paper, we showed that if you have this situation that you just described, that the speaker just described, the outcome after heart transplantation is still negatively impacted, even if it is reversible. The risk of RV failure is higher, and the mortality is lower at 1 year. Right. So it's reversible, but there's still something going on in that lung that's not good.
So now we go on to the next presentation. It's on long-term oxytocin device in the immediate post-life.
Good afternoon, everybody. Let's go with this interesting case. This is a 63-year-old woman with a medical history of hypertension, dyslipidemia, diabetes type 2, insulin requiring, with already an end organ damage, with moderate retinopathy, still a good renal function, not known previous heart disease, and maybe to highlight a severe asthma with a full inhaled treatment. These were the meds for these conditions. One day in September 2020, this lady called emergency services because she was referring suprasternal chest pain, and at site she was diagnosed with anterolateral wall STEMI, clip 4. So the STEMI code was activated and she was transferred to the cath lab, and she could get it around 1 hour and a half later. At that time the blood pressure decreased 60/40. A VS scan rapidly was performed. It showed severe left ventricle dysfunction. No mechanical complications, no AR, just a mild MR. So inotropic drugs along with an intra-aortic balloon pump through the right femoral artery were initiated to achieve the coronary angiography. This coronary angiography revealed a thrombotic occlusion of the proximal lat artery, along with also a severe stenosis of the left main and circumflex arteries. This stenosis could be successfully opened and released with implanting 3 drug-eluting stents, as you can see on your right. And the following days after the STEMI, the patient was somehow hemodynamically stabilized. She cleaned the lactate levels, normalized the renal function. But actually, after 6 days from the STEMI, we had patient dobutamine independent with the intra-aortic balloon pump. Also, with high flow oxygen requirements, the PF ratio was always around 200, still very high pro-VMP, around 13,000. Cardiac index of 2, PCP stack at 18, TT echo revealing left ventricular ejection fraction of 20%, anterior-apical wall akinesia, just a mild pericardial effusion, and a good contraction of the right ventricle. In the electrocardiogram, extensive anterior wall necrosis, and the platelets were going down, most likely secondary to the balloon pump. So we had clearly a patient in a intermax 3 status, and here goes the question: what would you do after 6 days after, from the STEMI in this situation? Number 1, I don't know if we have the questions to vote, or this is my slide. No. Go straight for a long-term VAT implantation as a bridge to destination therapy. Number 2, minimally invasive short-term left VAT, CentriMag left VAT as a bridge to decision, recovery maybe, or LVAT. Number 3, CentriMag, but as a bridge to heart transplantation despite diabetic and organ damage. Number 4, Impella CP through left femoral artery as a bridge to decision. Number 5, Impella 5O through left axillary artery as a bridge to decision, recovery, or maybe long-term. So feel free to vote. Okay, I see. So the dilemma seems to be 2 short-term VATs, no? Okay, what we did is to implant an Impella 5.0 through left axillary artery. We certainly discard the patient for a heart transplantation, and we somehow wanted her more recovered with a better conditions to receive a complex device. The improvement was better than expected. Actually, after 3 days from the implantation, we had the patient with a conventional nasal cannulas, and the fourth day after the implantation, she was seated in the room chair, feeling well, cheerful, and recovering muscle strength. The truth is that the following days, the test decreasing the support from the Impella failed, and they were not well tolerated by the patient. So we finally decided to implant an LVAT. So an HVAT was implanted after 10 days after the Impella, and actually the procedure was performed uneventfully through full sternotomy on pump. We left the OR with flow 2.5 liters and just a low dose of dobutamine and norepinephrine. But the fact is that the next days we had difficulty to get good flows with the HVAT, decreasing very often down to 1.7 liters and refractory to the increasing of the reps, despite the volume reflection, to highlight that the TT echo always revealed as still an IVS normal position and still good right ventricle function. And in order to get more flows with the HVAT, we were forced to increase more the volume reflection and to increase the doses of the inotropes. So this strategy ended finally to a right ventricle failure. Now we had the severe TR and a moderate, even moderate, severe MR that we didn't have before, and the PCP was confirmed that also these numbers. So we were forced to introduce percutaneous right ventricular support in the patient. At that time, we used for that we used a Centrimac with 2 venous cannulas. We use in this case 19 French through the jugular vein up to the pulmonary artery, and 25 French through the femoral vein. The right ventricle was running well in the OR, but we had, unfortunately, we had a perforation of the right lung with the wire of the pulmonary artery. So we had a huge bleeding through the drainage that luckily were still there. So we had to perform a rapid re-sternotomy. We found a little hole, just 0.5 centimeters at the hole on the parenchyma of the right lung, but the bleeding was tremendous. We didn't know why at that time, but everything made sense later, as you can see, as you will see in the next slide. We fixed the hole, just with one, 2 stitches, no more. But it didn't help the patient at all, and now we had a severe respiratory failure, so we had to intercalate a membrane oxygenator into the right ventricle in order to oxygenate the patient. And another problem that we had is that we saw it has seen before, the day before in the CCU, that the HPAD was very sensitive to the positions, even while the cardiologists were doing the TT echo, just pushing the thorax, the flow was easily changed. And we confirmed that in the OR, because just pulling and moving the rotor, we watched a tremendous change in the flows. So what we did was to pull back the rotor. We saw that pulling back the rotor towards the ribs of the left thorax, the flows improved. To get not that much, but to get 2.5 liters, we had to hold the rotor onto the ribs and hold it with the stitches to get these flows. But unfortunately, we were not able to close the chest because the flows decreased again. So we left the chest open. This is the first X-ray we had in the CCU. As you can see, a severe bilateral pulmonary edema, but more important on the right. So what we thought is that we had selective right lung perfusion. We introduced too much the pulmonary cannula towards the right lung, so we had to pull it back a little bit, 3-4 centimeters, and the edema of the right lung improved. But in 24 hours, we have a very bad situation, as you can imagine, a patient in a multi-organ failure. So what we had to decide what to do now, and what we conclude is that we had to take the patient back to the OR and switch, and with the aim to switch the right ventricular support to a VA ECMO and remove the patient from the shock. But sorry, to discard problems with the inflow cannula, we perform a TE echo before going to the OR. I don't know. Here. It seemed that the cannula maybe was, it's running, that the cannula was a little bit positioned towards too much towards the septum, but we actually didn't conclude to anything, to any conclusion, to anything significant, and so we decided, okay, we go again to the OR and try to switch to VA ECMO. But we could reposition again before implanting a VA ECMO, because we said to ourselves, okay, if we implant a VA ECMO, maybe it will be the end. We'll see. We don't expect too much for this patient, so we tried again to reposition the rotor, pulling it more back towards the left thorax and holding even strongly with stitches. Now, with this maneuver, with forcing more the pulling, let's say, we could easily get 3.5, even 4 liters. So we said, okay, let's leave everything this way and try what happens in the next days. So we could avoid the BA-ECMO, but we have a tremendous bleeding, mediastinal bleeding due to the coagulopathy, as you can imagine, so we have to pack the mediastinum and leave again the chest open. Not everything was bad news, so thankfully the flows could be kept the next days, around 3.5 liters. So it helped out the patient. She cleaned the lactates. She was tolerating the hemofiltration, so the cardiologist could make a proper volume depletion. So when this proper volume depletion was achieved, we decided to go back to our close the chest and remove the packaging of the mediastinum. It was performed 6 days after the second reposition of the rotor. But the story doesn't end here, because now we had a difficulty to clean the left thorax. Bronchoscopy showed a free bronchial tree without anything inside. I mean, nothing obstructing this bronchial tree, but the scanner showed, the CT scan showed the occupation of the left thorax, an important occupation of the left thorax, most likely from all blood clots, all blood. So the last thing we want to do is to to perform a resternotomy, because we didn't want to change the position of the rotor. So we decided, okay, we are going to perform a left thoracotomy to clean all the clots, is what we found actually. We clean all the clots, and this intervention made a big change to the patient. It made a big change to the patient. We could remove the membrane oxygenator 48 hours after the left thoracotomy, and the right ventricle support actually 7 days after the cleaning of the chest. Okay, as you can imagine, more things happen to this patient. We don't have time, but we can say that after 5 major surgeries, several complications, after 170 days in the CCU and 260 days in the hospital, she was finally discharged home. She was visited just 7 weeks ago in the external visit basis. The HVAD is running well, 3.3 liters. But we have now a problem with the right ventricle with a borderline function, moderate 3+ TR, and no MR, and just a mild AR. And now the cardiologists are trying to make the hard work to titrating the meds for this patient. This is a summary. It's a difficult patient, but this is the summary. Okay, thank you for your attention.
Thank you very much for your very excellent case and with excellent management. Any question from the audience? So we must move on to the next case. It's a non-ischemic dilated cardiomyopathy, and it's Dr. Carles Díez from Hospital Universitario de Bellvitge in Barcelona.
So thank you, Chairman, for your kind presentation. Let's see if it's fitting on the image. So I'm going to present quite a challenging case we had to face in the middle of the pandemic. I do not have any conflicts of interest. So this is about a 43-year-old patient without any remarkable medical record. He was a current smoker, and he had the medical history of a father who died on the heart transplant waiting list, but we did not have any kind of records. And the patient had a first check in year 2000, where no cardiomyopathy was seen, but then they lost follow-up. So he moved to Scotland due to job opportunities, and there he started cardiac screening. So the electrocardiogram was referred as normal, and TTA showed slightly dilated left ventricle, and ejection fraction was moderately low. On Holter monitoring, they saw non-sustained BTs, but no other remarkable things, and they performed an MRI that what they saw was the mid-wall late gadolinium enhancement with a normal RV function. At that moment, the patient wasn't with any kind of treatment, and he went back to Spain in 2016 when he started follow-up in the outpatient clinic. And at that moment, we saw no remarkable differences between the last tests, but we recommended to start a neurohormonal treatment because of the ventricular dysfunction, something that in advance I say that patient did not follow. And this was the MRI that what it showed was this left ventricular dysfunction and dilation with quite of a preserved right ventricle and the mid-wall late gadolinium enhancement. I don't have the pictures now, but you have to believe me, it was the same. So we lost the follow-up again, and 3 years later he comes back April the 15th to the ER because of new onset heart failure and with features of cardiogenic shock. At that moment, what we saw is that the patient was quite in a preserved state, but he was needing some dobutamine and IV furosemide perfusion and 45% oxygen. So, as I told you, the patient confessed to had abandoned the treatment months ago in case he ever took it at some point. But that's the initial workup, so pretty bad edema and with quite of a fast heart rhythm. Just to say that dobutamine was provoking him quite a lot of auricular tachycardias. But he resolved congestive signs in 48 hours and started on vasodilators. The vitamin was withdrawn with less than 48 hours, and diuretic tapering was feasible with conversion to oral treatment. The patient nonetheless persisted with sinus tachycardia, and we started prognostic medical treatment, but at the same time we thought that this might be a heart transplant candidate despite all the things that he had done before, but we started the diagnostic workup to make a consensus decision. Just to remark that despite he was stabilized, or what we saw that he was stabilized, he was still with quite of a high anti-protein P, quite of a high troponin T, and liver function tests weren't that good. So at some point he was not that good. That's what was happening on the monitoring. So we started oral amiodarone, and we were getting more and more nervous, and we wanted things faster and faster, but he had a heart failure relapse 7 days after what we called a stabilization. That was his treatment at that moment, apart from furosemide. So at that point, what we can see is that he had worsening renal failure, the lactate was about to rise, and he had TP altered, ALT also, and NT-proBNP was rising again, and the fast echo showed that he had really severe biventricular dysfunction with regurgitations and biventricular congestion, but no other complications. So we decided to get him to the ICU for close monitoring and complete the study and diagnostic workup for heart transplant. So at that moment, he was with milrinone, 0.3 micrograms, and nitroprusiate and IV furosemide. The BP was medium BP 70, but the cardiac index was really low, 1.5, output 3.5, PAP 50, 2938, and CBP was 25, and wedge was 24. The urine output was not that good, considering all the meds he was on. It's not that bad, but was not that good, but he cleaned the lactates. At that moment, it was quite of a high vascular resistance, both in the pulmonary and the systemic territories. So we also performed a right ventricle function test with the hemodynamic parameters, and what we saw is a very low PEPI and a stroke index from the right ventricle, and equalized CBP and wedge pressure. So at that moment, while we were escalating drugs, the patient presented quite of a fast ventricular tachycardia that fortunately was self-limited, but it indicated that the patient was deteriorating, so we get an intra-aortic balloon pump, and fortunately with this, and we could lower a bit milrinone, and the patient got quite of a better cardiac index and output, and the pressures dropped down quite a bit. The urine output was getting better, and more or less he had the same problems regarding liver function. But pulmonary resistance dropped, so the patient was eligible for heart transplant if we thought about that, but the right ventricle was still not that good. So this was more or less the echo with severe biventricular dysfunction, moderate to severe MR and TRs, and the right ventricle was not that good. It was already spheric. We tested TAPC, also the Doppler tissue, and also the strain of the free wall of the right ventricle. And anyway, most of the ratios were not favorable for a good outcome after LVAD placement for the RVs. And we decided, this was explained before, but what we saw is that was a moderate to high risk of RV failure. At that time, we received also the genetic testing of the patient. It was a filament sheath, frame sheath mutation. That means that it has a pretty bad prognosis, and it was already the time that these ventricles were not going to go anymore. And well, at that point, that is my question. So, how would you mechanically support this patient? There's some tricks here, because you have to remember, I'm going to do some hints, you have to remember the period we were and how in the old clinical picture. So we could go for LVAD with temporary RV support. This was explained by Fran, and it could be manageable, and it could be a good decision. We could go with short-term biventricular Thentrimag and get him to the emergency waiting list. We could go for percutaneous short-term support with Impella, minimally invasive, and go to the emergency waiting list. We know that in Spain, that means you have about 14 days to get him transplanted. And we could go for total artificial heart, long-term support. We know how it goes, we know how tricky it is, but we could go there, or if there are other options. So the ball goes for 41, and most of you would go for the emergency list for short-term with Thentrimag. Should we go forward? Yeah. So that was the problem there. We have talked about this before, the Corona crisis. So we knew that the patient had good things to go for long-term support. So it was a young patient, and also we expected a long time on waiting list because of a elevated predicted heart rate ratio. He was A blood type, the pandemic and previous non-adherence. We didn't know that much the patient. That would be a good thing to do. But at the same time, the RV was not that good. There were BTs. It was a ASIM-like DCM, and the Intermax profile was not that good, altered liver function. But there was no frailty to overcome, no sensitization. So we decided to innovate, considering that it was not that easy to get a heart for this patient. So our final decision was to go for a short-term Thentrimag biventricular support and include it in the emergency waiting list, but we interpose an X-core cannula from the pumps to the cannula. So in POD2, the patient was weaned from the respirator, so RV was 4.1, LV was 4.3, and urine output was fine, and kidney function was fine. So we included him to the waiting list, emergency 0 here, so it must be at least 1 UNOS. So on POD4, the patient was stable, heparin ratio was about 2, no bleeding, and the patient was rehabilitating, but 4 weeks after the including on the emergency list, there were no any kind of offerings. Remember, we were like in April to May, so at that moment, he presented an altered level of consciousness with fluctuating stupor, and we made a CT scan, and that's what we had. Multi-territory ischemic strokes, and we saw that there were thrombi and fibrin deposits in the LV circuit in between the BA and the interposition of the cannula. There was a place of shear pressures and quite a lot of blood interposing, so maybe that would explain the problem. And at that moment, that's not another question, but we went together and thought, okay, we go now for LVAD and we get every support. What we done, it's not the best decision, and we maintain the biventricular support, and we stitch to this mid to long-term support and get him in the list, or switch to total artificial heart right now. So at that moment, what we decided is to check for intercardiac thrombi. Of course, there were not, and we tried to raise anticoagulation and change the LV circuit and the rotor, but the patient persisted having strokes. We checked that he had no antibodies against heparin, and at least he didn't have any bleeding on the head. So, but he was progressing neurologically, aphasia, mutism, and right upper extremity paresis. So we were escalating drugs. We went into vivalirudin, aspirin, and we got a membrane oxygenator as a filter on the left side of the rotor. And at the 10th day after the first stroke, he gained stability. We could rise TTPR to 2.5, and we switched to biventricular X-core. So we know that's not the best hemocompatibility device, taking into account that the patient was having lots of strokes, but that's what we planned, so we stick to the plan. And overall, the patient had a good post-operative clinical course when switching the devices, and we were under vivalirudin on TTPR 2.5, and despite an aspirin, but despite that, the patient was having thrombi on the right chamber and he had fibrin deposits on the left chamber. We are familiar with that with X-core, so we escalated to dipyridamole together with the rest of the anticoagulants, and we changed the right chamber, and we checked that the platelet elimination was 90%. Fortunately, after that, the patient had no more stroke events, no more bleeding, and could rehabilitate. Thanks to all our friends in the ICU that gave me this picture about the patient and for his effort. And after 19 days of admission almost, we got a heart for the patient. And fortunately, the intervention wasn't eventful. There was no important bleeding. The function of the graft was nice, and there were low-dose VA drugs. So the clinical course was good. He could be started on CNIs and mycophenolate, steroids, and basiliximab. No rejection, good graft function, and discharged home after POD 30 from the heart transplant and 4 months after hospital admission. So this is the last greeting card he sent to us, and the movement of his new heart, pretty nice. And just as a take-home messages that I take or I learned from this case with all my colleagues is that there are different types of cardiomyopathies, and each one may preclude determinate MCS strategies, LV morphology, but also physiology. Maybe arrhythmias could be a problem, and it is indeed a problem. NIDCM allows distinct MCS strategies, including continuous flow LVAD, yet it broadly depends on the ongoing clinical situation and in patient's previous clinical profile. It is really important to make shared decisions with multidisciplinary teams. This is paramount, and it is important to upfront plan potential alternative pathways. In case of adverse event, this is crucial, and of course, to remark, it is one of my jobs that genetic testings in non-ischemic DCM is important because it allows to better interpret the clinical cause of the cardiomyopathy, and of course, infer prognostic outcomes both for patients and family members. Thank you very much.
Thank you. Is there any question for this presentation? No?
Well, it is our case, but anyway, I would just like to remark, what would you change now that's in retrospect regarding management of this patient?
Yeah.
For example, especially the anticoagulation. I mean,
yeah.
What we currently do with these things.
What I think we have changed is that from now on we go much earlier to vivalirudin, for example, as we get better hemocompatibility with this patient. After 48 hours, if we don't have any bleeding or any remarkable problem, we change to vivalirudin in this kind of patients. That was friend fire, Joe.
Thank you very much for the presentation. Exactly for bivalirudin, I would like to ask you. We know that the financial difference in the prices are argatroban and bivalirudin. Bivalirudin is more expensive. Did you have any problem in the hospital to approve it in the pharmacology department for that patient because he was weeks or months on bivalirudin, no?
Yeah, we actually are not having problems with this kind of patients because we've went too far on spending money that it's not that much into heparin or bivalirudin, and we just go for this for patients with short but mid-term support. And argatroban is also policy here. We use it just in patients with severe renal dysfunction. If not, we prefer to go to bivalirudin. We are more comfortable with that.
Right. I don't exactly remember the beginning of the case, but when you presented it, I was wondering what was the decision to go for Centromac Bivat rather than ECMO to transplant?
Yeah.
As a quick peripheral ECMO and then quick transplant, so to speak.
The problem here was the allocation problem. So we were in the middle of the COVID and we were expecting long-term waiting. So we decided to go to something that was more consistent in time.
And here it's huge. Yeah. Another short question is, the patient before even in his course, he had some VT. And then before he got the LVAD, he got a VT. Do you routinely, do VT ablation combined with the LVAD implant in the operating room when you map the heart?
We have never done that. We've got a few cases of VT in the setting of LVAD, implant or pre-implant. In one case, we did it before, I remember the case, and in the other case, it was after that, but not simultaneously in the OR. That is quite interesting, by the way. But
that's what we tend to do. So the advantage of doing it in the OR, that you can do both epicardial and endocardial. Yeah. And you do a map, and the map actually takes, right now we measure how much time it takes, between 7 to 9 minutes, because the chest is open. They can really run the equipment that they need in order to get a good map.
Yeah, I think that for this patient, arrhythmias did not help on the hemodynamic profile.
So that's
that is a very interesting approach.
More questions? We will finish with the last presentation. This is Jaume Pons from the hospital Son Espasas in Mallorca. And he's going to talk us about the hypertrophic myocardiopathy.
Thank you very much. Thank you very much for the invitation. I'm glad to be here today, and I want to especially thank the Advanced Heart Failure team here in Beibice for the incredible support that give us managing our advanced heart failure. So I'm going to present this hypertrophic cardiomyopathy case. This is now today 50-year-old woman. She has hypertrophic cardiomyopathy, non-obstructive, many years ago, stable 45% left ventricular ejection fraction and normal coronary angiogram. She had a causal mutation in myosin binding protein. And during follow-up, the maximum wall thickness was 21 in inferior septal wall, and we did a cardiac MRI, and we found leg gadolinium enhancement in anterior and inferior wall. She had a family history of sudden cardiac death, and because of that, we decided to put a defibrillator in 2014. She had paroxysmal lateral fibrillation, but she did well up-titrating beta blockers. So she was long-term asymptomatic, anticoagulated, high doses of bisoprolol and valsartan. The problem, one of the main problems, started on April 2019. She had left breast cancer and in a really advanced situation. So the problem was also that we couldn't offer the best chemotherapy for her because of cardiotoxicity, but she did really well on the other treatment, and she had a really good response, and was a great surprise that the tumor had a great reduction at the time of mastectomy in September 2019, and the oncologists were really happy, and we were really happy with that scenario. She needs radiotherapy, and we have to remove the ICD on the left part, and we re-implanted the ICD once the radiotherapy was finished. So she evolved well after that oncological treatment and that oncological process, but she deteriorated from the cardiological point of view. She was not stable, she was in class 2, and left ventricular ejection fraction was about 35–40%. At that time we decided to implement pharmacological treatment, and we get on all the recommendations, but we couldn't get the maximal doses because of low blood pressure. She stabilized till January 2021, and she came rapidly worsening with dyspnea and class 3–4, relatively euvolemic, and severe left ventricular dysfunction, 30% left ventricular ejection fraction. The left ventricle was dilated and a restrictive physiology, restrictive filling pattern we found there. So at that time we believed that we wouldn't get any long-term benefit from improving medical treatment, and we decided to admit her for heart transplant evaluation. We did all the tests, she was free from malignancy, we couldn't find any contraindication, any absolute contraindication for heart transplantation. Blood tests were always normal. We did a right heart cath, and she was on low output situation. Cardiac output was 2.6, cardiac index was 1.5, and high pulmonary pressure, wedge pressure, and central venous pressure. Performing also, looking at the right ventricles, the predictors for right ventricular failure for LVAD implantation were not too bad. So we decided to discuss the case with our colleagues here in Babice Hospital, knowing that she was not a good candidate for heart transplant because of breast cancer. If we look at recommendations, you need 5 years cancer-free survival prior to consideration for heart transplantation. So we thought probably she was a good candidate to LVAD therapy on bridge to candidacy. She was stabilized, she was discharged and improved, pushing medical therapy. She was close follow-up, stable in class 3, and she was in Intermax 4, and as Dr. Lebron explained before, we think that probably a better implant in a good situation when you don't have a lot of experiences is our center than waiting things to happen. So we discussed the case in our heart team meeting, and we planned the implant. The patient was admitted, she went on intensive care unit, and she had a pulmonary artery monitoring, and she was on high CVP, high wedge pressure, and high pulmonary artery pressure. So we start preconditioning with inotropes, low doses of the vitamin plus vasodilator plus furosemide, and we switch on Milrinone 24 hours prior to implant. She had the LVAD, the HeartMate 3, without problems during the surgery, and we went on off pump with Milrinone bolus plus the vitamin plus low doses of norepinephrine, NO plus iloprost, and 4,400 speed of the pump with a flow 3.3, 3.5. Before that, we were concerned that mechanical support in hypertrophic cardiomyopathy and restrictive physiology is a challenge, and you can have more section events, that pushes you to decrease pump speed, and you can have more thromboembolic events. But looking at our case, it was not really that scenario. The LV cavity was big, and we didn't have obstruction, and the patient was stable and was in Intermax 4, so we decided that was a good case for our center. The patient was extubated 7 hours after. She was hypertensive, which was a good scenario for us. 28 hours withdrawal of the vitamin, and we could start it on oral vasodilators and anticoagulation and aspirin without problems. 7 days stay in the intensive care unit, and she went to the hospital floor uneventful. She tolerated really well up-titration of all standard advanced heart failure medical treatment, and 9 days after she was discharged. And nowadays, 10 months later, the patient is uneventful, doing a nearly normal life, free from malignancy, tolerating typical medical treatment. The pump is at 4,900 speed with 3.84 liters. We didn't the ramp test with transthoracic echo because the images were not so good, but we optimized our pump with transesophageal. And we hope we will discuss again the case with our colleagues in Baby Che a couple of years if she's still being well, and she will probably be eligible for heart transplant. Thank you very much.
Thank you very much, Dr. Pons, for this very nice, challenging case. Any question for the audience?
I didn't know that in Mallorca you can have a heart failure. I thought it's heaven.
Thank you. So thank you very much for your attention for this, I think, has been a terrific session. Doctor, yo
Sí, simplemente, ¿no? La comida es en el Esperia, que es el hotel
Hello? Anybody there?
Hello?
Hello?
Uh,
Can you hear me?
Wait a minute, Dr. Smith.
Yes, I can hear you. Can you hear me? Can you hear me?
Yes. Good
Excellent.
afternoon.
Good afternoon.
Can you share your computer in order to check if it's okay?
Yes, I can do that. All good?
Yes, perfect. So,
You
we
can.
expect.
Do you see my slides now? Yes.
Yes. It's okay.
Okay.
We expect to start about 3 or 3 o'clock.
Is there a chance that I can be a little bit earlier because I might have to go to the operation theater as well?
Okay, I will inform to Dr. Joe. I think that now they are gone to the lunch.
Okay, when are they back?
It's planned to start again at 3:15 to
Oh,
3.
okay. So okay, no problem. I see. So yes, so I will check in again at 3:45 then. Okay.
Okay, thank you.
Okay.
See you
Thanks.
later.
Bye.
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 Sí, claro, claro que sí. Sí, sí, donde quieras. ¿Qué tal, Ana? ¿Cómo estás? Porque el Jan Smito, claro. Sí.
Hello?
The first speaker has not able to come here with us, but we are going to connect with him. It's a great pleasure for me to introduce Dr. Professor John Smito from Germany, from Hanover Medical School. And he's going to talk us about key points to consider during the implant and intraoperable management when consider sternotomy versus thoracotomy. Dr. Smito, can you hear us?
Yes, I can hear you well, and don't know how many people listen to me, but it's a great pleasure to be.
Excuse me, Dr. Smito. We can hear you very well. Okay, now, Dr. Smito.
Buenos días.
We have a little problem with the audio.
No. Here we go. I share my screen.
Yes, perfect. Okay, you can start.
Yes, buenos dias, ladies and gentlemen. It's a great pleasure for me to be invited at this great conference. Unfortunately, I cannot be with you. Omicron numbers explode and are still quite high, and travel restrictions do not allow me to come, but I can clearly see that you have a great meeting, and I would have loved to come to Barcelona. Next time I will come for sure. Best regards to my friends Albert and Jose and the whole team. I had the honor to support you last year. It's 1 year ago when I was there the last time. And today I would like to talk about key points to consider during the implantation and intraoperative management, when to consider sternotomy versus thoracotomy. The history is quite clear. The most often implanted assist device worldwide is nowadays the HeartMate 3. And we are proud that the worldwide first implantation was performed by me and my team already in the year 2014 here at Hanover Medical School. We also published this in the Journal of Heart Lung Transplantation already 2015. But it's a success story, not because of us here in Hanover. It's even more a success story because the pump is excellent and because of the patient is still doing fine. I talked this morning with Kurt, our patient Kurt, and even 7.5 years later, he's still doing fine. And that's why we do this. That's why LVAD implantations are extremely important. But he was not the only patient which we implanted in the year 2014. Sorry, 1 second. Bitte einmal Hanke anrufen, ich komme dann gleich. Danke. He was not the only patient in the year 2014. There were 8 patients during the CE mark trial of the HeartMate 3 who were implanted in Hanover 2014. And the great news, which we published in the year 2021, last year, is that in this group, all patients survived. So the upper line of the Kaplan-Meier survival curve is not the frame of the other curves. It's a real survival curve of all 8 patients who were implanted 2014 here at Hannover Medical School with the HeartMate 3. And even 7 years later, we are proud to present a 100% survival rate. And it's even more important that these patients are doing well without any pump thrombosis. Also, not only being alive, but also they are improved by clinical status given the NYHA classification 1, 2, 3, 4. And all patients were coming out of NYHA classification 3B and 4 and are nowadays in NYHA 1 and 2. The quality of life improved significantly over time, pre and post-operatively, and remained stable over the years. And the 6 months, that's how the patient looks like today. He is always traveling in winter to Spain. Probably this is the good German-Spanish connection, that he lives in summer in Germany and the winter in Spain, in the south of Spain, because the climate is much better. And he always mentioned to me that he would not have had such a great life, and he would not have done this 50-50 life, Germany-Spain, if he would not have received this assist device. So the key why I was invited to this great conference is to share our experience here in Hanover with you, and how to make all those results visible and possible. And I tried to separate my talk into 4 characteristics and 4 categories. Of course, it's clear that every patient has a pre and intra and post-operative care, and even a late post-operative care. But today I was specifically asked to look at tips and tricks for the intraoperative course, and what are the key factors for such a 100% long-term survival rate. And preoperative, I think the most important things are that not only the surgeons decide what to do and when to do, but it needs to be an interdisciplinary decision by a specialized heart failure team. They don't implant the devices too early, but also not too late. I mean, it's an easy sentence, but it's heavy if you think about it. The patient who is Intermax 5, 6, 7 or higher is probably too good, too stable. These patients are at high risk to complain about the driveline, complain about this, that, and all the side effects, and will not really benefit from such a device. But starting from Intermax 4 and 3, those patients are more or less perfect, as the indications of our 100% survival curve in 2014 indicate. But if you are too late with patients and multiple organ failure, with liver failure, kidney failure, lung failure, heart failure, brain is not functioning and resuscitated, maybe these are patients who are quite late or too late, and then the survival rates are not as good, and you have a high mortality rate. So the balance and timing is crucial for the key to success. Sometimes, sometimes it's also important to be brave to say no, because my key factor for success here in Hanover, when I took over the program at the beginning, was that there were some test patients sent which were already nearly dead, and we refused them and said, no, this is too late, we cannot do it. And it's always tough to say yes, but it's sometimes even harder to say no. And it's important to optimize everything before going to the OR. So the congestion to the lung, liver congestion, impairment of kidney function, you can improve the condition of the patients significantly by medications, by taking out fluid extraction, taking out by excellent fluid volume management, by even catecholamines, by ECMO support to reperfuse the patients. Maybe impeller devices are important, such as unloading the left ventricle to reduce the congestion to the lungs and perfuse all vital organs. Also, it's important to bridge to decide. Here in Hanover, we have the impeller 5.5, for example, where you can bridge the patient with a 30-day approval for the impeller 5.5 pump. So you have lots of time to decide, to clear up the fog, to see whether the neurological symptoms are cleared and the neurological function is intact, and also kidney, liver, and lung function can recover. And within the time frame of 1, 2, 3 weeks, it should be enough to decide to bridge to LVAD, or even to recover the hearts and explant such a bridge to decision device. So what are the key disadvantages for fluid sternotomies? Of course, everybody knows it's a huge trauma, it's a huge incision, so it's a huge trauma. It's a high risk of bleeding. You need high amount of blood transfusions. There's a high risk of pericardial tamponade based on bleeding and the pericardium, and a pericardial tamponade leading to thoracotomies. There's a higher risk of right heart failure. There's also a higher risk of wound infection. This is the basis for my discussion later. And if you look at the less invasive approach, you can clearly see that you can, by small incisions at the upper hemisternotomy and also mini thoracotomy, you can reduce the trauma, you can reduce the opening of the pericardium, so RV overdilation is still not possible, and the heart is kept into the original position. So a kinking of the heart is not possible, especially patients who are previously operated with, for example, CABG surgery. It's a big benefit to use this technique, because you just have to open the thoracotomy and the pericardium anterior to the LV apex, and then you can suture your ring to the LV apex. The outflow graft can be tunneled through the left pleural cavity, and the dissection of the whole heart and the dissemination of the anatomical structures is totally reduced. And especially in those redo cases, there's a big advantage to use this technique based on the fact that the bleeding is reduced, the wound trauma is reduced, so the wound surface is not as big, and the heart is still kept into the original adhesions. And this is a very important factor, because once you keep the heart into the original adhesions, these patients cannot suffer from a pericardial tamponade and are always hemodynamically way more stable compared to the full sternotomy patients. That's how it looks like. This was a typical case. It's a DCM patient, just to give you some impressions. This technique was initially developed already 10 years ago for the HVAD, which is not available anymore, but we also modified this Hanover technique, which is already 10 years old now, to the first HeartMate 3 implantations, which we did already in 2015. And you open the thoracotomy and suture the apical shearing ring to the LV apex. Here, this is the bigger HeartMate 3 ring. There's already a smaller ring available just for thoracotomies. And to use this ring, I think it's a very safe operation. We insert the pump into the LV apex and tunnel the outflow graft through the pleural cavity. One big benefit of this technique is, if I go back one slide, if you look how the position of the LV is into the left ventricle, then it is already the final position. You have the LVAD in place and you do not have to dislocate the pump. And you can already ensure at the time of implantation a perfect inflow cannula positioning. This is extremely important, because some people say, why is your right heart failure incidence lower than in other centers? This is not only because of less invasive approaches. Of course, it's dependent on on our experience and its preoperative preparation of the patient, but it's also the way more improved inflow cannula positioning, and I think this is also a key part of our success. And the proof is, for example, here in the X-ray, a typical patient which has a defibrillator and even a CRTD device in place, and who got the LVAD, and the LVAD is with the inflow cannula looking towards the mitral valve and is unloading, thereby unloading the left ventricle perfectly. You see that there are only three wires to close the chest in such a patient, and so the wound trauma is reduced, the bleeding is reduced, the hemodynamic stability is improved, and the patient is really clinically benefiting from such approach. So I can summarize what are the advantages, and there are at least 80, 90 papers already out there. There's one paper missing and one study missing. That's a prospective randomized trial. This is still not available in this field, but there are meta-analyses and lots of papers in the field out there. And all in summary is that the trauma is reduced, the bleeding risk is reduced, thereby the demand for the use of blood transfusions is reduced, especially the redo cases are associated with 0% pericardial tamponade. The risk to suffer from right heart failure is induced, and as a consequence, the permanent RVAD need is also reduced. Jose, when he kindly invited me to give this speech, asked specifically to give some tips and tricks, and when would you go for a less invasive surgery and when would you not do it. I try to summarize it, at least with this small slide. Concomitant procedures sometimes do not allow less invasive surgery, meaning that if you need to work in parallel at the tricuspid valve, or you want to do several bypass grafts in addition, then it's not possible, and it's not recommended to use the LES technique. But it's also important to say, if a patient is Intermax 4 or 5 and extremely stable and not previously operated, and the right heart function preoperatively is extremely good and stable, then you can perform both cases. But the more sick the right heart is, the more a patient would benefit from such a technique. So severe right heart failure cases can successfully perform with LES, and I would strongly recommend to use it. If you want to have a chance that this patient should not end with RVAD in parallel, then you should go for LES technique. From my point of view, the redo cases benefit probably most because you don't have to unpack the whole heart and you can keep the heart in the adhesions, the wound trauma is reduced, the bleeding is reduced, and no pericardial tamponade can occur. Nowadays, with COVID, it's a little bit more difficult, but in a globalized world, learning curves are not really necessary anymore. So avoid learning curves. There we can teach, consult, proctor, and whatever, learn from the experience centers who did plenty of hundreds of such cases. And I can tell you, I myself burnt my hands many times. It's not necessary to do the same mistakes again. But also the industry sees the LES as the future. There are lots of innovations coming from the industry, and they support all those new technologies, especially with the upcoming future devices like HeartMate 4, 5, 6, and HeartMate 7. There's a clear miniaturization trend for sure. So the Abbott, for example, provides also a mini apical cuff, and they also have new coring tools which are underway here and there, and it's just a question of time to use all these devices, that we can facilitate the use of less invasive surgeries. And once there's the HeartMate 4 available, sooner or later, this is for sure, no doubt, that 90% of all patients are going to be operated with smaller incisions. More than 100 centers worldwide visited me. I'm the one in the back operating, so lots of centers, even from the United States and all over the world, came already here to Hannover to learn from our experience. And I still remember my good experience at Bellwitge Hospital, and was great being there. Hopefully the patient is still doing fine, and kind regards to all of you. Thank you very much for giving me the honor. For sure, Albert, we will see each other quite soon again once COVID allows it. From my point of view, the future for VAD surgery is less invasive, and sooner or later, LES will replace full sternotomy. We don't have to reinvent the stone wheels again. The future is in front of us and not in the back. But it's also important to select the right patient at the right time. And I think from my point of view, these are the most important clinical factors when to clearly implant an assist device. A patient who is suffering from severe end-stage heart failure, NUA4 and Intermax 3, with poor functional capacity, recurrent hospitalizations, intolerance to medical therapy, non-responders to CRTD systems, patients who underwent already ICD shocks with end organ function and the need of inotropic therapy are at least those patients where you have to carefully, or should carefully, look for permanent solutions. I can tell you that the lakes are full of fishes, but the eagle needs to present a perfect timing. It's timing, timing, and timing to select the fishes. It does not help to have thousands of fishes in a lake if you are not good at timing. And to share more of our experiences, I would like to welcome all of you in Hanover. In May 24th to 27th, we will celebrate the EUMS, the European Mechanical Circulatory Support Summit here in Herrenhausen, Castle Herrenhausen in Hanover. And I would like to really see most of you in an in-person meeting here in Hanover. And thank you very much again for inviting me. It was a great pleasure and honor, and feel free to ask any questions. Thank you very much.
Thank you very much, Professor Schmidto, for your nice talk. Professor Schmidto said that he must go to operating room, so we have 5 minutes for short questions. Is there any question on the audience? If not, I want to make a question. You have explained several advantages for the mini approach, but if you want to select one, the most important advantage for the mini approach, what is this for you?
I think the prevention of right heart failure, or the avoidance of right heart failure, is a big advantage, because if a patient suffers from right heart failure, then the quality of life is low, the congestion to the liver is still there, the the cardiac output is not really improved. And so right heart failure is a clear, very important factor to be avoided. And whatever you can do to avoid right heart failure, do it. So everything which is preoperatively, intraoperatively, or postoperatively helpful to avoid right heart failure is important for the patient to benefit most, because the LVAD is just unloading the left ventricle, and most often the right heart is kept alone. And so whatever we can do medically, management techniques, or surgical techniques to prevent right heart failure, I think is for the patient the most important factor.
Hi, Dr. Schmitto. What about the pain related to the thoracotomy? Because that is something the patients do complain much more than with a normal sternotomy. How can that influence, for example, respiratory function and weaning off the ventilator?
Excellent question, because I heard this complaint a lot, and many of other colleagues are mentioning it. Don't know whether German patients are indolent, but in clinical practice, I don't see clearly more pain. We investigated it internally. Our patients were the same, requested the same amount of drugs to prevent pain. But of course, it's logical. The ribs are painful, and if you operate at the ribs, then it hurts more than a sternotomy. So from a human factor, I would also support your argument. One trick is that you clearly need to avoid fracturing the ribs. If you internally increase the incision and dissect the intercostal muscles from the ribs, the stress to the ribs is avoided. And that's, of course, one important factor which you can see and learn here how we do it internally. It's tough to teach online, but it's important to take the stress away from the ribs. And with our retractors, we try to avoid the fracturing of the ribs. If a rib is fractured, then it hurts. But during the last 90 assist device implantations, no rib fractured. It's important to avoid this. And if a rib is not fractured, then the pain is more or less the same.
Jan, thank you very much for being here in our meeting. I'm Dr. Miralles. We know us from the previous sessions. I want to ask you, what are your explanations, because you say that always with this approach, you preserve the right ventricle function. And which is the clear explanation for that? I would like to know a little bit of that. Thanks.
Yes. There are several factors. One factor is that the pericardium does have physiological function. God made the pericardium to protect the heart, and that there's a liquid inside the pericardial effusion to let the heart pump smoothly. If you perform a full sternotomy in very sick patients with LV failure, congestion to the lung, and already stress to the right ventricle, and you open the pericardium, then the pericardium, which functions as a restraint device, is opened, and you can have a RV overdilation. The RV overdilation is like actin and myosin fibers are binding, but if you overdilate it and they are not functioning and not binding anymore, they will never get back. And once there's a RV overdilation is occurring, then the RV failure is already started. And once the RV is failing, it's extremely tough to come back. That's one factor. The second factor is, in a full sternotomy case, the heart needs to be lifted out of the original position, get the sutures of the apical sewing ring and the pump inserted, and you place it back. All this lifting of the heart is kinking the right ventricle, is squeezing and smashing the right ventricle. It's also kinking the right ventricular outflow tract. It might lead to kinkings of the right coronary artery, and all these mechanical manipulations are not good for the RV. And the third thing is, if you have the less invasive surgery, you perform a more or less no-touch technique to the heart. You're suturing the sewing ring to the apical, to the LV apex, and the performance of the and the placement of the inflow cannula of the LVAD is always in parallel to the septum at the right place, and you are not having the inflow cannula to the septum. It's not sucking there. Then there is a better inflow position, leads to less septum shift to the left side, thereby not stressing the right ventricle. And all these factors, this is the third reason. And the fourth is that you are opening the pericardium at the tip of the apex, and the LVAD is placed very smoothly without stress. If you implant the LVAD with a full sternotomy and you place the LVAD down to the left down corner, then the inflow and the pump is squeezing and pushing the LVAD towards the aortic valve. So if you just have an open pericardium there and it's loose and it's just smoothly placed there, then it's another factor. So the summary of 1, 2, 3, 4, 5 arguments is at least clinically significant.
Yes, what do you think about the approach to the aorta through a right minithoracectomy in place of the hemisternotomy? What do you think about the approach?
Excellent question, because this is also a modification of our publication and of our initial technique. I always say that the influence on the right ventricle is the same. Whatever you are used to at your center, if you perform minimal invasive aortic valve replacements, and you are used to a right minithoracotomy, and you are used to this access, keep on doing this access. If you're used to do an upper hemisternotomy there, do this. From my point of view, clinically and regarding right heart symptoms, it's more or less the same. The overall or the most important aspect for placement of the LVADs is the left anterior thoracotomy compared to a full sternotomy. But what you do for the upper hemisternotomy or right thoracotomy, it's more or less the same.
Just last question, Professor Smith.
Hello, Professor Smith. I would like to ask you, what is your approach when, let's say, a patient undergoes a minimal invasive LVAD implantation, but you might know or not pre-op that needs something else to be done, let's say, like a replacement of the aortic valve, or suddenly there is an intra-atrial septum with a big shunt. What is your approach when that happens intraoperatively? Thank you.
Also, excellent question. To be honest, never happened with all my 1,000 assist devices because and that's important because the planning of the operation is maybe also part of my success here in Hanover. That if you have a redo case, perform all necessary diagnostics, even a CT scan, that you don't run into open knife, that you know what to expect. Aortic valve surgery can be also performed in parallel with the upper hemisternotomy, but the key is most often tricuspid valve. And there my suggestion is that tricuspid regurgitation grade 3 should always be performed in parallel. Grade 1 to 2 is probably secondary to high PA pressures and LV congestion, LV dysfunction and congestion to the lungs. So this will remodel, but tricuspid valve grade 3 or insufficiency grade 3 should be performed in parallel, and then we go directly with a full sternotomy.
Thank you.
Okay. Thank you very much, Professor Smith, again, and we wait you here the next edition of your meeting. And thank you. Goodbye.
Thank you.
Thank
Goodbye.
you.
Thank you very much.
Okay. Thank you very much. So we move on the second speaker of this afternoon, Ana Hurtado. She's from A Coruña, here from Spain, and she works in the critical care unit of the Hartfield Hospital in London. She's going to talk to us about the management of the main complications of bad patients in the immediate postoperative period. Thank you very much.
Thank you. Thank you for the introduction, and thank you again for inviting me to come here. It's an honor to join this fantastic meeting that seems to get better in each edition, so congratulations. I've been asked to cover the topic about the immediate postoperative complications after the LVAD implantation. And these are the list of complications that we can face, but I'm going to cover today vasoplegia, bleeding, and RV failure. This is an algorithm I particularly like because it's quite helpful for, sorry, it seems that it's not. Yeah, so this is the algorithm I was talking about. I particularly like this one because it helps you to follow what is wrong with the patient when suddenly a patient with an LVAD is hypotensive. So when we cover or we talk about vasoplegia, we need to know what is vasoplegia for any patient, and particularly for a patient after an LVAD implantation. And basically means a lack of in the vasomotor tone, which is refractory to catecholamine therapy. What we will see in a patient with vasoplegia is that suddenly they have a low blood pressure or a progressive lower blood pressure with a normal or even higher than normal LVAD flow. Is due to obviously a low systemic vascular resistance, and the CVP can be variable. Is relatively frequent after cardiac surgery, and is particularly even more frequent after an LVAD implantation, going up to 30 to 40% of the patients. They might develop some degree of vasoplegia. In this paper, they review a significant number of patients after LVAD, 252, and they found that half of the patients, they develop some degree of vasoplegia, being moderate and severe vasoplegia present in the 22.6% of the patients. And looking at the predictors of vasoplegia post-LVAD implantations, they found that the MELT score, the need of vasopressor support pre-LVAD implant, a low systolic or a low MAP pre-implant, a higher creatinine, and also a prolonged or longer length of stay before the implant, and a longer bypass time are predictors of the development of vasoplegia post-LVAD implantation. And also vasoplegia is associated with a higher mortality in these patients. And not just, a lot of complications can be related with development of vasoplegia post-LVAD implantation, including major bleeding, right heart failure, respiratory failure, and as I said before, mortality and even a stroke. And how do we manage patients who develop vasoplegia post an LVAD? We know that there's a lack of responsiveness of vasopressor therapy, and it's for multiple factors, including the lack of the response from the receptors in the vascular smooth muscle, the depletion of the steroid stores, and an increase in the nitric oxide production. So our first line is vasopressors. This is the list of options that we could use. And noradrenaline is usually the most common and the first-line treatment for vasoplegia. That can be also added vasopressin and epinephrine. Also, in some of the patients who develop severe vasoplegia, we will add a shock dose of steroids. Just to mention methylene blue, because it's something that is being used off-label post-cardiac surgery in patients who develop severe vasoplegia, and it's based on the ability of the methylene blue to counteract the vasodilatation through the nitric oxide. There is a lacking of supporting data. This is how usually we administer methylene blue as a salvage therapy, basically, as a bolus, or it could be even as a continuous infusion, because the half-life is 5 to 6 hours, and it seems to be beneficial when it's used as a continuous infusion. This is a recent publication from last year where they specifically look at the use of methylene blue post-LVAD. It's a small group of patients, just 27, and they found that methylene blue did not improve the outcome of the patients, but there was a reduction in the noradrenaline requirement, and that reduction was maintained over the time. We look at our data at Herfield, the use of methylene blue post-surgical patients, and specifically for LVAD patients, we had 11 patients where we used methylene blue for refractory vasoplegia, and we found the same thing that in this paper recently published, which was there was no change in the outcome, but there was a significant reduction in the noradrenaline requirement after the administration of methylene blue. And just to mention this study, the Cyclone LVAD study, which is running at the moment at our hospital. We are leading the project, and we look at the use of the cytosorb, which is a filter that can perform hemoadsorption and removal of cytokines, and it's based on the idea that vasoplegia is secondary to the CS response after or during the LVAD implantation. It seems that the interleukin, and the most famous even after COVID, is the interleukin-6, which might play a role in the development of vasoplegia in these patients. So what we are doing is basically using the cytosorb filter during the bypass in theaters, and in some patients we will continue with the cytosorb when they get to intensive care, and then we will measure the interleukin levels pre and post the use of the cytosorb. As a secondary outcome, we will look into the incidence of vasoplegia, right ventricular failure, renal failure, mechanical ventilation, length of stay, and mortality of our patients. And we hope, that's not for sure, but we might have some results by next year. We hope so. Just moving from the topic of vasoplegia to bleeding is the most frequent adverse event in our patients, and a quarter of the patients post-LVAD, at least in the old series, they might need some re-exploration because of bleeding. It's responsible of up to 9% of the mortality, and that's why we know that anticoagulation should be completely reversed after the implantation, after having the bypass. And we do full clotting tests, and we use also TEC. The location of the bleeding, as expected, is mediastinal, thoracic pleural space, chest wall, and GI tract. When bleeding happens, there is a delay of recovery and an increase in the length of stay of our patients. It can lead to hemodynamic compromise, cardiac tamponade, and also we have to remember that transfusion in these patients might lead to more sensitization, right ventricular failure, longer waiting time for heart transplant. And what are the factors that can lead to the increase of let's say, the need of transfusion might increase mortality. When we talk about transfusion, significant transfusion leading to complications in these patients, we are talking about the need to transfuse 5 or more units of blood intraoperatively or postoperatively. And it's not just related with this, also these patients, they might have a higher rate of complications as infection, increased length of stay, and as I said before, an increased mortality. And the bleeding can happen even within the first 14 days post-implant. And we, in this paper, they review risk factors for early bleeding in these patients, and they found that patients supported on ECMO pre-implant and with low platelet count pre or post-implant, they have a higher risk of bleeding post-LVAD implantation. This is what we do, our protocol. We wait until the patient at least 12 hours post-implant before we start and consider starting heparin. And when the drainage through the chest drains is low. We use unfractional heparin. We follow or we monitor the anticoagulation effect by anti-10A. Initially a low target, and then we increase it over the time. And when the chest drains are removed is when we add aspirin. If a bleeding happens, a severe bleeding happens when the patient is already anticoagulated, we will stop anticoagulation, we will reverse to normalize the clotting factors, and obviously there is a risk of thrombosis that we have to accept because the risk of bleeding is probably higher, at least in the perioperative period. We have to remember that if there's a bleeding and the patient is hypovolemic, there's a risk of suction events, cardiac tamponade, RV failure, and so on. And what we will see when the patient develops a cardiac tamponade after an LVAD is obviously low blood pressure, a low LVAD flow, a high CVP, and then on echo we will find a collapse that usually is It's more frequent to see it around the right cavities, but as you can see in this patient, we had a big collection collapse in the left atrium and the left ventricle. And moving on from bleeding to RV failure, I mean, it's been discussed already today. The incidence is something in between 20 to 40% in the patients post-LVAD, and is associated with increased morbidity, increased mortality, short and long-term mortality, increased length of stay, and lower rates of successful bringing the patients to heart transplantation. And we have to remember, just a reminder, that it's not just the immediately post-operative period. Up to more than 10% of our patients, they might develop a late RV failure, which is more than 30 days post-implant. And it also carries a variable prognosis. It's very difficult to evaluate the right ventricular function after an LVAD, and despite that, there are many changes that can increase the risk or make the patient develop RV failure. There's also a lot of potential for the right ventricle to improve, and not everything is necessarily bad. But when we look at the physiopathology and why the right ventricle fails after the implantation of an LVAD, if we follow this by the numbers, at the bottom you see first thing that happens is an increase of the preload for the right ventricle, because the LVAD itself is giving a higher cardiac output that is going through the right cavities as well. Also, the patient might have a bleeding, might need blood transfusion fluids, so that increases the preload. The next thing that happens is a change in the septal position because of the offloading of the left side, and there's a lack or a loss of the contribution of the interventricular septum to the right ventricular function. It could be ischemic injury, poor preservation of the right ventricle, dilatation of the tricuspid valve, increase of the tricuspid regurgitation. Also, the PVR might be already high, and it can get even higher if the patient needs a massive transfusion, or there is hypoxia and other added lung problems during and after the surgery, and also the development of arrhythmias. As I said, it's difficult to predict, and it carries a very high mortality. I think the discussion about the intra-op optimization has been already done. It seems that the minimizing the cardiopulmonary bypass time, minimal invasive approach, careful with the bleeding, perhaps the consideration in some patients that delayed sternal closure, and maintaining a good ventilatory and acid-base balance is very important for the success of these patients, and a careful assessment of the problems that might happen, and optimization of the LVAD flows to avoid added problems. There are different definitions of what is RV failure after an LVAD implantation, but what we will see clinically is a patient, again, hypotensive with low LVAD flows, with a high CVP, a low PAPI, and then when we do an echo is when we see that the right ventricle is dilated, the function has got worse, there is more TR, and also the flattened interventricular septum, or even bulging towards the left side. And what can we do medically to optimize these patients? Well, we have to address preload, afterload, and contractility to optimize the right ventricle. Preload, we will try to optimize the fluid status of the patient, try to, with diuresis, renal replacement therapy, and achieve a low, or let's say I put here 15 millimeters of mercurium, but a low CVP. Address the afterload for the right ventricle to help with nitric oxide or sildenafil, and then optimize the contractility with inotropic support. The options are, we all know the options in terms of inotropes. We can escalate the dose of them, we can increase or optimize or add more pulmonary vasodilators. We have a preference for milrinone as inotropic support, but we also have to remember that it's a non-selective, it can cause non-selective vasodilatation, which is not just for the pulmonary vascular system, also for the systemic circulation, which can end up in vasoplegia and other problems. Inhaled milrinone could be an option. Also, avoid hypoxia, because it will lead to pulmonary vasoconstriction, increase the PVR, and more RV dysfunction. When the patient develops renal failure and oliguria and end up with fluid overloaded, is also can develop worsening right ventricular function and treat aggressively and soon any tachyarrhythmia. But when the medical treatment fails, we have to use mechanical circulatory support, and the options are a few, but quite limited, I will say. Impella RP, we have used it in our institution. Protect Duo cannula also is another option that we have used. But I think the best and the more physiological option, and at least for me, my favorite, is the venopulmonary RVAT. Maintains the transpulmonary flow, offloads selectively the right cavities, but it needs to be implanted through surgery. It can be direct cannulation, dacron graft to the PA, and then central cannulation to the right atrium or peripheral through the IVC. And when we do it early or plan the implantation of an RVAT, it seems that it doesn't affect the outcome of our patient, which is very important. This is a publication from a few years ago from our group at Herfield, where we review a significant number of patients post-LVAD, 152. The need of RVAD was in 23% of the patients, being predictors, patient being female with higher bilirubin and a previous sternotomy. And in our group of patients, the RVAD did not affect the survival of the patient or the possibility for transplantation. But sadly, despite the expertise and the planning, sometimes our patients, they go through the multi-device support pathway, which sadly, sometimes it happens. And just to finish a couple of cases quickly, this is a young female girl who developed DCM postpartum, ended up with an LVAD implanted in 2016, and post-implant she ended up in chronic dialysis, sadly. Recently, or more recently, she developed aortic regurgitation. She was having her dialysis, and then for logistic reasons mainly, she tested positive for COVID, so she couldn't have her dialysis at her normal, regular place, ended up coming to the hospital, and then by luck, probably, we got in to assess her better. So we thought that the AR was worse, and she was probably on borderline or low cardiac output at that stage. So we decided to perform a tissue AVR on her. It was 5 years after the LVAD implant. So she underwent the tissue AVR, and sadly they couldn't come off bypass, and she needed an RVAD at this stage. So she came to ITU with her LVAD and the RVAD implanted. And just to show you, the first echo is a few days later on full flow of RVAD, 4.5 liters. The second one now is when we tried to just wing by 1 liter the RVAD, and it did not, I mean, the right ventricle did not like it at all. So we optimized the patient medically, we offloaded her aggressively with the filter, with aggressive negative balance, increased dose of milrinone, we kept her on nitric oxide, and 2-3 days later, finally we managed to win the RVAD flow to 1 liter, and despite not looking the best, it was enough for her to come off RVAD. She had no other complications after that surgery. She was kept on milrinone. She needed noradrenaline and vasopressin post-RVAD explantation because she developed vasoplegia, but everything went well, and she's still in our ITU recovering with a tracheostomy, but I think she's going to get over all these problems. And this second case is just a typical patient post-DCM who underwent a HVAD through a minimal invasive approach, thoracotomies. It seems that he developed anaphylaxis when coming off bypass. There was a moment I thought in our hospital we have the higher rate of protamine anaphylaxis, but I think in this patient and many others it's probably a degree of RV failure. We blame other factors, but probably there was already RV failure in theater. The patient came out of theater without mechanical circulatory support, just with the LVAD and significant amount of inotropes, pulmonary vasodilators, noradrenaline and vasopressin. And he deteriorated a few hours later. He was hypotensive, we were escalating the dose of inotropes and vasopressors, he developed worsening metabolic acidosis, and finally the LVAD flow dropped to a low 1.5 liters. Following again this algorithm, the patient had a high CVP, we did an echo, and the right ventricle was clearly failing. With a TAPSE that was clearly reduced, there was more TR, the septum was neutral and shifting towards the left, and despite the medical treatment, we had to put the patient on ECMO at the bedside because he was crashing and it was 3 a.m. in the morning, and sometimes these things happen because not everything is available at that time of the night. But as you can see here, the flow on the RVAD was, on the ECMO was 3.6, but obviously we are bypassing the heart, so there was no flow almost through the LVAD, which is increased the risk of thrombosis. So the patient a few hours later was transferred to the cath lab. We placed an impeller RP and the ECMO was removed. Thinking, and we talked today about hemolysis. The hemolysis was very, very significant with the patient on the impeller RP and the LVAD, but at the same time the right ventricle did recover, and we managed to remove the impeller RP on day 6 of support. When we thought that everything was fine and the patient was stable, had a tracheostomy, suddenly we had this problem. The flow on the LVAD was dropping. There was this abnormal flow that we identified on the screen, and then we did an echo, and the patient obviously had a big pericardial effusion with a big pleural effusion, and he was tamponade. Went to theater, everything was sorted. He had a very prolonged ITU stay, but finally he did recover, and he went home after a few months in the hospital. And just to summarize my talk, there's a continuity of events, and it's not just one, and they all lead to each other, so we have to plan and expect these problems to happen. Vasoplegia is not uncommon. There are risk factors, but I think in most cases it's unavoidable. And right ventricle is the most common cause of circulatory failure post-LVAD. Perhaps the minimal invasive approach is the future for all the centers implanting LVADs. Bleeding is another big problem, and we have to be careful with anticoagulation, completely reversed after the implant. When these problems happen, they carry a very high morbidity and mortality. Estimating the risk for these patients to develop complications is very difficult, and perhaps the most important thing is the optimization pre-LVAD. And we have to anticipate all these events and know what to do and plan what to do next. It's a multidisciplinary team approach, and it's what improves the outcome of our patients. Thank you very much.
Thank you, Anna, for this nice and interesting presentation. Any question from the audience? Okay. Yo.
Thank you for a great presentation. I saw you're starting to use inhaled milrinone.
Yeah.
Can you tell us a little bit more about that experience?
In terms of, sorry, can you repeat that?
Can you talk as it working? Is it's
in some patients, we all know we've been there. We use milrinone because for us it's our favorite inotrope. But some of them, especially in the immediate postoperative period, they develop severe vasoplegia, which you end up having to stop the milrinone. So we have used iloprost, inhaled iloprost. Prostacyclin is not our preference because of vasoplegia as well, and also bleeding complications related with the use of this. We use nitric oxide, and we have used the combination of milrinone with good effects. I don't have full results, but there are no side effects. There is no systemic vasodilatation when you use it inhaled. The use we use is 5 milligrams inhaled every 4 to 6 hours. Obviously, the half-life inhaled is a bit more unpredictable rather than when we use it intravenously, but it has been successful in some of the patients. But I must say that when you need to escalate the pulmonary vasodilators and you get to this point, it's likely that the patient has got RV failure and needs something else to be done.
Yeah, great cases. Quick question: when you after you fixed the aortic valve in this patient, how did you manage? What were your plans regarding speed of the assist device? What happened at that point?
During the surgery, you mean? I mean, it was
speed before and after.
When came off bypass, at that moment, obviously they tried to use a lower speed than when they started, but her right ventricle was quite poor before having the tissue AVR. So I think it was kind of expected that the right ventricle was going to fail. They didn't really try very hard. They immediately, they had one brief attempt to come off bypass, and the right ventricle was clearly ballooning, and they just implanted the NARBAT. She was a very young, I mean, she's a very young girl, and we didn't want to take any risk with her.
Only one quick question, bleeding. The first 3 hours, chest tube output is always on this kind of the patient is increased. We use the crystalloids to compensate the bulimia, but sometimes the question is, will you correct or give prophylactically at the moment of the chest closure, fibrinogen, platelets, or plasma, just before they start the bleeding, or you will wait 3 hours and react if the bleeding onset?
What we do is we use a lot of TEC, thromboelastography, and the patient will come out of theater with completely normalized TEC. So that is what we do. So we will correct as per TEC results.
Oh, I have a curiosity, I'm a surgeon. Which RBAT configuration did they choose in the first clinical case? Which RBAT configuration? Which right ventricular support did the surgeon choose in the OR to support the first clinical case?
In this case,
yeah, in the case of the aortic valve
it was
replacement.
central cannulation, central right atrial drainage into PA with direct cannulation. There was no dacron graft or peripheral cannulation. It was all central.
Okay, just to know. Thank you.
Yes.
Thank you for your talk. Only one question. Do you do something with the medical treatment to try to avoid vasoplegia? Like, I don't know, don't give any medication before surgery or something as a routine, I don't know.
You mean to prevent?
To avoid vasoplegia, because when you are in the OR and you have the vasoplegia, maybe it's just difficult to know how to manage, or how do you do that?
I think intraoperatively it will be managed as any other patient with noradrenaline and vasopressin, and it's by the time that they get to intensive care is when you need to escalate the dose of vasopressin.
Yeah, I was thinking about, you know, like more elective patients that you are going to do an LVAD implant, and sometimes they say before surgery maybe you don't have to give, I don't know, like ACE inhibitors or whatever before surgery because it may avoid vasoplegia, which is not really, I don't know if it's a reality. You don't do anything with that.
No, not really, no.
And when you manage vasoplegia after the surgery, usually you go on vasopressin before and then...
Yeah, we use, I mean, obviously in UK we have vasopressin that is not available in Spain, so we escalate dose of noradrenaline to not a very high dose, and immediately we use vasopressin. And then we will reach a not very high level is when we already probably add steroids, because these long-term patients and chronic, they all have some lack of cortisol and steroids.
And methylene blue would be like the third step of the management.
But we have used successfully methylene blue. Despite the lack of evidence, in clinical practice, you see that it's effective. But obviously, methylene blue can also increase temporarily the PVR, so you have to be careful. But we have used it successfully in some of these patients.
Well, we are going to continue with the clinical cases. The clinical cases are about the challenge during the LVAD implant and postoperative management. And the first speaker is our resident. It's a pleasure to introduce Dr. Javier Tejero, who is going to talk about the implant using thoracotomy. Javier.
Okay. Perfect. Well, good afternoon, everybody. First, I want to say thanks for the organizer for inviting me to be part of this meeting. Just said that, as we don't have much time, I will dive into it. We're in front of a 57-year-old male patient who was a former smoker. He has previous history of hypertension, dyslipidemia, and type 2 diabetes that was diagnosed when he was just 18 years old, that nowadays has both macrovascular and microvascular complications. He has also a long-term story of ischemic myocardiopathy that began 16 years ago with an inferior STEMI. At the moment, they performed a coronarography. They saw a 100 chronic occlusion of the right coronary artery, so they could do nothing at the moment. 3 years later, he presented with an arterial STEMI. At the moment, he had an acute 100% occlusion of the left anterior descending artery, and the mates from the interventionalist implanted an stent there. 5 years later, he presented again with a non-STEMI. At that moment, he had a 3-vessel disease, so the patient was in discussion with the multidisciplinary team, and they thought he was a good candidate for surgery. So at the moment, they perform a right mammary artery bypass to the left anterior descending artery and the left mammary artery to the first obtuse marginal. After that, the patient was stable, but 5 years ago, as a left ventricular ejection fracture dysfunction was detected, the defibrillator was implanted. He, after that, remained also stable. 2 years ago, transthoracic echocardiography was performed, having a 40% left ventricular ejection fraction, a mild MR, and mild pulmonary hypertension. Everything went fine till 1 year ago when we had 2 hospital readmissions, one because of heart failure and one because of acute pulmonary edema. At the moment, they found that he had a new severe mitral regurgitation and a mitral cleft was implanted. He evolved well. He also had some history of paroxysmal atrial fibrillation. And 3 months ago, he had an upgrade to a resynchronization therapy. But despite that, in the last 2 months, he had new hospital readmissions. In the new echocardiography, he had a 19% left ventricular ejection fraction and moderate mitral regurgitation. And to be able to discharge him home, they had to start weekly involuntary levosimendan infusions. As other comorbidities, he had a stroke 17 years ago with no consequences, and 3 years ago, an aortobifemoral bypass was performed because of peripheral obliterative vasculopathy. And at that moment, the patient was on the maximum dose he tolerated of heart failure treatment. We can see here one X-ray, the last X-ray he was done before leaving the hospital. We can see some cardiomegaly and some signs of redistribution. And in the blood test, we see some level of mild kidney function, the proBNP of 5,000, normal liver function, normal coagulation, and mild anemia. So, in view of a patient with this medical history, being in telemaxic situation, what would you go for? Complete the study and put him on elective heart transplantation list? Try to do some approach through percutaneous coronary intervention, or maybe try to reduce the mitral regurgitation? Go for an LVAD implantation through the median sternotomy to have full exposure of the heart and the vessels and to work more comfortable? On try a minimal invasive LVAD implantation. Oh. No, well, okay. There was no question, so it's okay. So, okay, that was more or less easy, also with the title. So, to get ready for that, we perform a coronary CT scan to show us that both mammary were working fine, and as we can see, the right mammary artery was crossing in the mediastinum in front of the more distal part of the ascending aorta, and that the left mammary was at the proximal segment close to the sternum and then went down to the artery, pulmonary artery on the left side of the heart. We also performed a right ventricle assessment with transthoracic echo, where we saw a normal right ventricle size with a good TAPSE. And moreover, we performed the pulmonary catheterization that showed us some degree of pulmonary hypertension, but with good parameter for the right ventricle. Moreover, with levosimendan and nitroprusside, we could see that the pulmonary hypertension was reversible. So, that's just what we did. We did elective implantation of hardware. 3 days before, he came to the hospital to do the optimization of the volemics and of the right ventricle. And after that, we went for the surgery through first an upper mini sternotomy through the second right intercostal space. We dissected the aorta, preparing that for central cannulation after to do the anastomose of the outflow graft. We identified the right mammary artery and could preserve it. We did a percutaneous puncture of the femoral vein, and then we went for the anterior left thoracotomy for the special of the heart, so the ring attached the system, and the tunnelization of the outflow graft from one orifice to the other. The total cardiopulmonary bypass was just 45 minutes. At the end of the surgery, the pump was working fine for 2 liters, and the patient was hemodynamically stable with low dose of the butamine, and nitroprusside, and inhaled nitric oxide. The following days after the LVAD implantation, the patient had a good recovery, keeping hemodynamic stability. So he could tolerate progressive weaning of inotropic support and a start of heart failure medication. He was intubated in the first 24 hours after the surgery, but already he had some complications in this period. One of it was an acute kidney injury with some worsening of the renal function, but with no need of replacement therapy. The main complication was that when he was awake, he didn't saw, in fact, he had a problem with his vision, so we performed a cranial CT, and we saw that he had a bilateral occipital stroke that left him with left homonymous hemianopsia. And after that, he presented an episode of Charles Bonnet syndrome. And the following days, he also had a transient ischemic attack with no consequences. Despite this, the global evolution was fine, and he could be discharged from the coronary unit on the 22nd postoperative day. For the rest of the hospitalization period, he was hemodynamically stable, except for one episode of low-flow pump, and it was related to hypovolemic. So with the reduction of the diuretic and some volume, it would recover and had no more problem. He had a good physical recovery. The kidney function was even better than the one he had previously to the LVAD implantation. We performed a transthoracic echo prior to discharge that showed a 10% left ventricle ejection fraction, a good right ventricle function, no valvulopathies, and the interventricular septum was centered. So the patient was discharged home on the 44th postoperative day. And 7 months after that, the patient is having a good recovery with no events and no need for interventions. And this is something what he looked like before leaving the hospital. Thank you for your time.
Okay, congratulations for the class. Any question? Okay.
I understand if you ask the most questions, you get a nice bottle of wine tonight. Is that correct? No. Quick question. Amazing case. How did you go on bypass? Like, where did you cannulate for that? And second, I think it's an amazing case. Where did you cannulate for that? And what if something had gone wrong? What are your exit strategies in this patient? I think none, but I'm not a surgeon. So very bold. Thank you.
Well, we did the arterial cannulation through the aorta, almost in the arch, the aortic arch, and the percutaneous suspension of the femoral vein. That was for the cannulation. And Dr. Mirage was the main surgeon at the moment. I don't know what was in his head, as I was dressing. I don't know what we have done. We have a real big problem. We were really being careful, but probably just go through a full sternotomy, cross fingers, and be careful that everything is fine.
Yeah. Amazing case. Fantastic.
You have a question here?
Thank you very much for the case. It's amazing what you did with the mini sternotomy. I was wondering, in light of the bilateral stroke, did this patient have significant carotid artery disease pre-op? Is it something that could have been...
Yeah, I don't want to assure you 100%, but I think he didn't have carotid pathologies. He had the vasculopathy for the legs, but not really not in the carotid at the moment. Yeah, it was okay. Well, confirmed.
Alexander?
It's our fault.
Alexander?
Thank you.
Christian. Last quick question. How you make sure that the tunneling of the outflow graft and the pleura, which is blind, it's not twisting? You use the hardware, it's only 10 millimeter graft. It's very easy.
Yeah.
Something which you never recognize initially.
Yeah, well, the graph has a line on it, and this is the guide. I mean, there's a black line on the top heart, so we were sure that the red line was, the black line was on the same part, on the thoracotomy and the upper sternotomy. And the full 360 degree twist is difficult. I mean, just with the fingers, you could touch one part to the other. So it just through the graph is more or less okay, and with the black line, you can be quite confident that it's like this. It's okay.
So you didn't use that technique that fill the graft completely with the saline, with the pressure, and then tunnel it is like a pressured graft to avoid any twisting. It's just a question of tricks, what you use.
I didn't understand you, sorry.
The technique you described is like you orient your fingers, but it's still risk that you have a 360 degrees.
Yeah, but
one of the techniques is fill the graft with a saline clamp, with those clamps, and if the graft is under the pressure, you will never twist it.
Okay, no, I think it's a good option. That was our second patient done through minimal invasive case. Maybe that's a good option to have the full graft full, so you can check it.
And this is true. You can see from the thoracotomy all the trajectory of the graft, and there is no problem. You can see almost everything, and then there is no doubt about the kinking of the graft. There is no. This is true that in this case we did from the left pleura. It was a little, we had some doubts when we had to transverse to the aorta, because there is sometimes the first part of the left mammary artery. But it was easy, it was not a problem.
No, what we do to answer also to your question is that we perform first the implantation of the inflow cannula. We start the pump, like that you inflate the outflow graft, and you are sure that you have a perfect flow, because before to perform the anastomosis, we perform the purge, we rinse the tube, we see that the flow is okay, and after we perform the anastomosis. And doing that, you are sure that there is no kinking. And for sure, the black line could be helpful, but in our experience, 2 times, okay. The black line was totally twist.
We were lucky then.
I think that it's a very good approach for this specific patient, but let me be a little bit provocative, because I would like to discuss with Jan Smith, because the reasons that he said that the mini thoracotomy avoid the wraith failure that you questioned to him, I think that are very theoretically, because if they are real, we have wraith failure in all patients that we have full sternotomy, or even in off-pump surgery, we put the heart in a lot of positions, and we don't have any problem of wraith failure. It's my
point of view.
Because Javier, what is our approach for LVAD implantations in our institution? The usual approach?
Well, the usual approach, the median sternotomy, no, like 99%, 99.9%, and they do fine.
Okay, thank you very much.
Thank you.
Last question, short question.
Just a small comment to say that, to be honest, performing implantation with an LVAD was easy by a small thoracotomy, but with an little bit difficult because it's bigger, and not just the pump, but also the outflow tract, because the connection of the outflow to the pump is quite big.
Wide, yeah.
And after, when you want to do it by a small thoracotomy, it's a little bit difficult. And sometimes it's necessary to have a large thoracotomy. So I think it makes a difference, because the minimal invasive approach, with HVAD, okay, but with artmetry, when the thoracotomy is like the sternotomy, I don't know. I believe, but...
Okay, yes, thank you very much. We have to move to the next case. She's the Dr. Susana Costa from the Centro Hospitalar Universitario de Coimbra, Portugal. And she's going to present a case about the cardiomyopathy with severe pulmonary hypertension. Thank you very much.
Good afternoon, dear colleagues. Let me present this case of a 69-year-old male with no significant comorbidities. He has an ischemic dilated cardiomyopathy that was diagnosed 13 years ago. He was followed in a secondary hospital, implanted an ICD for primary prevention, and he has his first admission for acute heart failure 8 years after the first diagnosis. 1 year later, in 2019, he was referred to our hospital, at that time to the outpatient clinics. He was not under optimal medical therapy, so we started him on ARNIs and up-titrated the other neurohormonal medication. We also did a genetic testing because it was not done before, and it revealed a mutation in filamin C gene. In 2020, he had another admission for acute heart failure that we treated with IV diuretics and levosimendan. At admission, he had an NT-proBNP of 3,000 and mild kidney dysfunction. The ECG was on sinus rhythm with left bundle branch block with QRS over 160. The CPET, the VO2 max was 15. The TTE had a biventricular dysfunction, and the right heart catheterization we did showed a low cardiac output and also a combined pre- and post-capillary pulmonary hypertension. We did a VQ lung scan and also a pulmonary function test to exclude other causes, other components of pulmonary hypertension, but they were quite normal. At that time, the patient was under moderate dose of diuretics and moderate dose of ARNI, and the other medications were tolerated at the maximum doses. So at that time, we decided to do an upgrade from the ICD to CRTD, and also we started on sildenafil since the PVR was over 5. In 2021, he had 2 readmissions for acute heart failure, at that treated again with levosimendan and diuretics. In the last one at admission, he had NT-proBNP over 5,000 and also moderate renal dysfunction and also liver dysfunction, so cardiorenal hepatic syndrome. After compensation in this admission, he repeated a CPET and the VO2 max was under 13. And this was his echo, severe left ventricular dysfunction with an EF of 19, at least moderate mitral regurgitation. And regarding the RV assessment, there are some parameters that made us suspect of RV dysfunction and a moderate risk of RV failure. He had a TAPS of 14, S prime of 80, and a FAC of 31. Otherwise, he had not the RV diameter was okay, and he had a RV-RA gradient of 44. We repeated the right heart catheterization and after compensation with diuretics and levosimendan, and it was not good. He had a PVR of 4.9 with a CVP of 7, a wedge of 16, and a mean pulmonary artery pressure of 31 with a very low cardiac index. So this is a low output state, and also confirmed the pre- and post-capillary pulmonary hypertension. We intended to do a vasoreactive test with dobutamine and nitroprussate. With dobutamine, the PVR went down to 3, so, and the cardiac index went up to 2.5, so it didn't, and since the wedge was normal, it didn't went to nitroprussate. Regarding other parameters of RV dysfunction, the liver function tests and hemoglobin were normal. He had slightly elevated INR. If you look at the table at the right side, the hemodynamic parameters of RV dysfunction was quite good. He has a right ventricular stroke wall index of 500, CVP to wedge relation of 0.4, and a PAPI index of 3.7. So we discussed this case in our RT meeting. This is an Intermax 4 patient, a frequent flyer. It's not an Intermax 3. We was not doing levosimendan every week in the outpatient clinics. So this patient, despite the 69-year-old age, he was a very good mental status, also family support, and also social conditions. So we thought with this vasoreactive that was positive, we thought he could be transplanted, or LVAD implantation was another option, and we discussed this. And that meeting we decided to go for LVAD implantation. We could discharge the patient. You can see that he was under high dose of diuretics, sequential nephron blockade with also furosemide plus metolazone, and the other modifying disease drugs were not anymore tolerated in the maximum doses, but we had to reduce them a lot. At admission, we admit the patient for LVAD implantation, and this guy, he doesn't complain so much, so he arrived and he said he is okay, but when we evaluate him, he had the NT-proBNP was over 9,000. He has never had any value like this, and the creatinine was 2. He was in AF, atrial fibrillation. Previously, he had just one episode of paroxysmal AF many years ago, so this was new for the patient. And when we put the Schwann guns on the patients, we found this. We had a mean pulmonary artery pressure of 49 and a wedge of 35 with PVR of 5 and very low cardiac index and very high systemic vascular resistance. So this is my question. What do you do at this time? Would you defer the LVAD implantation to compensate these patients, or we will do electrical cardioversion plus high-dose IV diuretics? Would you preconditioning the patient with levosimendan perfusion, or would you do electrical cardioversion plus inotropic and vasodilator perfusions?
Very difficult question and difficult discussion.
So, is it done? May I continue? I cannot. Okay. So we didn't postpone the LVAD implantation, so we decided to go to sedation and electrical cardioversion, and we started the patient on milrinone and sodium nitroprusside perfusion, and the results were remarkable. I think the patient was also very anxious for the LVAD implantation, and that might be also an explanation for these results, because after these measures, the pulmonary artery mean pressure went down to 25, the wedge to 21, the PVC, the CVP went down from 16 to 5, and the cardiac index went up to 2, and also the pulmonary and systemic resistance went down. So we decided to go forward with the LVAD implantation. During the procedure, the patient was under inhaled nitric oxide, also dobutamine and initially milrinone, and then dobutamine and norepinephrine. And at time he went out the OR, the LVAD pump speed was 4,300, and the pump flow was 3.4. As you can see in the echo, there was a mild mitral regurgitation, but because of the RV, we wanted to go slow with this. So in the post-op period, the patient was under mechanical ventilation for 4 days, and during this period he also did nitric oxide. The dobutamine was, and norepinephrine, they were weaned at day 4 and milrinone at day 5. He was under initially high-dose IV diuretics, and during the admission we did electrical cardioversion for 3 times. Sorry. We started sildenafil therapy at day 4 after weaning mechanical ventilation and nitric oxide, and we could start heart failure therapy at day 7 along with rehabilitation. As you can see in the echo video, we had some difficulties like balancing the diuretic dose. He had a mild pulmonary pleural effusion, but then he had also some suction events with hypotension. When he went to the bathroom, he had flow events. So we ended up increasing slowly the rotations up to the pump speed up to 4,900 RPMs, and when we discharged the patient at day 25, actually the patient went home with no diuretics at all. At follow-up, this patient has now 4 months of follow-up. During the follow-up period, he was followed almost at first months, one time a week. He had a mild, at the beginning, mild mitral regurgitation that he did not when he was discharged, so the RPMs were increased slowly, and now he has not what is there, but 5,500 RPMs with a flow more or less 4.8 liters per minute with no mitral regurg at all, and RV function is still low. He has a TAPSE of 14, but with a small RV, small inferior vena cava, with no need for diuretics. We repeated the right arterization, and these are the measures. Normal PA, pulmonary artery mean pressure of 12, normal wedge and normal CVP, and also pulmonary vascular resistance of 1.8. At this time, the patient now is under almost full dose of disease-modifying therapy, which includes all 4 classes of drugs, and he tolerates those drugs quite well. And finally, to finish my presentation, I would like to thank Drs. Joe and Miralles, not only for the invitations to be here, but especially for being with us and supporting us in with this patient that actually was our first LVAD implantation. So thank you very much.
Thank you very much. Some controversial question, short question. Several centers use epinephrine or adrenaline in the post-op of these patients, especially when they have any degree of right ventricular failure.
We usually use norepinephrine.
Only norepinephrine?
Usually, yes. If we need adrenaline, we also use it, but usually we start with norepinephrine.
Mm-hmm.
Yes.
Okay.
But actually, the right ventricle went better than we expected.
For this case, you know, looking at the entire trajectory, the biggest thing that changed was he was now unloaded. The LV was unloaded, yes. I should say, effectively for a period of 4 months. And before, we never really had a normal wedge pressure, probably as an outpatient. After optimization, if you do a right heart cath, maybe you got a wedge of 16, 14. But I bet he was walking around perpetually with an overloaded LV. And I wonder, with these hemodynamics, would you continue him on sildenafil or take him off of it? I'm not sure he even needs it anymore, the sildenafil. Because the etiology of his right heart failure, which was left heart failure, yes, has been effectively addressed with an LVAD at this point.
Yes, this was an ambulatory cardiogenic shock patient, because in the physical examination and us talking with the patient, he doesn't complain so much, but hemodynamics was very bad. Your question is a very good question. So we did not reduce sildenafil therapy. I don't know. I don't have an answer for that. Maybe we can.
Yeah, I totally agree with that. I had the same question. You could look at it 2 ways. You could say he's doing well. You don't want to rock the boat. But on this high dose sildenafil, you can also have increased bleeding risk. Anecdotally, that's the case. So I would also not be shy to,
try to
slowly wean it.
Okay, let's do it.
Is there any more question? No? Okay. Well, the last clinical case is going to be presented by Alexander Stepanenko from the Hospital Universitario Clínico de Valladolid, and he's going to talk us about the complications in the postoperative period. Thank you, Alexander.
Thank you. Good afternoon, chairmen, ladies and gentlemen. First of all, I'd like to thank the organizing committee for the opportunity to present our interesting case from the north of Castilla. I will speak about acute respiratory failure after LVAD implantation. It's not frequent, but it's a very serious situation with increased morbidity and mortality. The universal definition from Intermax and also applied to academic research community, or actual definition of that, is only inability to wean from the respirator within the 6 days. Even it's not specified if you need to reintubate, and then it's difficult to make respiratory weaning later. If you look in the historical data starting from HeartMate 1 pulse-field device, HeartMate 2, hardware, and HeartMate 3, the incidence of respiratory failure with this definition is decreasing. However, it still be in the range between up to 20%. In the recent Intermax report, 6% of the patients presented respiratory failure in the postoperative period, and this cohort of the patients presents 2.5-fold increased risk for death in the first year. Of course, predictors is the shock, Intermax level 1, 2, previous surgery, may be related to transfusion, atrial arrhythmia, right ventricle dysfunction, chronic lung disease, problem of the parenchymal and diffusion disturbances, and chronic kidney disease, maybe in the first 72 hours, problem of the volume control. So our case is acromegaly patient, giant, almost 2 meters height, in 36 kilograms of weight, presented in 2008, first diagnosis of the dilative cardiomyopathy, negative genetic study. He underwent implant of the defibrillator in the same year, and he was symptomatic for several episodes of the ventricular tachycardia with different antiarrhythmic treatment, finally with amiodarone and low dose of bisoprolol. Our group evaluated him 3 years ago for a transplant, and due to enormous body size, even for Spain, it's very difficult to find a suitable donor organ. And the recommendation was try to reduce the body weight less than 125 kilograms. Unfortunately, in the autumn of 2019, he started to deteriorate and received his first levosimendan. We re-evaluate the case and look for transplantability, again look for right ventricle function and end organ function. We estimate risk for right ventricle failure as low, and I'm sorry the video is not working from the presentation. I will present you manually. Right ventricle is trigonal shaped with well circumferential and shortening. CVP is low. Left ventricle is dilated. You see that apical part is trabeculated, sort of like non-compaction in this way. And we estimated, based on the cath lab data, clinical data, and echocardiographic data, his risk for right ventricle failure as low, and underwent a scheduled surgery. We use the SU and core technique, very thick trabeculated myocardium in the zone of the apical cannula. Standardized come off from CPB using the oxynitric, adrenal milrinone, even the pulmonary pressure were low, and noradrenaline to maintain the systemic pressure. He went to the ICU after uneventful surgery with the flow of 4.5 liters. The right pleura was opened occasionally and the chest tube placed. We use his defibrillator to pace him because in the surgery he presented some episodes of the ventricular tachycardia. And even coming to the ICU, he presented a relative hypoxemia with a low PAFI. No mediastinal bleeding from the chest tube in the first hours. We started to perform a weaning from a respirator. We awake him. He maintained in the pressure support ventilation more or less adequate oxygenation. And 8 hours later, we extubate him and put him in the non-invasive high-flow nasal cannula, which permitting us more or less acceptable saturation, peripheral saturation, but still a low oxygenation in the oximetry. And in the first day, we've been traveling with hypoxemia. He presented also oliguria and volume retention. CVP started to increase, even the pulmonary pressure low. We took off milrinone, thinking to improve a little bit systemic pressure, reduce needs of noradrenaline. But the next day, as always, in the morning, suddenly he presents again VTs, which we treat successfully with anti-tachycardia pacing using his defibrillator. But in this complex, he presented progressive desaturation without response of non-invasive ventilation. Later, we connect him to B level and 100% of FeO dose. And we had to reintubate him. And now is my question. Could you please present the question? What you would do in this situation? He got ventricular tachycardia, amiodarone, maybe is effect of the negative effect of the amiodarone. I will try to make everything in the context of IRDS, because radiographic, there is no signs of effusion, no signs of atelectasis. I will put patient in the prone. It's like Shakespeare question, to prone or not to prone. It's a second postoperative day. Chest tubes, pacer wears, just recently sternotomy. I will go to the standard protocol of the RDS, and then I will use aggressive lung recruitment, or I will not put the patient in the prone because it's. I will start inhaled oxynitric. Even there is no evidence for that. Or in aggressive case, I will put the ECMO just to resolve refractory hypoxemia. So the auditory is more or less in the middle, undecided. We put him on we perform bronchoscopy just to be sure that the airways are open, and we started low dose of inhaled oxynitric, which allowed us stabilize immediately peripheral saturation and increase, or at least see the progressive increase of the PAFI. The medium, meanwhile, left ventricular assist device without any alarm and problem, 4.5 liters of flow, due to the intermittent kidney failure, increase of CVP and volume overload. We try to make the negative balancing using the continuous vena-vena hemodiafiltration. And we try to optimize everything or pre-optimize everything to intend to win oxynitric, but every time we do it, oxygenation of the patient is dropping. And never he presented retention of the CO2. He was always with a good carbonic status. And this is the next days. We, after the optimization of everything, try to win the oxynitric and always desaturation, always almost on the indication of veno-venous or veno-arterial ECMO for to secure the oxygenation of the patients. We try PEEP trials, is acromegaly with the huge lung volume, elasticity, lung compliance until 100. We try sedate him, we try awake him to use the diaphragm movements, look for any factors what we may recruit in this way. Of course, we were thinking we pass something, and we check again the septum of the intra-atrial and intraventricular septum, and we didn't find any connection in the atrial or ventricular septum. We perform twice intraesophageal study with different Valsalva maneuvers, including the expiratory occluding of the respirator tube, but we didn't find nothing. Our pneumologist suggested us to take a look or looking for systemic shunts, portosystemic shunts, which is described to produce hypoxemia. We've been looking for systemic shunts, arteriovenous malformation in the lung, performing the CT scan, and we didn't find anything. The lung was well ventilated, very little atelectasis in the dorsal regions, bilateral, but couldn't explain severe hypoxemia, severe refractory hypoxemia. And we turned to the prone, but at the day of 11. So of course he at that time was completely stable from the cardiac point of view without chest tubes. But it's still 136 kilogram male, which you have to turn. And it's not easy. And the question is, it's safe or no? Unfortunately, there is no consensus opinion in the case of refractory respiratory failure and need for prone position. And there is some evidence from the general cardiac surgery in the postoperative period which confirm that it's feasible, but it should be done carefully and a well-prepared team. No? And we have seen immediate improvement of the oxygenation, but of course after the turning him in the supine position, this improvement slowly disappeared. And 2 weeks after the surgery, initial implant, we performed percutaneous tracheostomy. And finally, over the 3 weeks after the implant, we've been able to wean inhaled oxynitric. Maybe it's coincidence, but I think is one of the important factors which contributed to success that he was obstipated over the 3 weeks, and after the 3 weeks, he performed his decompression of the intestinal, and CVP dropped from 14 to 6. So he was awake with tracheotomy, decompressed Bailey. No? You have seen his picture. It's maybe one of the important factors in the mechanics of respiration in this guy. And this contributed to a possibility to go on with the pulmonary weaning. Respiratory disorders in acromegaly is known, and in general, these patients have a 3 to 7-fold higher respiratory mortality in general because of the several anatomical and physiological facts. Acromegaly or giants due to acromegaly have a different craniofacial anatomy of the anatomy. They are predisposed to have a sleep apnea and subclinical hypoxemia. They have a macroglossia, barrel chest with different respiratory mechanics and increased elasticity of the lung. And I think as most important is the disturbance of ventilation perfusion. His spirometry 1 year later after assist device implantation without any pathology of the lungs which could lead in the difficult postoperative period. And just to conclude that acromegaly patients, we have to be careful in the postoperative care. Acute respiratory failure after the LVAD, it's important or serious complications, and we should avoid. In our experience, inhaled oxynitric with low dose and then prone position may help together with tracheostomy to manage these patients. And if everything failed to maintain hypoxemia, ECMO may represent a valid choice in experienced hands. And this is the patient last month in the outpatient clinic. He's ongoing over the 2 years, and unfortunately he gained 30 kilograms more, and now definitely delisted from the transplantation. So he is ongoing like destination therapy. Thank you.
Thank you very much. That's very interesting. Okay, we have time for 1 or 2 questions. You?
Alexander, did you give steroids to this patient?
Yes, he was on chronic substitution therapy because of the acromegalia. And within this acute decompensation, acute desaturation, we use steroids like in the context of treatment of IRDS, but without any visual effect. So we couldn't go on an improvement of the pulmonary function in him.
Anna?
Thank you. Very interesting case indeed. I just want to ask you a question and make a comment. It seems that from the sequence of events that you told us, it took a while for you to look at to the interatrial septum to see if there was a shunt. I mean, we are quite on top of that, so we will look for immediately when there is hypoxia, X-ray looks okay, compliance is good, there's no problem with ventilation. We will look for that actively whenever happens. Did you look for that and then you recheck later? And is what happened, or it took like 5 days to actually?
We perform in surgery always transesophageal echo,
Yes.
and this is the first what we check before the skin incision is the aortic valve, right ventricular function, and any communication. And he got the previous transesophageal study in the context of the transplant evaluation. So we have all 4 studies performed because it was unexplainable hypoxemia for us.
Yes.
And we've been looking with different kind of the maneuvers provoking increase pressure on the right side, decreasing the flow of the pump, just to see any communication, but we failed to confirm it.
And sorry, just a comment about the prone position. I think after COVID, the lack of consensus might change completely, and I think it's perfectly safe to prone a patient even on day 2 or 3 post-op when there is no other added complication. And obviously the benefit for prone in this particular patient was huge.
Yes.
Maybe it was just time that the lung function was going to get better, or it was the prone position. That it could, I think in my opinion, it can be safely done in these patients because, I mean, and now we have 2 years of experience proning any kind of patient in intensive care.
I completely agree with you, but we achieved with inhaled oxynitric with 5 ppms remarkable improvements, and we thought, okay, we still have time to wait a little bit to take out the chest tube, to give the situs of the surgery to consolidate, and then if we are not able to go a next step, then we will use the prone what we made.
Yes, yes. And sorry, just the last thing. So what do you think that was the problem?
Sorry?
What was the cause of hypoxia?
Acromegaly. It's a complex situation. His chest, his belly, huge belly, which is pushing up. You can't put the patient in the vertical position with the tube inside. So I think the tracheostomy was the key. Nitric oxide only allowed us to be more or less safe with the hypoxemia, but not advanced us to success. And I think put him in the chair with the tracheostomy and decompress the belly, that was the key to go on.
Okay. We have to finish this session. Thank you for the audience, thank you, of course, for the speakers. And I think we have 10 minutes to a break with a coffee. And we come back 5 p.m. Thank you very much.
Bueno, muy bien, Manuel.
Muy bien. Daniel.
Nos hemos salido, ¿no? Yo creo que
Hola. Everyone, please take your seats so we can get started for the last session. Let's take a seat, please. No se oye, ¿no? ¿Verdad? Let's take a seat so we can start with the last session.
Hello, my name is Andrea Xerez. I'm a cardiac surgeon of 12 October Hospital, and I'm here with Marta Ferrero from Hospital Clinic here in Barcelona. And it's a pleasure for us to be here and to be in these talks with these three international leaders in heart transplant, mechanical cardiac support, and heart failure. It's an honor to be in these talks. So I think they don't need further presentation. So please, just with our first speakers, Uriel, with a talk about optimization in the device and medical treatment guided by echocardio and right catheter.
So again, I have to say, I forgot how fun it is to be with old friends together. So to everybody here, this is absolutely a joy to see you all and to meet with you. And right now you did a big mistake because you give me to talk a little bit about LVAD optimization. So Uli and Guillaume, your talk is canceled. I'm taking all the time of the session, and that's it. We're going to speak from now on about LVAD optimization, that's it. And actually, a lot of the people here in the room were involved in a lot of those protocols that we developed. Lola and Marta and David, and of course, Joe, you all bear part when Uli and I just started envision all the concept of ramp and how to do LVAD optimization. So those are disclosure. So we just start from that, and we said, we have a pump that gives us great outcome. Let's start from this point. 75% survival free of disabling stroke and fear of the need for device exchange. The question, can we get it even better to that? Before even starting to speak about the device optimization, I want to mention a few words about medical therapy, really minimal, because LVAD patient are heart failure patient. They still heart failure patient, and we should not forget that. There was a beautiful study by Brian Houston that showed that you give ACE inhibitor and ARB, you reduce the rate of GI bleeding, and that's the reason we should continue to give them after. But we thought about more holistic way to look at it, to look at neurohormonal blockade in general, all the cascade. This is before SGLT2, and I definitely think that SGLT2 will fall also to be successful. I got a feeling that SGLT2 need to be in the water because it's good for everyone. But let's see what SGLT2 did. We look at the 6 months following. And first of all, we saw that we are not so good in this. Meaning, even though we are heart failure doctor and we give 90% beta blocker to all heart failure percent, in LVAD we actually reach only 70%. ACE or ARB was something like 60%. Aldosterone blocker was in the 50% range. That's actually like the heart failure. So let's go one by one. Beta blocker associated with reduced event of heart failure admission. GI bleeding, pump thrombosis or stroke was pretty much the same. But heart failure, beta blocker is important. ACE inhibitor ARB, very similar to Brian Houston, the GI bleeding was reduced, but also the heart failure. So those two medications we probably need to continue to give. Aldosterone, spironolactone, we don't need to, at least this is a small cohort, but we didn't find any differences. This is a 100-patient study, but at least it gives us a comfort to know. We just published our results with Entresto. Entresto is very similar to ACE and ALB as well. SGLT2, hopefully next year I will be able to tell you. Next thing, before we go into the device optimization, also relate with communication with other devices. And patients have ICD and CRT. So let me do it very fast because this is very important. First of all, patients that have ventricular tachyarrhythmia die more than patient that doesn't have ventricular tachyarrhythmia. That's in general about LVAD patient with ventricular tachyarrhythmia. The probability of death is much higher. Patients that have ventricular tachyarrhythmia before the LVAD implanted tend to have more often ventricular tachyarrhythmia. And this is a very dramatic difference, as you can see here. 34% freedom compared to 91. So that's the reason I asked the question before, if you remember, about the VT ablation, because if the patient had before, probably is going to have after. And is ICD matter? And I'm going to give you a final answer to that. You will see a slide that nobody saw before, because it's unpublished data, but something that will give an end to it. Uli and I look at it together with one of our fellows at that time, Rashad Garan, today is the director at Beth Israel, and we didn't find any difference with ICD. But the studies that Maya Saikas from Croatia did find that there was difference, and I opted to give you a recommendation, because the recommendation in the US, if you need to replace a defibrillator and the patient got it only for secondary prevention, you don't need to do it. For primary prevention, that's a different story. CRT. CRT was very interesting for us, and I will do also a very fast track. Actually, here we tried to answer the questions. There was a lot of randomized retrospective study that gave an answer that probably it doesn't important if CRT is on and off. However, what we did is a randomized study. We took patients, and we took all those 40 patients, and they're randomized to be in CRT or right side pacing. And what happened is that biventricular patient versus CRT pacing, after that, for 2 weeks, we measure all parameters, KCCQ, 6-minute walk, we'll measure also arrhythmia burden, etc. And then we turn them to the other programming. We did not know which one was what. And only after they finished the study, we understand what the patient were. We were blinded to the study. The EP actually did all the maneuver in regard to that. So immediately, as you can see here, biventricular pacing was associated with lower daily step count, lower 6-minute walk, and lower KCCQ. Again, just daily step count was dramatically lower, almost by 700 steps. 6-minute walk was dramatically longer by almost 40 meters, and KCCQ was lower by almost 7 points. So, I told you I will give you an answer. This is for momentum free, to give an end for this. Momentum free, we took the study, the pilot study, and the CAP. On the left side, you see ICD and CRTD, meaning patients that have defibrillator, whatever type, compare to no defibrillator. As you can see, there was no statistical difference. There was trend to actually people that didn't have anything to be better in momentum free. So again, we don't need ICD to save life in other patients. In relate to the CRT, it's a little bit more tricky. None is 86%, ICD is 82%, CRT is 78%. It seems to be that there was statistical significance between CRTD and none in outcome already, not only 6-minute walk and quality of life. This went away. It was not statistically significant. It still remained in a trend when we did adjustment, meaning that we did adjustment to this patient. So again, let's just summarize. When we optimize an LVAD, we give beta blocker, we give ACE inhibitor ARBs, we shut down the CRT lead, we stop that, and the ICD, if you don't have to, you don't need to replace it because there is no need. So now I can go to the other stuff. There was a beautiful talk about the inflow cannula and the problem of position in inflow cannula. We can optimize LVAD only if the surgeon put the LVAD in the right place. If Guillaume didn't put it in the right place, we cannot do we can just do fine tuning. We cannot do good tuning. So heart-mate free, I will focus only on the device that is approved. We look at multiple directions from AP. We look at actually the inflow cannular corneal angle, the pump depth, the inflow cannular sagittal direction, and the cannular area. Okay? And we learn that a position that is more than 28 degrees is associated with much more heart failure. So again, if you stick the heart-mate free too much up, okay, it was associated with higher rate of heart failure admission. We are now doing analysis for momentum free. We need to read all the echo and it takes time. All the x-ray, it takes time, and we'll see if we can confirm it to that. It was not only heart failure. As you can see, there was a trend to also more GI bleeding. We are not surprised by that, and the reason is when the cannula is not in the right position, you cannot optimize hemodynamic. You cannot optimize hemodynamic, all the cascade of inflammation in that state. So now I'm going to what, Joe, you probably want me to talk about, the right heart cath and the echo optimization. But I mentioned this because medication, ICD, CRT, cannula position are as important as this, okay? So now let's go to it. Marta, you told me near when you start pressure volume loop. So I will do it very, very simple. Pressure volume loop is one beat of the heart. In this one beat, we look what happened to the pressure inside the heart on the y-axis compared to the volume inside of the heart. We're starting from a point, this point, in which we start isovolemic contraction. We build in pressure while all the valves are closed. The pressure is so high until in this point the aortic valve open and we start ejection. This is systolic period. Until we eject enough blood that the aortic valve is closed, okay, and we start the isovolemic relaxation, diastole. Then we have the pressure is so low, mitral valve is open. We start the fill-in pressure until the mitral valve is closed. This is one cycle. The wide of this pressure volume loop is a stroke volume, okay? The height that the pressure volume loop can generate is depend how much we can contract strong. So this line that's called the end systolic pressure volume relationship that contain the pressure volume loop on the maximum ability of contractility. This line represents contractility. And the EES represent the slope of this line, represent the contractility. The more you go to the left, more pressure you can generate, you're stronger, you're more contractile. The less contractile, you're more heart failure. The lower part of the curve, the diastolic period, because as we said, this is systole, yes? All of this is systole. All of this is diastole. The lower part of the curve is contained in a line that is actually not a line that is linear. It's a parabola. And the more steep this line here, the more diastolic dysfunction you are. So we can look at it from a different direction of V30. What is the volume when the pressure is 30? If the volume is low, you have some diastolic dysfunction. If the volume is high, you have a heart that knows how to relax. This is what's called lithotropy in the heart. The last thing I want to mention is actually the afterload. We can learn from the maximal point of pressure to the maximal point of volume. Okay, we can have a line, the EA. And this EA represents for us the contractility, the total peripheral resistance. The more we go into the right, more afterload we have. The more we go to the left, less. Again, just think about pressure and volume, how they contain to each other. So now, this is heart failure patient. Very low volume, very small stroke volume, very high and pressure. We start an LVAD, and what happened, the PEC left ventricular pressure is going down inside the ventricle, because the ventricle doesn't need to contract. But also the preload is going down, meaning the end diastolic volume of the heart is going down. What's happening, we push all the blood to the aorta, so we create an uncoupling between the aorta and the left ventricle. That's the reason the pressure in the left ventricle is low, the pressure in the aorta is high, and we have a decoupling between the pressures. Now, when we understand all of it, we need to remember the last thing. The heart is a work machine. Every beat contains energy. The consumption of energy depends on how much energy we take, and this is inside the pressure-volume loop, the pressure-volume loop area, but also the potential energy. Let's say the heart is so stretched, it's so high in the volume on the right side, this is called the potential energy. The combination of the two is how much energy we consume. Now, when we move this, first of all, you see that the area of the pressure-volume loop is smaller, but it's also moved to the left side. So actually what's happening is that the energy of the heart is going down. Heart on a LVAD can rest. When we understand all of it, we need to think on every specific patient where we want to put them. If my goal is myocardial recovery, in the beginning I want to reduce dramatically the energy, bring it as much as I can to the left, and then slowly release and see where the heart is. And that's the reason when we optimize an LVAD patient, it's important to understand it's a dynamic process. So it depends when are you in the course of the disease and the course of the support and which patient you are. So there are patients that I will want to take them from the black to the green, and there are patients that I will want to take them all the way down. Usually, young patients, I will take them in the beginning all the way down. I will take over the heart, and then I will start releasing them. And you can create complete support or partial support. All of it can be done, but you need to optimize. So how do we do it? This is, you remember what I said? We need a smart pump because this is a stupid one. Why it's stupid? You know only one thing, speed. This is what you set. The pump will do anything it can in order to get to that speed. So the flow, how much blood it's actually pushing forward, it depends on the rotor speed divided to the gradient where it's pulling blood from. It's pulling blood from the inflow, the left ventricle, into the aorta. So the more this gradient will be, like during diastole, the lower the device flow will be. The smaller this gap will be, like systole, because we have higher pressure in the ventricle, and in the aorta it's stable pressure, the more flow we'll get. So continuous flow pump are pulsatile flow. They are pulsatile flow from the narrative that there is some systolic and diastolic activity. So what we created in the beginning, and this is a journey that Uli and I started in 2010, the first publication was in 2012, so it's 12 years ago, Uli. We understand that in order to understand all of it, we need to see how the heart is reacting to us changing speed. We started with the HeartMate 2. We look at the speed change from 8,000 to 12,000 RPM. Well, I'm not going to go to the detail of it. The concept was to see the pump behave as we thought. It's stupid. We increase the speed, they increase the power. So that's the reason the green line is always going up in a linear way. Because we want more speed, we need to work harder. But what was very beautiful in the HeartMate 2, that immediately the volume of the ventricle, the red line, is going down only in a very linear way. When we tried to do it in the HVAD, it was not like that. Meaning, it was not linear. The linearity happened only after the aortic valve was closed. And I will go to that in the end. So now, when HeartMate 3 came to the market, we immediately did the same thing. Actually, originally, we couldn't do it in the US because the only HeartMate 3 in the US was high momentum free. So I called some of the friends in Europe, and Jan Schmito that was here before, and Ivan Netuka. We did a tour in Europe, and every city we came, we did a couple of RAM tests. So this is, there is the Euro trip, and there is the RAM trip. So that's what we did during this. And we did this on a bunch of patients, and it was really fun because we learned how different practices in Germany and Croatia and wherever, and the Czech Republic. First of all, the first lesson, all the devices behave the same. When you increase the speed, the baseline, the wedge can be very different. So every patient is a different patient, and that's the reason you need to do it, because your patient is going to be different one from each other. But all of them reduce very nicely the wedge pressure in response to speed, if it's HVAD, if it's ATME2, and it's ATME3. By the way, the slope is very similar to all of them. It may not look like that, but the slope is very similar. The CVP was, and my apology, I see that the graph is a graph here for wedge, but the CVP was pretty flat to all of them. In acute setting, and we'll get to that, we don't see changes in the CVP. And this is part of the caveat and the problem with a ramp, because its change tests something in an hour. It doesn't test the effect on a long term. And the Venus system, you have to remember, it's a very capable system. It can consume some of those volume, but on the long run, it's going to have an effect. So the first step is to understand, if we get optimization, CVP below 12, wedge below 18, cardiac index below 2.2, Monroe, the same value that you use in the shock, can it do something good to the patient? And yes, it can. So this is a prospective study that we did. It was non-randomized, and we demonstrate that 43% of those patients have had heart failure admission, even if they're but it's much less than the 20% that did not reach those admissions. So hazard ratio that was almost double the freedom from heart failure admission. We still see that we have a lot of potential because there is a lot of heart failure admission. But it's not only heart failure admission that's going down, it's actually also hemocompatibility related adverse event. And as you can see here, people that are optimized, the hemocompatibility related adverse event was 25%, compared to people that non-optimize, almost 56%. Meaning when you optimize a patient, you're going to reduce heart failure admission, stroke, and other GI bleeding and other elements. So then we said, but this was not randomized. What will happen if it will be randomized? And then we did Ramp It Up 1. Now we call it 1. It was just Ramp It Up. And in this study, we randomized 4 sites, not only us, because we were used to do it. We took also Stanford, Northwestern, and Utah together with us, and we tried to see what happened if we will teach people how to do the hemodynamic ramp. Can it help with patient management? It was a pilot. It was not supposed to get statistical significance, okay? So first of all, people that were in the hemodynamic arm had double the amount of how many speed change you did for them. And the reason is, it's actually very intuitive. We know the pressure, we start managing it. When we don't know, we don't touch. And it's not only for the speed, also dramatically more change in the beta blocker and dramatically more change in the diuretics. This is one-to-one with analysis of I'm blacking out of who did it from the Champion study on the CardioMEM done that show that people in the CardioMEM out had much more medication changes compared to the control arm, okay? The surprise was that even though it was only 40 patients, 20 in each arm, we almost reached statistical significance in reduction of the adverse event, as you can see here. 62% freedom compared to 46% freedom. So I'm very excited that we are going to move to the next 3. And the next step is to do it continuously, not only once and see what happened in one time, what will affect in 6 months. What will happen if every day you will be able to change? And that's the reason the CardioMEM. But I told you it's not so easy, because 50% of the CardioMEM patient, of the HealthVet patient, have diastolic decoupling, okay? And when you have diastolic decoupling, gap between the diastolic, the mortality is much higher to patients that have the decoupling. Heart failure, readmission-free survival, okay? And that's the reason it's very important not to go to this area. And when we increase the speed only based on PA diastolic, we can easily do that. So the purpose of Ramp It Up, by the way, decoupling is also associated with more hemocompatibility-related adverse event. It's all going in the same vein. You're not hemodynamic stable, you're going to pay a price in all the adverse event related to LVAD. So we are going to actually learn how to use PA diastolic in LVAD patient. It's going to be patient-specific. In the beginning, when we implant the CardioMEM, we are going to do a ramp. We'll learn what is actually the decoupling. We'll minus this decoupling from the chronic management. For each patient, it will be minus different thing. So now, you remember what I told you. One pump was actually doing something linear, the other was not. So this is the HeartMate 2. Low speed is gray, high speed is yellow. very longitudinal unloading. This is the HVAD, global unloading. It shrink, but in a global way. But something was together in both of them. The RV became big in both. So we try to understand better what is happening and to just take it to the number, and you can see that there is a deflection point in which, if you increase the speed, the LV will always be happy. LV want to be small. But the RV will tell you, that's it, I had enough from you. Don't continue to do it. So to do ramp is very tricky because you need to understand it. And we try to understand if it's the HotMate 3 is the same, and yes, the HotMate 3 is the same. It's something between the HotMate 2 and the HVAD. It's a combination. It's longitudinal unloading and global unloading, but the RV blow up when you go up too much. And that just show you the similar vein, exactly like the other pump. So now we want to solve this one. So what we decide to do is to really understand what we call interventricular interaction. Interventricular interaction is the influence of the left ventricle on the right ventricle function and vice versa. Usually what you think about it when we speak in here, this is the cause for RV failure. So let's understand two types of interaction. Type number one, called serial interaction. We are giving flow from the left ventricle to the right ventricle. The right ventricle never saw this flow before. So there is going to be, is this right ventricle can handle this extra flow or cannot? This is serial interaction. And there is parallel interaction. By the way, this by itself is a talk for 1 hour, so I promise I will do it very short. Okay? Parallel interaction, the left and the right share the septum. It's the same septum. So when I pull the septum to the cannula, if I'm increasing the speed, I'm changing the geometry of the right ventricle, and 80% of the right ventricle activity is in the septum, only 20% in the free wall. It's completely the opposite for the left ventricle. 80% of the left ventricle activity is in the free wall, only 20% in the septum. So because of it, can the LV handle it? This is a project that we do with Manrit. Manrit, we have already 15 patients. Their initial analysis is going to come on 20. Every patient is a pain. I think Manrit and I, we are very happy that we do it because we text each other, but then we are so tired in the end. And we put a conduction catheter in the RV. This is a conduction catheter. The reason it's so hard, the conduction catheter was not born to the RV. They were born to the LV, so they are straight. And the RV needs some curve, as you all know. That's the way the RV works. And we're trying to find at least 3 segments that we can really get a good pressure volume loop. We do it in the cath lab in a scenario in which we have the pressure volume loop system. We use the LICAM, 3-dimensional echo, and a regular swan. So usually we put a swan in the brachial vein. We put the LICAM, the conduction catheter, in the jugular vein, and the echo we do regular. And that's how we do the test. So this time, you remember the pressure volume loop I showed you? They are different because this is right ventricular pressure volume loop. You see they are much, much lower. Look at the pressure of them. Much lower, much more stocky. They are not so trapezoid as you saw before. We're looking at 2 points, okay? The point in which the pressure is 20 in the end-systolic pressure-volume relationship, or the point that the pressure is 10. We're actually trying to understand the diastolic and systolic function of the right ventricle. So this is a classical example. And I wanted to say, because someone presented a case that had the RV pressure, the Chinese patient that come from another hospital and came on a BIVAD, and he can easily cruise after the course. And the reason is, you remember he had a pulmonary pressure of 70. This actually shows you that the RV was trained. So this is a classical case. 5,000 RPM, I just show you free speed in a 54 and 58. All those pressure volume look the same. Meaning me increasing the speed didn't change anything. No serial interaction and not parallel interaction. Meaning this ventricle is not going to suffer from RV failure. Something in this right ventricle protecting. Probably, to begin with, it's a ventricle that was used to work against high pressure. On the other hand, we had a patient like that. This patient, we increased the speed from 5,000 to 54. Look what happened to the ability to generate systolic pressure, much lower, okay? As a result of it, in 5400, the right ventricle cannot generate pressure, it cannot push blood to the left side. We went to suction, and that's the reason you don't see here the high speed, because this ventricle went to suction. This is full-blown RV failure. Okay, this is a ventricle that cannot, it have an interaction, both serial and parallel, by the way. And we had patients like that, but the systolic function was fine, stayed the same. But the diastolic actually went down, meaning the ventricle was more compliant. Those patients actually can handle increased speed. There's a positive serial interaction, meaning the ventricle is not working in its expense when the left side was not pulling enough fluid. So this is a positive diastolic parallel interaction, okay? So now we can create model on multiple things. Let's take a speed of 6400, and this is a patient that have a systolic interaction. On the top, you see the RV. Here you see the LV. So this is the baseline, and this is a systolic interaction. The right ventricle systolic interaction, meaning he cannot generate enough pressure. As a result, the LV will start seeing less, and that's the reason the curve is going to move left, and we will not get enough flow from this LVAD. On the other hand, you can have a diastolic interaction that the ventricle can tell, bring it to me, I can handle all the volume you want, increase the speed, I'm okay. The left ventricle doesn't care. And of course, you can have a combination of the two that can put us in a challenge. Which one of the interaction is more that? When we'll finish the first 20 patients, Manrit and I will share with you the result, and then we already got money to continue to 40. So, in summary, hemodynamic optimization, improve heart failure readmission, free survival, associated with lower hemocompatibility related at the event. However, interventricular interaction manifests heterogeneously. Systolic interaction result in diminished RV systolic function. Diastolic interaction render the ventricle more compliant and improve RV function. And the balance between the two, opposite forces. And the net effect of an interventricular interaction is always a variable and patient-specific, and that's the reason you need to do it. Thank you very much, and I know that I cut time.
Thank you, Nir. I had my class on pressure volume loops. So until now, I think you have done all the questions at the end, but maybe if in this occasion it would be nice to have some questions for Nir right now. Does anybody have one? Manrit, how not?
Manrit.
Go ahead.
I have a comment and two quick questions. So first of all, when I read your RAM studies and Palak study on how we actually don't do a good job in unloading these ventricles, I thought surely that's not true. And since we discovered RAM studies at 4 to 6 weeks post-VAD, I think the quality of life our patients has significantly improved. So thank you for that. My first question is timing for RAM study. The 4 to 6 weeks after, do you also for DT patients do them a year to year only if they have symptoms, or is it just something?
So originally our protocol is every year in a DT patient we repeat the RAM test. In reality, specifically during the last 2 years because of COVID, it was very hard to follow that. Lately, because we opened back the cath lab completely, I can tell you now we have a flux of that reason. Suddenly we recruit many more to the pressure volume loop study. And so our protocol is every year to repeat. If a patient is rock stable, it's like, you're sure that you don't need to, and he's 78 and you don't think about so many years forward, we don't do it.
Second question, do you ever reload a recovery patient as you are moving towards recovery?
So as I said, we have very different protocol to patient that we target recovery. The protocol actually include also metabolic elements that I don't have a proof yet to show you. I think they're good. Omega-3s, they get 4 grams of omega-3 and they get 200 milligrams of CoQ10 on top of neurohormonal blockade. So we are learning that probably in a few years because the recovery is so rare, it's taken us a lot of time. But those patients, we unload dramatically in the beginning to let the heart rest just from all the trauma And then we slowly actually, I'm trying to relieve and to get to a what called partial support and not a full support.
So it looks like in the future we're going to be facing at RV RAM test more than left ventricle, no? Focusing on the left ventricle.
I will tell you the truth. I really think doing pressure volume loop is something that is more research-wise and not clinical-wise. The reason is this is really time-consuming, and it took me time to learn how to put the catheter in the right place. Manrit, I don't know how much time, but it's not so easy. In the first cases, I thought that I'm like 2.5 hours trying to position the catheter in the right place. I think this is for us to learn what we need to do. Eventually, we'll need to find a better way that will allow us to optimize. I do think that it's coming. I didn't have enough time in my original talk, but there is a lot of sensor that will be able to give us pressure continuously also on the right side, like on the left side. On top of it, we're going to see more units that can give us, like Fire 1, that can give us volume on the right side from the inferior vena cava. It's a small netinol clip that you put in the inferior vena cava, and it tells you how much volume you have on the right side. I think communication with multiple devices. This device, in order to optimize it, will have to know how to play in the sandbox with all the other devices. And we need devices to give you pressure on the left and devices that give you pressure on the right, because what we're doing in the cath lab is for us to know that communication with those devices are important.
Yeah, this is I just want, oh, there's a question.
Sorry.
Just say it without the mic. We'll repeat it if others can't hear it.
Very nice presentation. Thank you very much. Is
Thank
it interesting to open the aortic valve? Is it very interesting? But it's more interesting that the cardiac output be the patient needs. But sometimes the valve, aortic valve, not open because you can reduce the flow of the heart. So, what do you think about this?
So Dr. Yorda is going to talk now about complication, and I got a feeling he will talk about aortic insufficiency. You bring in a brilliant point. When we optimize a patient, it's not only about the hemodynamic, it is about our ability to maintain some activity of the aortic valve, because we know that this is the most important thing to prevent AI. I have to say again something that Uli, I don't know if you're going to go into it, AI in HeartMate 3, much less frequent than AI in HeartMate 2. Maybe it's because of the intrinsic pulsatility that it has. So sometimes it creates what we call copulsation and counterpulsation. And when it creates copulsation, meaning the speed is dropping at the time of the systole, so the ventricle is actually ejecting through the ventricle, and then you have aortic valve opening. Fascinating point. It's part of the when you optimize, you look and you try to make sure that you keep some of the aortic valve open. And Uli will talk more about that, I'm sure.
Yeah, great. I just wanted, one of the main points that I always look at on this is you underscore it usually. When you look at what happened to the wedge pressure, now they all respond to a ramp. To me, and this is for those who don't do ramp studies all week long, but do a number of LVADs like many of your centers do, to me the most important finding of all of this was that when they brought the patient to the lab and they thought the patient was doing okay on the outside, the opening wedge pressure was between 10 and 40. This is one of the main points of the research. And then now I've never seen this thing with the compliance. I remember when Nir did this is 10 years in the making and more. Initially, he did the 3D echoes, and you could see that with the ramp, the right ventricle gets bigger. And I remember we're talking about that, and initially he thought, oh my God, it's failing. You know, and I did say, well, maybe it needs to get bigger. And to now see that this compliance with the catheter is so nicely demonstrated, it's really nice.
But it's really something that is important. And I think we have a lot of residents here, so I will give a comment about education and not about LVAD. I think physiology is a key to understand adverse event and good outcome. Uli and I went to this because I remember Uli was the director of MCS during that time, and he said, we need to create protocol, something that will make everything in line. And we tried to create protocol. In the beginning, people thought that I'm crazy. Remember, we were going with the Vividai.
Not only in the beginning.
But in the 12 years later, the amount of information that we now understand about that. So for all of you, the residents, you always ask physiological questions. Answer them in a physiological way on 2, 3 patients. Slowly, 12 years later, you will say, whoa, I probably did a 1,000 ramp. And then you can answer some question.
Just one quick comment. So what do you do? Like, you do a ramp test, you have your patient optimized, the pressures are good, the cardiac index and everything. But then when you do echoes in the, before you do the other pressure measurement 1 year after, sometimes the aortic valve is not opening, but it changes and it's so dynamic that it depends, like if the patient comes walking, it's opening, but then it goes to the echo and it's been waiting for 30 minutes and it's not opening. So how do you manage this? Because if you, like, anytime he comes, you low down the speed, then you go up. I think you go a little crazy, and I'm not sure that we need to do
Lola, that. a very good point. I will say 2 things. The more time passed from the LVAD, the more I want to go to partial support. Only in the first few months I want to do full support. So if I have an opportunity to reduce the speed, I will reduce the speed a little bit. I will increase. I always try to push as much as I can after load reduction. You are going to get a lot of flow for the pump with less speed if you reduce the afterload. Because that's the reason I showed it. So when time passed after the ramp, it's already 6 weeks, you come up again, another echo at 3 months, suddenly the aortic valve completely closed, increase the afterload, decrease a little bit the speed. This is perfect segue to achieve what you want to get in the end. Maybe after Uli talk, we can talk about.
Maybe we can come back to the questions after. I don't want to keep Uli waiting.
Okay, great.
Thank you.
It's all about body language. Very good. Well, again, thank you. I gave near 10 minutes of my time, so we can now move on. I'll catch us up. As to your question about the aortic valve, right, this is something very important. One of the important complications in LVAD support is aortic insufficiency development, and here's why. It is basically because the leaflets of the non-opening aortic valve fuse and create an unstable valve where also the tissue itself of the valve changes. This is something that is well known now, where in 2014 we published this paper to show that aortic insufficiency is a common finding in patients on continuous support LVAD. And I have to say, this was long before speed optimization and all of that was fully understood, or understood as well as we do now. And we reported at that time that freedom from at least moderate AI, which is probably clinically significant, at 3 years was only 68%. We also suggested at that time, in 2014, that the key to the aortic valve insufficient development is aortic valve opening, just like the question that you had asked. And we reported that if you regularly open your aortic valve, your risk for aortic insufficiency is actually very low. There have since been a lot of papers confirming this. Basically, those are the main findings. Here's one other paper in the INAMEX database where we didn't go in 200 patients, but in 10,000. And they basically showed the same result. What can we do about it? If the aortic valve doesn't open, what I talked to about was de novo aortic insufficiency when patients don't have it at baseline. It's a different story. If you already have some AI at baseline, obviously in that setting it will be more common. And in that setting, the surgeon has to decide whether to intervene at the time of LVAD implant, either with a so-called Park stitch that you see here, the fledgeting of the leaflets, or with aortic valve replacement. But I don't have time to go into this more. One important observation that doesn't go beyond this basic finding that holds true, frequency and mechanism, is that you might want to assess aortic insufficiency in a different way. And here's a paper from Nir where he showed that you can do this in a very complicated complicated echo and cath lab algorithm. But it is good. It is a research tool, in my opinion. Back to the clinic. What do you do when patients have severe AI? And here you have a cohort of patients that had severe AI that we monitored, and we just increased their speed to overdrive, to create cardiac output despite AI. And in half the patients, you can get away with that for at least a year, as in this case. The other half will need an intervention, be that a rescue transplant, be that an Amplatzer device that you can place to close the aortic valve, or be that nowadays would be TAVI, right? Again, I'm not going to go into that in detail, but this is just a concept what we can do. The true catch-22 of LVAD therapy used to be, I have to say, clotting and bleeding, right? The two mechanisms that are the yin and yang of patients on LVAD support. So let me go through a few slides with that. We used to think a lot about which device is better. We talked about HVAD. Some people think too many strokes, some less, more bleeding, less bleeding. So we said, which device is the best for this patient? Well, just like Survivor Spain, there can only be one winner in the LVAD field, and at this point, the only commercially available device is the HeartMate 3. Right? We're looking forward to newer devices. So let me focus on the HeartMate 3. You have seen this slide many times now. The outcomes with it are excellent, and this is a slide of adverse events early on in the momentum experience, and the message here is only that pump thrombosis is essentially gone. There is no pump thrombosis anymore, really, with HeartMate 3. There are other issues, but the inside on the motor pump thrombosis basically does not exist unless injected. Bleeding and stroke are still very important complications, and at this point, I think the most burning question is, why do LVAD patients have strokes? Nia mentioned to you earlier that nowadays most of the strokes are perioperative, they're mechanical, something during the surgery, something that happened shortly after, and long-term support, two different categories. And the next question you want to ask is the mechanism of stroke device specific. Are there certain devices that give you a stroke for certain reasons, but others will not do that? And can we prevent the strokes? And as we started out with doing the RAM studies, studying strokes in HeartMate 2 patients, we observed very early that hemolysis was a key factor for stroke. And we thought at the time that the hemolysis occurs only because there is a clot in the rotor or something that chops up the blood, and then you get hemolysis. But this is not the whole truth. We understand now that hemolysis itself may cause a thrombus via release of free hemoglobin, platelet activation. So the chicken and the egg, the first may actually be the hemolysis. We also understand, and I put these slides back in because this is getting more interesting recently, that sildenafil, our favorite drug, may block some of these interactions. And the first observation that we made with a HeartMate 2 device, mind you, a device that frequently causes hemolysis, was that patients who had low-level hemolysis and were on sildenafil would not go on to have thrombotic complications, consistent with the mechanism of blockage that I just hypothesized for you. In contrast, patients who are not on sildenafil with the same degree of hemolysis will go on to have thrombotic events. This is with the HeartMate 2. A large database study, again in INNERMAX by a group from Randy Starling, confirmed this in the HeartMate 2. It's the usual INNERMAX, 10,000 patients, highly statistically significant result. But the HeartMate 3 doesn't give you as much hemolysis as the HeartMate 3. So is this still a relevant mechanism? And is sildenafil still a drug that via this mechanism would help you when you have a HeartMate 3? And here's a paper that just came out about a month ago, where also with the HeartMate 3 and with the HVAD, HVAD has more hemolysis, so maybe why these curves are much wider apart, but also with the HeartMate 3, being on sildenafil, on a PDE5 inhibitor, reduced your risk of stroke, all-cause mortality, and a combined endpoint thereof. And this is the central illustration of their paper. It's very nice, and it shows highly statistically significant reduction of these endpoints when you're on sildenafil. I had the privilege to review this paper and write an editorial, and I want to caution you as to the use of sildenafil with the idea that it can improve all these outcomes. And the reason for this is that in this particular paper, which again just came out, they counted events from day 0. In other words, perioperative strokes were counted even though the patient could not possibly have been on sildenafil at this time. And when you look at the paper and you look carefully, is that when they correct for this, when they only account for events that would be considered longer term, actually lose statistical significance for their primary endpoint, and it only remains for the stroke. So with sildenafil, I think there still is a lot to be done, and there needs to be more work done to understand the exact mechanism by which sildenafil may reduce stroke. And we're doing just that in a clinical trial right now at Montefiore. There was clotting and stroke. The other side of the medal is von Willebrand deficiency. I'm not going to explain the slide. You've seen it a million times. You've seen this slide also. We know that you get von Willebrand syndrome with continuous flow pumps. The only thing I'm going to say is that seemingly, based on analysis of von Willebrand factor after LVAD placement, this seems to occur less with the HeartMate 3 device than with other devices, and possibly because there are wider gaps, which also give you significantly less hemolysis. What is the clinical relevance of this? You may bleed less. The other thing that we understand that is important for bleeding from an LVAD is not just a bleeding diathesis, but it is the lesion that you bleed from. And in LVAD patients, there are numerous studies to show that about 50% of all bleeds in LVAD patients are from AVMs, or better called angiodysplasias. If you have 100 patients come to the ER today, here with the GI bleed, they don't have an LVAD, you're going to have angiodysplasia in 2, maybe. If you have 100 LVAD patients come in, 50 of them have an angiodysplasia. That's angiodysplasia bleed. So that is a big target for us. Interestingly enough, again, the aortic valve is so important. You are less likely to have a bleed, freedom from bleed is here, if your aortic valve opens regularly, suggesting what Nia mentioned earlier, that pulsatility may play a big role here. So let's take a step back at pulsatility. We used to think pulsatile pumps, HeartMate 1, the old pumps, non-pulsatile pumps. This is wrong. This is not binary, but rather, when you look at patients with a normal pulsatility, heart failure patients already have reduced pulsatility before they ever get an LVAD. Then you put an LVAD in, then you have always opening or intermittent opening. You realize that there is a very broad range of pulsatility. And the question is it important, or do you get AV malformations because you have no pulsatility? And can we manipulate that? It's very difficult to study these AVMs, to do a push enteroscopy and look in the bowel. I don't know if you have seen this paper, but what we showed here is AV malformations or angiodysplasias in VAD patients, but they were everywhere. They were not just in the jejunum, also in the stomach and in the nasal mucosa. And we reported maybe a year or two ago, this is an old slide, that if you have more hypervascularity in your nose, which we can actually look in very easily, you are more likely to bleed. And the message here is, this is a systemic phenomenon. And if you listened well, I have tied this to pulsatility, and we have now expanded this work. And we have done video capsule endoscopy in heart failure patients, not LVAD patients. And you see here on the right that if you have no heart failure, a little heart failure, or a lot of heart failure, the prevalence of clinically silent angiodysplasia is actually quite high in advanced heart failure patients. We used to think the LVAD somehow induces GIADs. This is not the case. This is related to pulsatility, and this is kind of our latest paper. It's also in press now. So heart failure already induces angiodysplasia. The LVAD just boosts this. Nia mentioned earlier briefly, we think we understand what the mechanism for this is, that it's an increase in angiopoietin, actually a disbalance between angiopoietin 1 and 2, that leads to angiogenesis, and that leads to AVM syndrome bleeding. But what causes this? Earlier on in the cascade, probably non-pulsatile flow, probably splanchnic hyperperfusion, hypoxia, and then activation of this hypoxia-inducing factor. Now, interestingly enough, this is something that digoxin can block, and we have looked at this in a cohort of patients a few years ago, and indeed we showed that patients who were on digoxin for some other reason were much less likely to bleed, and this worked to support the hypothesis I showed you that this factor can actually be blocked by digoxin. But what I found even more compelling is this finding, that if you were on digoxin, an LVAD patient on digoxin, only 30% of the bleeds in these patients were GIADs. But in the group that was not on digoxin, almost 80% were angiodysplasia bleeds. So here's a medical intervention. I'm going to go through some medical interventions that we should do in addition to optimizing the pump. I told you about sildenafil. I told you about digoxin. I want to now get to aspirin, the medication that we still prescribe, maybe for no particular good reason, right? In LVADs, is it a necessary drug to prevent LVAD clots? Or are there no clots in the HeartMate 3 because of aspirin? We're not sure. Does aspirin meaningfully contribute to outcomes in LVADs, or does it just increase the risk of bleeding, actually? Right? That's a big question. If you need aspirin, is it any dose? Is it a class effect for aspirin? And does it tilt the benefit to risk ratio adversely, like we have learned in patients over 65, that this prevention aspirin actually just leads to more bleeding and not less heart attacks? So the initial experience, again, was here with the HeartMate 2. The US TRACE study essentially showed that if you bleed and if you are taken off aspirin, you will continue to bleed and you will not have more thrombotic events. So the European TRACE study essentially showed an a priori aspirin-free regimen with the HeartMate 2 does not lead to more thrombotic events, suggesting we don't need it. But that's the HeartMate 2. What about the HeartMate 3? This is a retrospective analysis of the Momentum trial where we showed that whether you're on aspirin 81 or on aspirin 325, doesn't matter. Same rate of bleeding, same rate of stroke. So 325 to 81, no effects. The big question is, what if you take the aspirin away? And you've heard a lot of knowledge we gained through little studies, 20 patients, 50 patients. That's the way, or used to be, the way of the left ventricular assist device. But here we have now embarked on a study globally where aspirin is used versus placebo. This is the ARIES trial that's ongoing that will enroll 450 patients, 350 already enrolled. And I want you to note this trial irrespective of the ultimate finding, because it is the first large-scale, randomized, double-blind, placebo-controlled clinical trial in mechanical circulatory support. So we really have entered a new era here where we will be able to test all these medications properly. So in conclusion, device thrombosis is now a rare complication. GI bleeding, I believe, will be resolved by creating pulsatility and adding AVM-directed medical therapy. Aortic insufficiency will be rare with truly pulsatile devices, and I haven't seen the data that Nia mentioned, the fact that aortic insufficiency, we can talk about this a little bit maybe, is less common in HeartMate 3. And my first questions right after will be, is this from the Momentum study? You know, is this adjusted for other variables? And is it really, I like the idea of the pulse that is so minimal, it's like a 5 millimeter mercury pulse. That's not going to open your aortic valve. But if there is a dyssynchrony with that in the heart, maybe you open it, we will see. And then I didn't talk about driveline infection, but it will not occur without a driveline, right? I can mention it just in one sentence. So that's all I have, and I'm happy to take some questions now or later, whatever works. Oops.
Okay, thanks, Julie. So Juan Carlos, if you had a question, do you want to raise it now?
Thank you for Dr. Uriel. Previously, do you believe, seeing the importance of the hemodynamic optimization of the patient during the ramp test, is there still a place for an only echo study for optimization, or should all be done with hemodynamics?
I think, first of all, to this part of the question, I think there is a place for echo, okay? But you need to remember that echo will not going to give you an answer. Don't trust only LV-EDD. Specifically, since I didn't go into it in detail, but the base of the heart is affected differently than the apex of the heart. I think in the 3Ds there was the green picture, you show it over there. So there is a room, the room is related to the aortic valve opening, but don't go only with the LV-EDD. Look at more parameter.
Thank you. And the second question, was it in the hemodynamic group? I believe in your paper only about 56 or something % of patients could be optimized, and about half the other patients could not achieve all the parameters.
This is at the baseline. This was a non-randomized, this is a cross-sectional study. In the randomized part, we successfully optimized 83% of the patient. So if you do an effort, and you try and you start playing with medication, afterload reduction and all of that, almost 4 out of 5 LVAD patients, you can bring them to a hemodynamically, what we call optimized situation.
Thank you very much.
I have a question for Uli regarding kidney function. Some time ago, we heard that pulsatility could improve kidney function. Do you have any information on HeartMate 3 in that regard?
I don't. I always wanted to look at this. What people observe is, as you may observe, that when you put the LVAD in, initially the renal function improves, and then if you just wait long enough, it seems to, the GFR seems to go down again after about 6 to 12 months or so. And we have never been able to look at whether this is driven by patients who don't open their aortic valve, i.e. receive non-pulsatile flow to the kidney, or not. I think we talked about this before. This is something, unfortunately, even in the momentum trial, I believe, or maybe not. I don't know if we have data on aortic valve opening.
So, yes, in the momentum trial, just to finish the aortic question that Uli said, we presented it in the last ISHLT. It's under review in JACC heart failure, and hopefully you will be able to see it soon. The rate of aortic insufficiency was exactly like the paper that Uli showed on the circulation heart failure, 9%, something like that, significant AI in 1 year, significant AI. HeartMate 3 was half. In every time point, 3 months, 6 months, 12 months, 24, it was half the rate. The aortic valve opening data does not exist in the collecting form. What we are doing now, we actually have the echoes themselves. And the study that Uli said about the cannula positioning from the alpha cannula to assess with aortic valve, we are rereading all those echo as a core lab, and we'll have a better answer for that. In relate to momentum 3 and kidney, Uli, and actually I think you should be added to this. There is a request for analysis. As you know, we can do only 4 analyses a year. So we meet the publication committee for Momentum 3 and we choose which publication. This is supposed to come in the coming year. And this actually would be one, I think, of the most important analysis, Martha, to answer this question once and for all, what happened, because we have so much data on creatinine, longitudinal, for 5 years, not 2 years, 5 years. You have to remember, Momentum 3 got an extension, and we're coming next year with the 5-year result of Momentum 3. So this question, we are going to do the analysis only on the 2-year data, but we'll talk it offline, but I think it's supposed to come in 2022 in one of the meetings, probably HFSA 2022.
Okay, if there's any question of the audience, and if not, we must go on with our next talk with the Dr. Lebrochon from Hospital Pitié in Paris. He's going to talk about the surgical management of the patient with mechanical circulatory support of long term. Please.
Thank you very much. So it will be difficult because Nir and Ulrich said that today there is no pump thrombosis, that tomorrow without driveline there is no infection, and that LVAD will replace heart transplantation. So I don't know if my talk is very relevant because I was asked to discuss of the surgical approach for LVAD in this complication. But I will try because I don't know the future, but in the present, we have still this complication. This is what you can see on this slide. For sure, with momentum 3, with ARTMET 3, we have less complication. And especially for thrombosis, pump thrombosis, it's something which is now quite exceptional, but it could happen. It could happen because, as you know, the pump thrombosis could be because of the device. It was true probably in the past, but it could be also because of the surgeon, like say the NIR, because of the malpositioning of the inflow cannula. I think I agree with NIR. I think it's necessary that the surgeon learn the surgery before to do the surgery. I think it's a good advice to avoid such complication, but it could happen. And also, there are a lot of reasons for pump thrombosis because of poor management about coagulation, because sometimes dealing between bleeding and clot is something which is not so easy, and also because you can have a graft kinking. If I can also tell you that probably with a small thoracotomy, minimal invasive approach, when you want to implant an LVAD, probably you don't control exactly with the same fashion that with a sternotomy when you perform the implantation, and for graft kinking, in our experience, it could happen. So you can have it's exceptional now with ARTMET 3, but it's possible to have a pump thrombosis, and in this situation, you have to treat that, and to treat that, you have medical therapy with anticoagulation, fibrinolysis, and surgery. And if we have to look what is the best option between surgery and medical treatment in front of device thrombosis, you can see, and we can find a lot of publication about that in the literature, but you can see in this nice meta-analysis published in ASIO 2 years ago, you can see that there is no picture. There is a big benefit for the surgical treatment. There is a better success in terms of survival, in terms of success, in terms of recurrence of thrombosis. So surgery for pump thrombosis, in my opinion, has a central place. Maybe this is the gold standard to manage this complication. But when we speak of surgery, it's necessary to know what technique we will use, which technique we will use. So first of all, it's necessary to identify the problem, the reason of this thrombosis. This is the first thing, because it will define the surgical technique. And in function of the surgical technique, we will choose the good surgical approach. It could be different. But we have to remove the clot, but you will see that what is very important for the surgical technique is to change the pump. And you can find also a lot of publication about that, and I chose this one because I think it's a nice publication from Yost, published this year, with 700 patients and 80 patients with a pump exchange, and they show that with the pump exchange, there is no difference in terms of survival with patients without pump exchange. So pump exchange is very efficient in terms of survival. You see on this picture that they perform for the thoracotomy, in fact not a thoracotomy, but a subcostal approach with an ARTMET 2 on this picture. And that's true that probably this lateral approach is very efficient. You can see on this slide, by example, the experience with just few patients, and this is what you find in the literature, a lot of small series of patients, and they did a comparison between sternotomy and the subcostal approach to perform the pump exchange, and there is a benefit for the subcostal approach in comparison of the sternotomy, because it's a shorter surgery, you have less bleeding, so it's something which seems to be the best approach. And this is what was published by Neuriel a few months ago also in this publication. But instead of subcostal approach, I think it's better to speak of lateral approach, because subcostal, it was true with ARTMET 2 in the past, but now with ARTMET 3, it's a little bit different. I know that there is no thrombosis with ARTMET 3, but in case of, if you have to remove and to exchange the ARTMET 3, I think the thoracotomy is a better approach than the subcostal approach, because I did it, and with the subcostal approach, it's not so easy. So probably the best option is first to control with echocardiography what is the position, the exact position of the pump to define the thoracotomy. especially if you perform a sternotomy before, which is, I think, today something which is very safe. With this small thoracotomy, you are just in front of the pump. If you need, this is for the surgeon, if you need to be comfortable, you can remove a rib, and like that you have a good exposition for the pump exchange. During the pump exchange, it's important to keep in mind that it's necessary also to correct the reason of the thrombosis, and especially to inspect the left ventricle to be sure there is no clot or no muscle or nothing else which could explain that. And also it's important to rinse to the tube to avoid a clot. And after, it's very easy to unlock the pump, remove the pump, and change the pump like that, performing an anastomosis of the tube and the other tube. So it's something which is very efficient. You have this publication from Imamura with Niroriel few months ago, and they reported that with device exchange you have good result. It's very efficient in terms of adverse event, also in terms of survival and of readmission. So it's something which is very efficient. So I think that we can consider that for pump thrombosis, the pump exchange is the gold standard, apart if you consider that you want to refer the patient for heart transplantation, and in this situation probably bridge to transplant could be an interesting option, and this is what we do routinely in France because it's a way to have a high priority level on the waiting list when you have a pump thrombosis. But it's something which is now quite exceptional, but in destination therapy, for sure the pump exchange is a good option. Now for the other complication, which will disappear in the future without driveline, but today we still have driveline, and we have complication, such complication. But when we speak of LVAD infection, it's necessary to know of what are we talking about, because there are non-VAD infection, general infection, other infection, VAD-related infection like mediastinitis, endocarditis, and VAD-specific infection. And it's not exactly the same thing, it's not the same treatment, and it's not also the same outcome. You can see by example that in the VAD-specific infection, it's not the same thing to have a driveline infection and a deep infection. It's totally different in terms of survival. This is what you can see in this Intermax report. And this is, oh, I'm sorry for the picture, but it was, believe me, it was the same thing there. For the driveline infection, when it's just an infection limited to the driveline, the survival is very good, in fact. But in fact, if you have a deep infection, infection of the pocket, infection of the pump, it's totally different. The prognosis is different, and this is why it's important to have a very aggressive approach. And it's important also to consider that, for sure, the driveline infection is something which is very common, very frequent, but it's not trivial. And it's necessary to keep in mind that it's possible to have an extension of this infection and a worsening of the situation. So it's necessary to be very aggressive to treat this infection by antibiotics, for sure, but also adding a surgical approach. And for the surgical approach, you will see that we have several steps, several levels. First of all, and this is probably the central part of this surgical approach, some general surgery. General surgery like a drainage of abscess, drainage of a collection, and it's something which is very important. And something you have to consider also is that on the driveline there is a velour, and in this velour there is some micro gaps. And this is a perfect home for the germs, bacteria, and other things. So if we have, when we perform the implantation, to be sure that we have no velour at the skin of the patient, this is the first thing. But after, when you have an infection, sometimes it's necessary to remove a part of the velour to avoid infection of this driveline. And I think it's very important to be very aggressive to treat this driveline infection, because it could be the first step to something much more difficult to manage. The next step would be to perform debridement. This is a general surgery intervention, but Debridement is something which is very aggressive, but also very efficient to control the infection. And sometimes to obtain the cicatrization of this wound, it will be necessary to have another surgery like muscle or omental flap. This is true for this driveline, by example. It's possible to do it, but this is specifically true for infection, abscess, or things like that for the pocket, for the pump. And to help us to obtain the cicatrization of the wound in such difficult situation, what could be very helpful is the negative pressure therapy, the VAC. It's something which is very efficient. We use it now quite routinely for such infection. You can see on this slide, by example, we see the pump in the wound, and with a vacuum therapy, with a negative pressure wound therapy, it's possible to control the infection and after to manage this situation. In our experience, we perform 3 heart transplantation with patients under VAC for a collection around the pocket, infection of the pocket, infection of the pump, with good result. All these patients were alive. And in the literature, the use of this negative pressure wound therapy is reported in small series of patients with exactly the same result and similar result of what I reported to you just before. The next step, the last step for the surgical management will be to consider the pump exchange or the heart transplant. So what about the pump exchange, the device exchange in a deep LVAD infection? This is something we can do, but for a surgeon, it's something which seems crazy, because in general surgery, to put a prosthesis in an infection context, this is something which seems crazy for us. It's a contraindication most of the time. So is it relevant to do it in such a situation when we have a deep LVAD infection? Well, you can see in this publication, they did a comparison for patients with a deep LVAD infection between pump exchange and patients without pump exchange. There is no significant difference. This is the same thing in terms of survival, and this is a meta-analysis. So, in fact, it's not efficient, probably, to perform such a pump exchange, but probably there are different situations, different patients, so it's not so easy to answer to this question. And in this publication, they report what I said before. Probably pump exchange is as a central place, or is the gold standard for device malfunction, thrombosis or hemolysis with the pump, but it's different for infection. This is what you can see on the left part of this slide. But you see also that if you decide to change the pump in an infectious context, it's possible, and the results are different in function of the time of the surgery. If you perform the pump exchange early, you have better result in terms of survival, in terms of recurrence of the infection, than if you perform the change after a long duration of infection. This is what was reported in this recent publication. Last but not least, what we can consider in front of an infection or in front of a complication for the LVAD is the bridge to transplant. So what about transplantation of patients with an LVAD infection? In this report, they have a similar result for patients transplanted with LVAD infection and patients transplanted without LVAD infection. In France, this is on the right part of this slide, this is the French report of Agence de la Biomédecine, which is the government agency. There is no difference in terms of survival between patients transplanted with infected VAD and patients on the standard waiting list. But probably there is bias because in France it's not a lot of patients transplanted with infected LVAD. But we don't see a significant difference. But if you look in the literature, we have meta-analysis to answer to this question, and infection of the LVAD appears as a risk factor of mortality after transplantation. It's with an hazard ratio of 1.3. This is what they report in this recent publication, but a few years ago it was exactly the same report. So probably this is a limitation of this strategy. But if we have to perform the bridge-to transplant, and it was the last part of my presentation about bridge-to transplant, and we can add bridge to recovery because this is the same challenge. Because I'm a surgeon, I have sometimes the feeling to be in this position, to be alone, to manage this nightmare. With a lot of people around, we give advice, you should do that, maybe it will be better to do that, but you are alone to deal with this situation. And if I have to share with you some tips and tricks, I can tell you that some classical recommendation for all the reduced surgery, for sure. It's necessary to have a systematic preoperative CT scan, for sure, defibrillation and peripheral cannulation for the CPB. Also, it's important, I think, to have a limited dissection of the big vessel, like we do for all the reduced surgery, and to control the outflow. This is the specificity probably for this surgery, and also to remove all the velour. It's very important for heart transplant because if you let some velour in the skin, and it's something which is easy because you have a lot of adherence, after with immunosuppression and everything, you will have abscess and such complication. We have that in our experience, and it was necessary to have a surgery after to remove this velour. So during the transplantation, we have a patient with an LVAD. It's necessary to remove all the velour. For sure. It's something which is very, very important, and this is probably the only specificity of this surgery. But probably it's not the only specificity. The other thing I want to share with you is that probably that the better tips and tricks I can share with you is that if you want to have a transplantation safe, I think that it's something you have to prepare during the LVAD implantation, because during the LVAD implantation you have to be prepared for the redo and to prepare for the redo. For that, it's necessary to have limited dissection and detachment. This is very important to avoid adherence. The discussion between thoracotomy and sternotomy, I don't totally convince. I will have a lot of difficulty to convince you to do thoracotomy for LVAD implantation systematically, like I heard a few minutes ago in another presentation, because I'm not convinced by that, and also because, especially now with HeartMate3, and I think that the surgeon will be agree with me, HeartMate3 is bigger than HVAD, so it's much more difficult, and also the ring is very small, and when you want to put the pump on the ring go in the ventricle and you see nothing, and it's impossible to occlude. So sometimes it could be very difficult. So I'm not really convinced by this strategy. I do it, but I prefer personally sternotomy. I think it's something which is safer, even if thoracotomy is more seductive and more marketing probably. Last but not least, avoid adherence is the key point for this surgery. And for that, two tips and tricks to share with you. First, and probably all the surgeons do that, you add a Gore-Tex plate. This is something which is very useful for the surgery. What you can do also is to put some Gore-Tex around the big vessel, like that. During the redo surgery, it's easy. You just have to find the Gore-Tex, and after you control all the big vessels. So it's very, very helpful. We do it also for total artificial heart, and it's the big difference. And the other thing I want to share with you is the use of resorbable hydrogel of polyethylene glycol, which is COSIL. This is what you can see there. It's a spray. It's distributed by Baxter. This is something which is very efficient. Very efficient. I have no randomized control trial to show you because we wanted to do it a few years ago in La Pitié, and in fact the surgeon refused because they believe in this approach and they don't want to do without COSIL. This is like light and night. It's a very, very different approach. And to convince you, I have this publication, which is a prospective, randomized, double-blind control trial about 30 children with congenital heart disease. They perform the chest close classically or using cos-seal. And for the redo surgery, the surgeon have a classification, you can see there, from grade 0 to grade 4 to define the level of adherence. And if I do a zoom in order you see something, you can see that there is no picture. There is a big benefit to use this spray to avoid adherence, and to use it routinely, I can tell you that it's true. So, to conclude about the surgical approach, which will disappear in a few years maybe, today LVAD complication still exists. It's like a sword of Damocles for this patient, a sword of Damocles, but for which the surgeon could have a place and the surgery have a central place for pump thrombosis, by example, because pump exchange with a lateral approach is probably the gold standard and very efficient. And for a specific LVAD infection, surgery is also very important and has a central place, probably just with general surgery, much more than with a pump exchange. And also, for sure, bridge to transplant or bridge to recovery could be an interesting issue, but it's another surgical approach. And as I said a few minutes ago, it's probably very important to prepare this redo during the VAD implantation. And now, just I would take the advantage to be in front of this panel of experts to share with you in 2 minutes an interesting clinical case which will probably become a surgical challenge. This is a young patient of 22 years old. He was in cardiogenic shock 2 years ago for a thyroiditis of Hashimoto. And I discussed of this case with Nir, with Ulrich, and with also Maria Crespo, and because we don't know what we can do for this patient. He was in a deep hypothyroidism. We decided to treat it with thyroxine intravenous and then with levothyrox. You can see there the echocardiography at the admittance of this patient. We have a poor ventricular function, biventricular dysfunction with 10 or 15% of left ventricular ejection, and we had to discuss of the situation. What would be the best option for this patient? Transplantation, total artificial heart. So we discussed with Nir and with Ulrich and Maria to help us to find a good option. And I don't know if we have the good option, but we decided to use two HVAD. So it's not an heart cyst, but it was a B HVAD. We performed the implantation at the apex of the left ventricle with a reinjection in the aorta, so something very classical, but with a good positioning of the inflow cannula. And we use for the right support an implantation on the right atrium to avoid suction and problem like that. And to do it, we put a Daquan tube graft on the right atrium, and we perform the implantation is in this Daquan tube graft. We perform this implantation in bridge to recovery and also in bridge to transplantation, because what I don't say it for you is that this patient was has a very big size, and probably he could wait a long time on the waiting list. The post-operative course was very easy for this patient, and we were a little bit surprised, but it's like that. We have the confirmation that it was an Hashimoto thyroiditis. With the myocardial histology, it was interstitial edematous fibrosis. And we use intravenous thyroxine and levothyrox during months and months and months to obtain normalization of the TSH. This is what you can see there, because during more than 1 month, in despite of that, the TSH were out of range. And after, it was necessary to have 1 year of this therapy to obtain a normalization of the TSH. And what about the heart? You remember the echocardiography of this patient, and you have few months later the echocardiography of the patient. So we had the feeling that he recovered, but now it's difficult for us to know if we have to cross the river for the recovery. And we decided to do a RAM test, but it's not a RAM test performed by NIR, so it's, I'm not sure it's exactly the same thing.
Next time, call me, I will come to Paris.
Yes, yes, we need you for that. And the problem is that it's very difficult to decrease the speed of the pump, especially on the right side, because pressure are still, we have a good outflow, and because you have low pressure in the pulmonary artery, but you see that when we decrease the speed on the two pump, we have no elevation of the central venous pressure, of the pulmonary pressure, so we have the feeling that this patient recover. And you see the echocardiography, and I have the two echocardiography, yes, of this patient. It was at 1800 ring per minute on the left and on the right side. And now the question is what we will do. What would you do? Because we are in front of this young patient. He's very well, he does sports, musculation, and now he wants transplantation or that we remove this pump. And we don't know what is the best option.
Wow, so this is a live case, right? This is like real.
This
is a real question. I actually remember you calling me, and I'm guessing you didn't listen to me, because I did say don't transplant him, but I said probably it will take some weeks, months to get better, put Centromec Vivat, which I'm shocked it took so long, right? So that was a good decision. Don't listen, never listen to the internist. So what do I do now? I mean, this looks, the RV is difficult to assess here, right? Because you're bypassing it.
Yes.
So that's really, because the RV didn't look so good, but I think it's because of the HVAT cannulation and bypassing it. You know, I think, is there a way to do a staged decommissioning? You know, I would probably decommission the RVAT and see what happens, and see if, you know, if the RVAT comes back, if the right ventricle comes back, or at least gets significantly better, then I think, you know, he's going to last, even with both decommission, even if he needs inotrope to get a transplant. He must then get some special status for him, you know. So that would be my suggestion.
I will be more brave. Okay? I think, first of all, a great case. And in this specific case, several elements about recovery. We do a lot of time decommissioning. Just keep the LVAD in, stop the LVAD, put a closer device on the outflow cannula. However, it's actually a bigger challenge on the heart on the long run. We are looking as, we need to stop talking about ejection fraction. We need to start talking about torsion and rotational speed. And the apical rotation of patient with an LVAD disappear, meaning that the torsion of the muscle is actually reduced. So if you really want to give this young kid a chance, you need to trust his heart. So what I will do is two things. First, I will go back to the pathology that you have, because you put a core. So you have the core from the LV, and the core, this core from the LV doesn't look like this is not going to be something that recovers. The mechanism here is a recovery mechanism. It's hypothyroidism. You have a beautiful LV. I think the RV will fly, Uli. I do think you have a RA cannulation, not an RV cannulation.
Okay, so we can decommission the RVAT because it's not in the apex.
Yeah.
And if that works,
decommission the
then
RVAT,
everything comes out.
and then you take everything out. Don't keep this guy with anything inside.
What we discussed was to, the next week, to inflate balloon in the two outflow graft to see what it happens. But the problem is that we can't inflate a balloon during a long time. But to see in the cath lab what it happens, inflating two balloons, one in the outflow in the pulmonary artery, the other one in the aorta, and to see what it happens. But
my prediction is it will look fine. I just don't know that I would trust the acute response for him to last. So
again, advantage.
I would do it for sure. But
advantage that you have here, you have a HVAD. In that regard, it's a much better recovery device. And the reason is the outflow cannula is 10 millimeter, not 14 millimeter like the HeartMate 3 and the HeartMate 2. So you can use all the technique that is percutaneous and not a surgery. Number two, I'm very, very impressed by this. Again, if we're taking what we do to routine evaluation for that, not a BiVAD, single VAD, our routine is to lower the speed to a low speed and keep a patient with a swan and let him walk around for 24 hours to 48 hours and see how it is. And I think the problem with an HVAD, it can clot.
On the right.
On the right,
yes,
it will clot.
For sure. And another thing to consider maybe for the surgeon, when we perform an AirVAD implantation with an HeartMate 3 or an LVAD or HVAD is the same thing, it's necessary to have a stenosis on the outflow graft. Because without a stenosis, with a low speed, it's possible to have a very good flow. And this is the limitation we have now, is that even when we are at 1800 rings per minute, we have a flow of 2 liters. And so it's something which is, I think, important to consider in such a configuration. Thank you.
Bravo.
So
amazing.
we're going to jump into the cases to see if we can apply some of things we learned. There's a question? Oh, sorry.
May I ask one question? Dr. Lebreton.
Yeah, well, you know, while Pablo Catalá is getting ready, maybe you can take this question. Go ahead. Pablo Catalá, if you can come to the floor.
Alexander, ask the question. As the next speaker just came here. Ask.
Oh, sorry.
Dr. Lebreton, only one quick question. Omentum transposition for the chest during the exchange of the infected device or transplant. Do you perform routinely omentum transposition to protect a new device or protect a new heart?
I don't hear the beginning of the question.
Omentum transposition. You mentioned omentum transposition only for management of the local infection of the driveline. But if you exchange the infected device or you make the heart transplant and the mediastinitis, do you use omentum as old-fashioned but effective?
We use omental for mediastinitis, yes, for sure. We use it. This is what we do also in cardiac surgery. We use omental because it's more difficult to put a plate of Gore-Tex in this context because it's a little bit septic. And the omental flap is a good option in infection, probably to treat this infection, to fight this infection. So we do it for mediastinitis typically, or when there is a defect in a big or a big wound or something like that, to cover the pump, like on the picture I show you.
Amazing.
Just one question. Do you sometimes just relocate the driveline? Because I didn't see in your algorithm, just if you have an infection in your left side, you just can put the driveline in the right side and just treat the infected side with a vac or with debridement with that submit, and you have the driveline in a non-infected side. Do you use it?
Yes, when there is an infection of the pocket, it's necessary to treat that with some general surgical consideration, drainage and debridement. And what we did several times is to perform thoracotomy, to rinse, to have a lot of drainage, like for mediastinitis or another thing. And for a few patients, we had to add a negative pressure wound therapy. And first we did that to try something because we were in front of a very critical situation with an infection. It was, for one of these patients, it was with a fungus, with a, we did that, and in fact, with that, we obtained the control of this infection, and it allowed the transplantation of this patient. And we have 3 patients transplanted like that. And for one of these patients, we still have a big perforation in the chest wall. It was like that. When I did the perforation, I had a perforation in the chest, but he totally recovered. So it's, I think for infection, it's necessary to be very aggressive, like a surgeon.
Thank you very much. Okay, so we have Pablo Catalá here from Hospital de Bellvitge, who's going to present a case on medical and device optimization.
Okay. Okay. Well, I will present a clinical case to show how we measure non-invasively here congestion and right ventricular failure in patients with an LVAD. So we are going to talk about a patient. She's now 76 years old. She has a non-ischemic cardiomyopathy, which was diagnosed in 2013, and she was referred to our center in 2015. We decided that she was not a good candidate for heart transplantation, so we finally decided to implant an HVAD in this patient on the same year, in 2015. So the first years after the HVAD, she had several admissions because she had gastrointestinal bleedings. Following these bleedings, she had an ischemic stroke because she had to stop several times the anticoagulation. Fortunately, she completely recovered from this stroke, and the thrombus did not make any obstruction in the pump. The same year, in 2021, she had a pacemaker implanted, and later on the same year, during the last month, she started to have an a heart failure. She required several admissions for this reason, and this seems to be related to a problem with the aortic regurgitation that has been worsening during the last months. And on the first admissions, we first decided not to implant a TAVI because we thought that the risk of moving the thrombus and having a new stroke or moving the thrombus inside the pump was quite high, so we decided just to wait and see with medical treatment. But she had a bad evolution. She started with refractory congestive heart failure. She started with worsening renal function. She started with dizziness and low outflow symptoms. Here you can see her echo at that moment. She has a severe aortic regurgitation. She has also, a severe mitral regurgitation. Here you can see that the aortic regurgitation is a continuous flow.
Wow, nice.
And here you can see one of the main topics that we are going to talk about is the renal Doppler. For the ones that are not used to this technique, is you have to look for the kidney with the echo, and you have to search for a point where you can see an artery and a vein, one next to the other. And here, on the top of the line, you can see the artery flow. As the patient has an HVAD, obviously she has a continuous flow. And on the venous Doppler, I will explain it with this picture. This is obviously a patient that has not an HVAD, but the venous flow works in the same way. So here, in a patient without any congestion, in letter A, sorry, you have a continuous flow, and as the patient starts to have more and more congestion, she starts to have a pulsatile flow in the vein, but she still has no time of stasis. She has no time without flow. So if the congestion continue and worsen, you start to have a pulsatile Doppler, but you start to have more time of stasis, and if the congestion is severe, you start to have a diastolic flow, and most of the time with stasis without no flow. So if we evaluate this Doppler of our patient in this moment, we can see that she has an only diastolic flow, and most of the time we have no flow. She has stasis. So we usually estimate the stasis index, that is what percentage of the cycle length has no flow. And here, if we treat this patient with diuretics, you can see that the flow, would be like this. You can see how now we have a big diastolic flow with a small systolic component, and the time without flow is much smaller. So in this case, that means that the treatment in this patient is working. Here we also evaluate the portal vein. So the idea is the same. If the patient has congestion, the portal vein will come more and more pulsatile. So finally, these patients start to have several admissions, so we decided to take the risk and we implanted TAVI using a Sentinel, a cerebral protection device. And the TAVI was all right, and she could be discharged on the next days with 2,420 RPMs and with 2.3 liters. Unfortunately, she had a new admissions a few days after the TAVI because she had low flow alarms. She persisted with low flow symptoms. She has no congestion, but she has low outflow symptoms and low flow alarms that she has never had before. So on the first days of admission, we optimized the preload and the afterload, but she continued to have low flow. We did a RAM test that showed that the pump was working all right. Here you can see her echo at that moment. Here you can see that obviously she has no aortic regurgitation anymore. She has a, she has a moderate mitral regurgitation. We know that this patient, and we know that when she has a mild mitral regurgitation, usually it means that the left ventricle is too small and we have to decrease a little bit the revolutions. Here you can see her diastolic diameter when she's on euvolemia, and here you can see her cava vein. So after having optimized the preload and the afterload in this patient, and after a normal RAM test, and knowing that she was more or less on her euvolemia, we started to increase the RPMs. So we tried this several times, but we have the same result. On the first moment, the right ventricle seems to be working all right, but on the next day, we saw this. We saw that the right ventricle started to fail. You can see here that now she has a mild mitral regurgitation. She has a much smaller left ventricle. You can see also that the right ventricle is bigger. Here we now have 38 millimeters when she used to have 48. Now you can see that the septum, is moving towards the left ventricle. She has a worsening tricuspid regurgitation. So how did we interpret the situation? We think that as the aortic rotation has been worsening during the last months, probably a higher percentage of the H-valve flow has been recirculating, so the actual anterior flow has decreased over the months. So probably the right ventricle has been working with much less flow than we previously thought. So at this point, we tried to use the renal portal Doppler on a patient on euvolemia to try to evaluate or to predict if the right ventricle was working right with the new flow that the H-valve was given. So my question to you would be, in this patient, which renal Doppler suggests a better right ventricle to increase the H-valve flow? A continuous flow, wider pulsatile flow, or a smaller flow? Okay, so no one has. Sorry? Sorry. Yeah. So here on letter C you have a continuous flow, and the other three are pulsatile. The one, letter A, is more wider, no? D. Well, for us, we think that probably. D. Okay. We think that probably the best Doppler would be letter C, because we think that if the patient has a continuous renal flow, it means that the right ventricle is working with the correct preload, that is not overload. So what we started to do in this patient, we started to increase the revolutions only if the echo, the renal and portal vein parameters suggested that the right ventricle was working fine with the new flow. And what we saw is that after small increases in the RPMs, even without any changes in the echo, we saw that the renal and portal vein suggested that the right ventricle was starting to fail. So with images to show you what we did, on day one we started with 2,440 RPMs and 1.8 liters, and we can see that the renal Doppler had a continuous flow, and the portal vein had more or less a continuous flow, so we felt confident and we increased 40 revolutions per minute in this patient, and we had 2.2 liters. On the next day, we can see that the renal Doppler has worsened a little bit. We have a big diastolic flow, a small systolic flow, but still the time without flow, the stasis time is quite small. So with this data, we still feel confident, but not as much as before. So we only increase 20 revolutions per minute. And on the third day, with 2.5 liters, we can see that now the renal flow has worsened much more. We have only a small diastolic flow. We have a lot of time with stasis without flow, and the portal vein is much more pulsatile. During these changes, we didn't see any changes in the right ventricle and the left ventricle. So with these changes in the Doppler, we decided to wait for one more day. And on day 4, we observed that the flow has increased a lot. We have 3.1 liters, and we saw that the right ventricle seems to be working better because we can see that the time with stasis is much smaller and the portal vein is continuous. So with this data, we increase a little bit. Again, we have the same problem on day 5. With 3.2 liters, we saw that the right ventricle seems to be failing again. We have a diastolic flow with most of the time with stasis and a pulsatile portal vein. So we stopped for 2 days and so on. On the 7th day, we saw again how the portal vein has improved. We have a diastolic flow with a small systolic flow. We probably with these Dopplers, we would increase again, and so on, so on. And so after 11 days, the HVAD could be optimized, and we could discharge the patient with 4 liters per minute, more or less. At the moment, the patient has had not any new low flow alarms, and she's doing fine. She had recently an admission because she had a COVID pneumonia, but she has no problem with the HVAD, and she could be discharged. So my take-home message is, just talking about the Doppler, would be that we know that renal and portal Doppler helps to evaluate congestion in all patients with heart failure, and we think that probably that could be helpful also in patients with an LVAD. Obviously, we have a lack of evidence. We have to build this evidence, but we think that it provides an additional information that could be useful. So thank you very much.
First of all, this is a cool case and a cool utilization, something that I'm not doing. I'm not doing the Doppler. It's very interesting. I learned a lot from this. But there is a couple of very important teaching points here. AI, always we blame AI and the aortic valve is not open. There is an open question whether RV lead to AI and whether AI lead to RV. Let's say you have RV failure. You don't have enough flow coming to the left side. You don't have enough flow coming to the left side. The aortic valve is not opening, and then you develop AI. When you have AI, you have increased pulmonary pressure. You increase pulmonary pressure, you're going to develop AI as well. So there is an egg in the chicken here, and nobody can know. And in this specific case, second thing is about HVAD. 2 things. Number 1, HVAD have the Lavaris cycle. And I don't know if this HVAD, the Lavaris cycle, was open or not open. If it was open, the rate of AI, because the HVAD is too strong, is very, very low. This is a nice project that DSAR did, now is in Leipzig. He did it when he was in Düsseldorf. And that's the reason it's linked more to the RV failure be the original issue for this specific patient. The second thing, HVAD is a pump. In a speed of 2200, it gives really minimal support, and you show it here, 1.8 liter. Usually HVAD, you run the speed in between 2600 to 3000. That's the range of the speed that you run. So this is very interesting to see that eventually you got to those speeds, but in the beginning you were in a speed that you still had moderate MR. That I don't know if, again, the MR is because of the AI or the MR because you don't unload enough the ventricle. And there is a nice paper that Manrit did with us from the Momentum 3. We demonstrate the MR go away in most of the LVAD patients. It doesn't stay. So if it stays, there is a problem. For me, I bet the RV was not a starter RV to begin with, and you need to crank the speed all along.
Okay, if there's any question from the audience. So we are going to carry on with the next speak about low floor alarms. Thank you, Dr. Gonzalez.
I must congratulate Pablo because he did all this by himself, and he really was very patient, you know, because originally, as you said, the speeds were very low, but that was because we were getting low flow alarms continuously. And the septum was going towards the LV. So after the implant of the TAVI, it really changed his physiology completely. So we needed to adjust, and that took us a lot of time. And really, the data we got from the venous congestion was very useful in actually doing a very careful transition. Obviously, if we had done it with the Swangans, it would have been more elegant, but then it took time also.
What was the reason not to do it with a swan?
Well, she was, she's a 77-year-old lady, and, we decided to try and do it without a swan, basically.
7 days.
It's more elegant without the swan. Maybe more efficient with a swan, but more elegant without.
Yeah, but also if you cranked up fast, the RV didn't tolerate. So that is also something that has to be taken into consideration. Okay, I'll go.
Super nice and extremely novel.
Beautiful.
Really good.
I'll go into my presentation. So this is a 55-year-old woman from Bolivia with trigastric cardiomyopathy with ICD, CRT, Intermax 3 despite optimal medical therapy. She's severely sensitized, so we didn't think she was a good heart transplant candidate. So when we implanted HeartMate 3, she had good social support, just had a little TIA in the immediate post-op period. And basically she was doing fantastic. The only thing is she gained weight. She was on all the medication we know. And so in November 2020, she had low flow alarms with postural changes, increased dyspnea and orthopnea. No weight increase, no fever. She also had a pain in the left thoracic area that worsened when she leaned on the left side. She had a mean arterial pressure of 75, which was a little bit higher than her usuals. Everything else was pretty okay. She didn't have edemas. And the flow was just slightly lower than her usuals, and she was on 5,400 RPMs with a PI of 3.5, which was quite similar to previous, and the power was also 3.5, which was quite similar to previous one. So she only had one episode of low flow, and this is the echo at this point. So she didn't have AI, but what was new was that MR. She didn't have that MR before. And LVEDD was just slightly a little bit more dilated. You can see a little bit of aortic regurgitation, and that was basically it. So this is also the echo, and we also showed that the RV was okay, but she had a TR that seemed more important than usual, with systolic pulmonary pressure of 45 and an inferior vena cava of 23, which was dilated with inspiratory collapse of more than 50%. So at that point, we decided to increase the vasodilators, increase the furosemide, which she had actually started 3 months before she didn't need furosemide. We started the furosemide 3 months ago, and now we had to increase it. We hadn't made any changes in the RPMs, so we decided to see how it went, but next day she came back with persistent low flow alarms and poor response to diuretics. The diuretics didn't do anything on her. The echo was quite similar to the previous one, moderate MR, moderate severe TR, dilated inferior vena cava. Blood pressure was similar, heart rate 60. She did have a little bit of regurgitation, and the flows were on the low side. Power was okay, but she had 5 episodes of low flow. So we did an ECG, and we interrogated the ICD. There were no evidence of arrhythmias. We got some blood analysis. Kidney function was her usual. The only thing that was different was the NT-proBNP, which had increased from previous ones. LDH was normal, and haptoglobin was inferior to 0.1. Hemoglobin was 13. We don't have plasma-free hemoglobin here, so we can't. And she was congested, okay? So we performed a ramp test, and basically here you can see in the bottom, we just increased RPMs, and basically the LV did not change at all. we weren't able to increase the flows. So here you can see 7,000 RPMs, and basically the flows are basically the same. So we didn't manage. We didn't correct that. MR was still there despite the increase. So here's the question. Can we have the answers, please? So first, is it an LVAD thrombosis? Perform thrombolysis. Definitely an LVAD thrombosis, as Guillaume said. Let's perform an exchange. Proceed to surgery. You know, she's not that bad. She's not in shock. Anticoagulates, add heparin, or I need more data. Perform an angio-CT scan. Okay, so we can show result. So most people will want. Ponemos la diapo. Uy, esto se ha movido. So this has. We can't turn the image. Podemos. Es que se ha torcido esto. Okay, so here you have the LVAD. Okay, so here you can see. Well, no, not now. There was. Gracias. Okay, here we have, no, don't know why it turns. Anyway, the LVAD, here you have the outflow graft, and here you can see that there's something occluding the outflow graft. Okay, so the patient here is hemodynamically stable, mean arterial pressure is 65, normal lactate, INR is more than 2 in the last 3 months, so we stop the antivitamin K, and we actually give vitamin K to reverse, and now what do we do? So if you don't know, we ask for help. So I actually contacted Uli, you know, I sent him a WhatsApp and said, you know, sent him the image, you know. So he told me I needed to do an angiogram as the next step, and, you know, whether stenting could be a possibility. As it happens, they had just reported a case of outflow graft twist. And he actually puts me in contact with Danny Goldstein, which is the surgeon at Montefiore. So he agrees that it's probably an outflow outflow tract twist, because I actually confirmed that it is before 2018. So there's this paper, Tale of a Twist in the Outflow Graft. So basically what happened with the HeartMate 3 is that this connection actually twists. So maybe the surgeon can explain it better, but basically it turns if you don't fix it. And so after this was reported, all the HeartMate 3s got a clip. I believe now it's already solved this problem, but this patient was implanted in 2017, and this was a problem of all implants then. This was published in 2018, and at the end it says you have to either surgically repair it or graft replacement. Doesn't say anything about stents. So here's the paper that Uli actually published. Mercedes is the first author of this paper. So here you can see the angiogram. Here you can see the CT reconstruction. And what they did was, what they say is, due to the nature of the obstruction, it is uncertain if percutaneous approaches can be successful. So what they did was open, untwist, and place a clip so that it doesn't happen again. So I looked into the literature, and this report from Cardiologia Polska showed that they had a similar case, and they actually stented it, and then this is at heart transplant, and this is how it looked. So you can actually have this solved with a stent. So how do you stent a HeartMate 3? Well, I didn't really know at the time, so Uli put me in contact with Jose. So we actually communicated, and he recommended the Venovo stent. So that was good advice, because then I was able to meet up with my interventionalist angioradiologist, and help them a little bit in this. But this all happens kind of, this was a Saturday evening here in Spain. So we were preparing to see what we were going to do. We were reversing the anticoagulation, but Dr. Galvan calls me at 6:30 that the patient is hypotensive, continuous low flow alarms, continuous opening of the aortic valve, no diuresis, so we start inotropes, we start norepinephrine, we stop the heparin because of an APTT of 3.5, we increase the LVAD as much as we can, and I get in touch with Dr. Miralles and Dr. Jonathan Houdanin, who was the angioradiologist on call. So they actually make a nice reconstruction, and here you can see how it's the twist here, the twist of the outflow graft. So when we explain this and whether a stent is possible, he says, of course it is. You know, why wouldn't it? You know, it's just, he explained it very nicely. It's like if you twist your sock and then you want to untwist it, you just put in your foot and it untwists. And this is what happens when they put the stent in. Something, you know, was a concept I wasn't familiar with. So we do, he didn't know what a HeartMate 3 was, obviously. So we had to explain, you know, what it was, how you could do it. So the patient's lactate was normal, so, you know, we actually planned the procedure, arterial femoral access with micropuncture kit, percutaneous to be able to have a percutaneous closure afterwards. We calculated the size of the Venova stent that he needed according to the outflow graft diameter and the measurements in the CT scan. So patient is in continuous low flow, but normal lactate. So we did further procedure to correct the anticoagulation. So I actually tell Uli at kind of like 3 o'clock evening here, it was probably morning in New York, you know, we're doing the angio, and he's surprised because patient did not go to the OR.
You need to charge your phone, it's 2%.
Yeah. Well, I was working the whole night. So I said she was actually relatively stable. INR was high, and we're actually going to try the stent. So I'm actually wondering why they didn't do the stent, because it was very similar to ours. So I show him, this is actually the angio picture. So we have done a case like this, say Zuli with equal distance twist to the pump. It looks a bit scary, but actually you have enough distance. To be honest, I feel surgical untwisting may be better. But you need angio to really decide this. So he actually logs in Potapov, who's golfing somewhere in Crete or somewhere like that. So he actually gives us some advice, but actually Jose is also logged in, Potapov is also logged in, so I'm with my phone kind of dealing with all this. But in the meantime, our man is actually doing the job, and he gets it done without all the info around, and he actually does a great job. He stents it, and immediately the flows go up, and you know, patient is discharged 5 days later with clopidogrel and Syntrom, and she's doing well. That's it.
This is great. Yeah, this was an amazing case, and I have to say, we have since published a paper on the technique, how to do this with all these catheter maneuvers. But the best part was the global consortium. I think Yevgeny was playing golf in Crete or something like that. I'm in New York and you're here. And then this communication, which is so beautiful about our niche in the field where we know each other and we solve these problems, which is incredible. There's a paper right now in review I guess it's in JHLT now, large multi-center, lots of cases that showed that this is about 5% over the first 2 years, I think, like 2% per year or something like that. I'm trying to look up the exact detail, but it's in review.
This is 5% in the time prior to 2018. It's very important that after the clamshell was introduced, you don't see it anymore. But what you see is different. What you see is the
outflow graft obstruction from the exterior compression.
Exactly. Yeah. Outflow graft obstruction due to the biodebris. Yeah. That it's related to your talk, actually, Guillaume, because you mentioned to put the Gore-Tex. The more Gore-Tex you put, the more biodebris you're going to have, because there is no breather to this. So we just published a series on 100 CT that we routinely evaluate, and the rate of biodebris was much higher than we appreciate. And I think in a destination therapy, we need to think 3 times before we do too much Gore-Tex. And I know that I'm not the surgeon.
What we do also is that we put Gore-Tex plate, but systematically, I don't know if you do that in your center, but systematically we put a tube reinforced around the outflow graft, systematically, to avoid compressure, extrinsic compressure with hematoma or things.
Inside of the bench relief?
Outside of the outflow graft, we insert the outflow graft in a Dacron, not a Dacron, but a tube reinforced, and like that you have no kinking and no extrinsic compression. And with that, it couldn't happen.
You don't see the biodebris.
Yeah, systematically we do that.
Sorry, so you have the graft, you have the bent relief outside.
Yes.
And you put between the graft and the bent relief, that's where you put something?
We reinforced the outflow graft.
Yeah.
Not the first part, because there is something to protect.
The bent relief,
but yes,
yeah. Okay,
but
higher up.
For the other part, we systematically add a tube of 20 millimeters reinforced.
Yeah.
And this tube is a good protection for that, and also for the sternotomy. When you will have to transplant the patient, if you have that, you protect your outflow graft. Okay. And you avoid compressure, you avoid...
Joe is frowning. I think
what's
he's
the
reading
tube?
my mind.
What's the tube made of?
What?
What's the tube made of?
Yes.
What is it made of?
The material.
The material, it's a Gore-Tex reinforced, and we take a tube of 20 millimeters.
Okay, but it's already
Gore-Tex, I
made.
think it's Gore-Tex, yes.
But
PTFE.
But the diameter is bigger than
Just
the
show the
outflow
picture
graft.
again, Joe. Can you show the slide that you had where you show the
They've taken it off.
reconstruction or something?
¿Podemos poner la presentación previa un momentito?
Because I'm not sure that, I think this may actually make it worse. Maybe I don't understand.
La mia última. Esa.
No, but Uli, now they have the clamshell. So they took both the clamshell and the...
Yeah, but you know, the issue occurs actually within the bent relief section generally, right? So there,
yes.
You know, so you put where this is, you don't put your new thing, right?
Yes, but we speak of 2 different things.
Yes.
Concerning the skinking.
Twist, forget
yes,
it.
This twist, yes, it's another point.
Yeah.
Because I think that, personally, I don't really believe in the rotation with the time. I know that Potapov speaks a lot of that.
Yeah.
I'm not really sure, because I think that something which is important to consider is the implantation technique, because what is recommended by the company is to perform first the implantation of the tube, the implantation of the pump, and after to connect.
Yes.
And I think this is the issue, because you have a risk with the screw to have this kink. But if you perform the connection of the outflow graft first, and you connect and you fix everything, after you put the pump in the left ventricle, you start the pump, you inflate your tube, and you perform the anastomosis like that, there is no kinking.
Right.
And after you protect the outflow graft, the last part of the outflow, you protect that by a tube reinforced, to protect that, to avoid compressure, to protect the sternotomy, and to avoid compression with an hematoma, or other things.
Yeah. So I completely agree with that. The mechanism here, you can see a picture like this, even without the twist. just the way the material seeps between the bent relief, the plastic, and the outflow graft. So I think this will still occur even if you stabilize what you're describing, if you stabilize the graft more distally. I'm a little bit concerned that actually it can also occur between your stabilizing material. We have had cases like this where we wrapped it with Gore-Tex to protect it and for transplant and all that, and then the material, this exudate, actually collects there. It's like the graft is sweating, so to speak, and then the sweat cannot go away.
No, it's not possible.
Yes.
Yeah.
There is no space for the thrombus to get in between the tooth.
Yeah, it's not thrombus.
It's
biodebris.
the material. It's the material. Yes,
It's
like
this
not the
material, yeah.
But I think there is no possibility to have a space in between the protection and in the tooth. It was difficult to see if it was thrombosis inside the tube at the beginning. But it's strange, of course, no? Because I know that there had been some thrombosis of the outflow tract, but it's not the most usual. Without thrombosis of the pump.
Yeah.
So do you systematically in Paris or in Barcelona evaluate what is your rate of biodebris? Do you do it systematically, or you just feel that you don't have it?
A rate of what?
Meaning, the paper that we just published now in the Annals of Thoracic Surgery, we took 100 patients and they got a CT, and we saw exactly what Uli is saying. This is much more common than we think, and actually we are not evaluated. Sometimes we don't think there is a problem because we don't test for it, and only when there is a disaster like here, you know about it. Do you systematically evaluate for the presence of biodebris?
Yes.
Yeah, so you do the CT.
Systematically, yes.
And there is no, so with this technique you don't find it.
No.
So this is something that is very important, I think, to the community, because right now, the amount of paper coming out about it, it just demonstrates how many centers are struggling. And again, this is a different story, because this is a twist. This is history.
Yeah.
But biodebris is very relevant.
Yeah.
And we will touch base after, because I want that will connect with my surgeons, because I still see biodebris. And it's not so easy because you need to operate on them. Biodebris is not always withstand. Twist, you can do this. Biodebris, you have to take it out.
In interest of time, I'm sorry, but I think we have to move on to the next case. That's going to be presented by Lola Garcia Cosilla, and it's going to be about driveline infection.
When?
Hello, good afternoon. So don't worry, I'm going to keep it simple. Last talk, I know you're tired. And
we want surgical consult now.
So I'll be fast, and after Dr. Leberton talk, it's hard to try to impress the audience with any driveline infection. But this is a clinical case that is actually an old friend of Dr. Leberton, because this 54-year-old man actually had the big part of the history, the past history in France while he was visiting a family. He had ischemic cardiomyopathy, and he was in Spain. But when he was visiting the family, he had an acute anterior myocardial infection. He was diagnosed with 3-vessel disease. Soon after that, he had an inferior acute infection and a very complex percutaneous revascularization. After that, he was supposed to come back to Spain, but he didn't have time to do it because he developed heart failure. And he got to the hospital with acute pulmonary edema. He could be discharged, but 4 months later, he developed cardiogenic shock. He was implanted with a VA ECMO, an Impella due to pulmonary congestion, and finally, 14 days after the ECMO, he got an HVAD in La Pitié. He was very early after the surgery. He had 2 driveline infections that were very mild with Enterococcus and Pseudomonas. And he was finally discharged in September 2019. He finally came to Spain, and he went to the GP and said, you know, I had some liquid coming out from my belly. This was in the Canary Islands, where they usually don't have a lot of LVAD implants. And he went to the hospital there, and he was diagnosed with a driveline infection, with a purulent exudate, with a Pseudomonas sensible. The blood cultures were negative. The TE echo was okay without any vegetation. And the PET-CT showed pump infection and fistula. He was treated with antibiotics, with daptomycin and Veronem, and then he was transferred to our institution. In the initial evaluation, the patient was looking pretty good, despite of the CT, the PET scan that he had. The Doppler pressure was okay, the pump was okay also, and all the labs seemed to be okay without any inflammatory or reactant signs, and the blood cultures were also negative. This is just to see the picture of the pump and how it was functioning okay, and we did a right heart cath that was okay. And this is how the driveline looked like. The culture of this purulent exudate was positive for Pseudomonas, and he was switched the antibiotic treatment because it was resistant to colistin and gentamicin, so we treat him with ceftazidime and ciprofloxacin. These are the results of the PET-CT that showed severe inflammation of the pump, the driveline, but also the femoral area, the axillary area. And the patient was in such a good condition that we were not sure of how much we should trust this exam. So this is the question. It's going to be easy because we had a very nice talk before. You can answer if you could put the question. I don't know if it's working. Okay, now.
Yes, I'm very happy because after the last presentation, the last case, I have the feeling that I wasn't very convincing, but I see that it's not true.
That's why we did it, so that you could be happy today, this afternoon. So if we can go back to the presentation, please. So that's what we did. This was our surgical approach. We did a driveline externalization, a wound debridement, driveline detachment, and we washed the area with hypertonic and amikacin wash, and then we used back therapy, as has been commented before. We did surgical review every 48 hours and closure after 12 days of this treatment with 2 negative cultures in the middle. This is the evolution of the wound that looked pretty good, and actually the cultures became positive again, but we did marked white blood cell and nuclear scan, which I think it's maybe more convenient for this evaluation, and it showed only infection of the end of the driveline. So this was the treatment when the patient was discharged, and he was on antibiotics, which we were planning to maintain for a long time. This was February 2020, and we list him for heart transplant because when you have a driveline infection, you have some prioritization in Spain. And he was very lucky because he got a heart transplant March 6th, just before the pandemic exploded in Madrid, because after that we just didn't do any other transplant. And now the patient is doing fine. He also got a COVID infection, but it was very mild, and now he is okay.
I think the surgical consult, Professor Le Breton, we called you on the beginning.
No, it wasn't in La Pitié. It was in France, but in another institution.
It was in La Pitié. It was in La Pitié. He was asking for you.
No, it wasn't in La Pitié for sure. But no, I think this is a good illustration of what I said before. It's an aggressive approach, a surgical approach for the infection to avoid to have a worsening of the situation. And after you have a stabilization, for the patient it's better. And we can consider after transplantation in a good situation with a controlled infection. So I think it's a good illustration.
You know, Guillaume, I don't know if you do this, our surgeon now, they put a small wound vac at the time of implant, like for the primary closure. And this has, I think we'll have a little thing at the ISHLT. We didn't come up with this, some other centers did. And that has really reduced our infection rate, seemingly. Like right at the time, yeah, I can connect you with Danny to how exactly they do it, but it's a small bag on the wound.
There is something like that, which is by Smith and Nephew. It's Pico, Pico 7 or something like that, because I use it for sternotomy to avoid.
They use that.
Yes, to avoid, and it reduced infection. Yes.
Yes.
Oh, okay, it's interesting. Yes.
Yeah, it will work very
Maybe
well
it makes
for us.
sense.
How many patients do you think that surgical approach is enough to control the infection and not to have to heart transplantation? Do you think the surgical approach, only surgical approach, is enough? Or how many patients? Or what percentage?
No, it's. I don't have. I can give you my feeling, but I have no number to share with you. But when you have an aggressive approach, a surgical approach, early, it's like this morning, early VAD, but early surgery also. If you have an early approach, early in this infection, you avoid a worsening. If you await after, with the time, it's not just limited. This is a deep infection, and you have after a fistulization, and you have infection of the pocket of the device. It's not the same things. So it's necessary to be aggressive early in the infection, for sure. And with that, most of the time, you success. It's a success to control the infection, and in our experience, it's like that. Because when you have an infection of the pump, it's not the same. It's not the same thing. In this situation, we do a drainage to control, to do everything, but we go to heart transplant when it's possible.
Guillaume, I think what you're saying is relevant in LVAD, in all field of LVAD. With driveline infection, Joe, I know that your case ended very nice, but I think also with twist and outflow cannula obstruction, you need to fix it as soon as possible.
Yes, for sure.
Because the patient can crash, so you were very lucky here. I think it's true for a lot of other elements. In LVAD, you need to act. It's not a subspecialty in cardiology that you have a lot of time to philosophical investigation. You really need the surgeon, the cardiologist to act very fast together.
It's a mechanical problem. Fix it. I would say that we avoid, I agree, with the driveline infections, which are more common with the HARPMate3, right, than with HRAD, for example. I would say 90% of cases we will avoid the need to exchange a pump for the infection, or even go to emergent transplant within our new system.
And something...
when you do it early,
Something I can also share with you is that on this picture I have seen that they did a contra-incision before, and we did that before, and now we stopped. We do the exit of the drive line just under the subcostal, with no contra-incision, directly like that. Yes, and it's much more stable. We don't do a loop like that.
Yes.
It's much more stable. For the patient, it's more comfortable, and we have less infection. I think it's something important, because before we said it's better to have a long way to avoid infection, but it's not really true. It's not stable for the patient. It's not good because it's not comfortable. So I think it's better now to have a direct way, just in subcostal. It's more stable and with less infection. I think it's better.
But the best is to get rid of the drive line.
For sure.
Yes. One question, Dr. Garcia. Dr. Garcia, was the patient... Was the patient in back therapy previous to close
every time.
Previous to close
the wound, you
yes.
mean?
Was the patient previous in back therapy?
So he went to the OR, and after he went to surgery, he came out with the back therapy, and that stayed for 12 days. Yes.
In my hospital, we usually use 2 mini thoracotomies to implant Harmony 3, and the dry line the dry line not only directly one incision. I dissect the muscle of obliquus major muscle, and I put the dry line into the muscle, non-subcutaneous, into the muscle, no problem, because the muscle prevents the infection very. Only directly, no contra-incision, no subcutaneous. I dissect the obliquus major. Between the obliquus minor and obliquus major, I put a pen, very large pen. No use the tunnelation of the, and then directly the dry line is under the muscle, and I have not any infection of the dry line.
Okay, so I think we have to call it for the day. Thanks so much for a fantastic day. Thanks so much for the discussion.
But just a comment about this strategy. Sometimes when the patient is an heart failure, the muscle is very small, and it's not so easy. And we had the experience of a tunnelization in the peritoneal cavity. So.
Okay, well, thank you very much, everyone. It's been a pleasure. Muchas gracias a todos. Espero que os haya gustado el curso y damos por finalizado el curso. Los que os hayáis apuntado a la simulación de ECMO mañana, pues ya la tenéis. Y muchas gracias a todos por haber acudido y a los presentadores por haber venido. Thank you very much.